Put it up. Yeah.
John. Hi, John. John, can you hear us?
Yeah, I can hear you.
Yeah, there is a lot of background noise. Can you mute all the participants?
Yeah. Hold on. Let me get rid of that. Yeah, there we go.
I need a stand back. Anybody from anatomy department? Anybody from help from anatomy department? Ma'am, yeah. एक सेकंड आप आ जाएंगे इधर. एक ब्लॉक चाहिए हमको, एक ब्लॉक. Lift the head. You may need to try and shift it a little bit because marking. No, it's you need to go like that, a little bit posteriorly. I'll also put a glove and then I'll show you. Chaitanya is here. Okay, so different incisions. Anybody wants to ask anything about the different incisions that we put? Different positions, different incision. These are all game changers. We'll show you that a window to the basilar is 3 millimeter by 4 millimeter. So let me tell you, I'm going to give you a triangle, 3 millimeter by 4 millimeter. And about 5 centimeter below, you got a basilar tip. Your angle where you are here, 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 or here decides whether you can reach it or not. If your angle is wrong, your surgery is wrong. You'll be struggling for the rest of your surgery trying to get that angle right. Are you understanding? Every one of you, it's very clear. So positioning is one of the most important steps of your surgery. You position wrong, you'll be struggling for the rest of your surgery. Not only the positioning for the patient, second thing you have to understand is the positioning you have. You're not sitting down like on a Sunday morning reading your newspaper, then you are in trouble. If you're trying to, operate like that or operate like that, if you're not comfortable, your eyes are not comfortable, you're not having good vision, you're in trouble. You are in serious trouble. Sit down, relaxed. What is the most relaxed thing that you do? Other than taking a crap or something? Sunday morning, do you sit down with a newspaper, with the pillows and all that? Try to be in that position. Completely relaxed. Then your surgeries will start improving, all right? Okay, let's go. You don't listen to me. You start your stuff, man. Come. Yeah. Yeah. So let's put the block here, okay? Yeah, below the shoulder. Yeah, that's right. Yeah. Yeah, okay. No, that should be fine. He will settle slowly. All right. Knife now. Yeah. Can I mark for you? So you need to figure out the zygoma. Since we are going to do the anterior petrosectomy also from here, that's why I want this marking all the way till here. This is very thick and very non-pliable skin, so you may have to struggle a bit. Go ahead. Ready? Skin first, and then after that. Now, while he's doing that, let's discuss some more core concepts about the brain. about skull base as such. So now let's get into endoscopy. So we're looking at sagittal plane now. What is that? Trans. Of course, you have to go transphenoidal. I mean transnasal, and transnasal. What is that? Not orbit, medial to the orbit. Well, you have to understand anterior canal fossa has transplanar and transtubercular, right? So sagittal plane comes from transplanar, transtubercular, transcellular, transclival, and transforaminal, right? That's the sagittal plane. When anybody tells you all this, don't get confused. It's a sagittal plane, starting from transplanar, transtubercular, transcellular, right? And then transclival and transforaminal, all the way. That is moving the endoscope only in this direction, midline. Now you transgress from the midline. What do you get? First thing first, this is a sinus that comes in your way, because these two sinuses will not allow your endoscope access to the sites. And there is a plate here. Okay, there is a plate here. It is called the pterygoid plate. So when you are going in a plane lateral, after cavernous sinus, you need to go transmaxillary, transpterygoid. Are you understanding me? And if you are going transmaxillary, transpterygoid, then you have access to the petrous bone, because the petrous is off midline. Are you understanding me clearly or not? And then below the petrous, you have access to the, the petroclival junction ends at the jugular foramen. So you have access to the jugular foramen also. So in the midline, you have transplanar, transtubercular, transcellular, transclival, and transforaminal. And as you go laterally, you may have to do transmaxillary, transpterygoid to get access to the petrous apex, to the jugular foramen, and everything lateral. Do you really want to do that? Because we have we have much better apps, as you say, than approaches. Okay, not our phone apps. We have much better approaches to the petrous apex, because for our petrous apex, a small incision here, subtemporally going, is much more easier for us. Jugular foramen is, we will see today, we will see tomorrow maybe. We can do a mastoidectomy and easily reach. We will have a very wide view of the jugular foramen. So I'm going to debunk all your questions. Okay, debunk the myths about skull base. All right, but your midline transplanar, transtubercular, that also maybe you can get it done with a supraorbital approach. But when you have the optic nerves on your way, to get below the optic nerves is a bit of a challenge from this approach. Okay, it's a bit of a challenge, because the optic nerves are formidable, large when you go into huge size. Getting below the optic nerves, between the carotid and the optic nerve, is a bit of a challenge. When you're doing an endoscopic approach, you're directly below the optic nerve. Your SHAs are here, and you are directly below the optic nerve. So your craniopharyngiomas, your pituitaries become much more easy. In fact, I believe the future of basilar tipping is transclival. Okay. I love doing the basilar with a anterolateral approach, but I believe the future is transclival. Charlie Drake actually started it, but because he didn't have Haddad flap at that time. And that is why probably they had too many infections and they stopped it. You should know history, huh? Very important that you should know history. So I believe the future of basilar tip, and in fact, one of my Japanese friends is doing it, okay? Is doing transclival clipping of basilars, okay? He got into some problems with the Japanese board. So he's in the freezer right now, okay? But these things keep on happening whenever you start something new. I only know so much about it because I happened to start something new, and there was a lot of issues, okay, for it. We will discuss about that also. So you should know, are you clear about the endoscopic anatomy right now? So you have transplanar, transtubercular, transcellular, transclival, and transforaminal. You have transmaxillary, transpterygoid. Okay, don't destroy much more. Okay, there is no need to widen that corridor much more. You can go all the way up to the jugular foramen. Okay, so there is, after that, I want you to understand one more thing. I'm going to tell you very simple, in a very simple way, so that probably the Esculap and the Karl Storz guys who are standing here should also be able to tell me what I just told you. Okay, you guys put attention to it, so that you guys are going to repeat. I mean, I'm going to ask you questions to you, okay? What is the central structure of skull base? What are you worried about in the skull base? Don't tell me cranial nerves, but because most guys are not worried about cranial nerves. If you have a cranial nerve deficit, the patient will not open his eyes or something. That's what's going to happen. Nobody is going to be worried, okay? But what is the structure that you're really worried about? Huh? Hypothalamus? No. I'm talking about extradural, man. I'm an extradural person. I don't want to get into it. That's not going to create a problem intraop. Intraop, what's going to give you a heart attack? Bleeding. What bleeding? Cavernous sinus bleeding. Believe me, if you are worried about cavernous sinus bleeding, learn how to take a Surgicel, put it there, just stay there for 5 minutes and it'll stop. How much ever cavernous sinus bleeding it is. Okay? Don't panic. Don't put your bipolar. Okay? Just take a very blunt dissector, put 2 suctions, put a Surgicel there, put a patty there, and start talking about maybe VVS Lakshman's innings in that Kolkata innings. You want to start talking about it, okay? By the time you're finished, it'll be done. The bleeding will be done. So cavernous sinus, no. What will not stop? ICA. You know what is the center of skull base? Each side skull base, what is the center structure? There is a serpent. There is a serpent right through the center of right-sided skull base and left-sided skull base. And this is the structure that you guys will have to master. If you don't have the ability to work in close proximity with this serpent, you cannot be skull base surgeons. You have to expose this serpent, carotid, every single turn. Every single turn. Okay. So then you have to understand what are the turns. Okay. There's so many classifications, but I'm going to give you our classification, which we proposed. I mean, it's there in textbooks right now. It's a very, very simplified way of Fisher's, modified Fisher's classification. I'm going to ask you, anybody has a paper and a pen? Do we have a whiteboard here? Do we have a whiteboard? I believe not. So we will start off. तो ये डालने के लिए कुछ
Deepak Mama.
There has to be a waste. I mean, maybe some plastic or something. No. I'll put it, man. No. Hi, Vaibhavi. Good to see you, man. Yeah. Even that is just a box like that should be fine. Yeah, glycerin निकाल दो. Glycerin निकाल कर रख लो. ये दे दो. They're bringing? हाँ, अच्छा ठीक है. अभी के लिए तो इतना ठीक है. Morning. So, give me a pen and a paper. Let's go the old traditional way. So, the serpent, if you look from the front, the snake in the skull base has an anterior side and a posterior side. That is the biggest disadvantage of endoscopy. You are seeing something end on. Okay. What do you want? Let us say, if a lady is standing like that, do you want a view from here? Do you want a side-on view? So you want to see the carotid like that, or do you want to see the carotid like that? Isn't it? So that, I say, is one big disadvantage that endoscopy has. So that is the first concept you have to understand. All right. But having said that, endoscopy has a few big advantages, because this is not like that. This is, that person is standing like that. You understand me? Even from front on, we're not having a straight artery. Sometimes it can be, but sometimes endoscopy has big advantage of getting into curves which even from laterally you cannot. But I'm going to classify this carotid so simply for you. Let's say this is the nose, this is the head. I'm going to put 3 lines. Okay? 3 lines. Clear? And I'm going to name it odd numbers. You don't want to keep 1. So you keep C3, C5, and C7. Can you identify these segments? What is C3? Paraclinoidal. Paraclinoidal is on the top here. So that's a clinoid. That's a clinoid here. So what is this called? Paracellar. So if this is paracellar, what is this? What is the segment which is parallel to the clivus called? Paraclival. Yes. So you have paraclival here. That's C5. And then you have C7. Parapharyngeal. That's right. So the ENT guys call it parapharyngeal. We really don't, neurosurgeons don't go there, so we don't call it anything. We should start going there, okay? Right, so that it's paracellar, paraclival, and parapharyngeal. This is intradural. And then you have another segment. This is the horizontal intracavernous. So that's the cavernous sinus. And this is the petrous. So you have C4 and C6, even numbers. You started off with C3, C5, C7, paracellar, paraclival, parapharyngeal. And then you have horizontal intracavernous and you have petrous. Your carotid is finished. Okay, your carotid is done. So you have C3, which is vertical and paracellar. You have C4, which is horizontal intracavernous. And you have C5, which is paraclival. You have C6, which is petrous. And you have C7. Now I'm going to draw a few structures around it to make the skull base. Okay. Now, this is clinoidal. So you have, let me draw 3, 4, and V1 going into the superior orbital fissure. Yes. You have V2 going into the foramen rotundum. So when you do endoscopy, this is foramen lacerum. Is that foramen lacerum? No. Foramen lacerum is where? This is it. This is where the VDN nerve comes. So V2, you can see V2 here. Medial to that, if you look, you will see VDN nerve and then foramen lacerum on an endoscopic picture. But side on, you're seeing V2 here, you're seeing V3 here, Gazerian ganglion is going to be here. You have the GSPN coming parallel to C6. You have cochlea anterior to the C7 turn. Okay, cochlea here, internal auditory canal here, and semicircular canals there. Are you understanding skull base topography in the broadest of detail? We are not going to details right now. I'm just giving you a map. See, when I give you a map of Maharashtra, you must know, I'm going to tell you where the major cities are. Mumbai is here. Okay. Karad is here. I must tell you that I cannot tell you Karad is north to Mumbai, right? So I'm telling you very, very, very sketchy details, and then we're going to build on it. Okay, we'll build on it. So you understood the anatomy of the carotid, C3, C5, C7. You understood horizontal intrapetrous and horizontal cavernous. You understood the third nerve, fourth nerve, V1, V2, V3, Gazerian ganglion. Then you understand where is cochlea. You understood where is internal auditory meatus. Posterior to that is semicircular canals. Yes? Everybody? Yeah. So we, wow. Who's this guy who organized it? This guy is good, eh? Fantastic. So, yeah. Do we have a laser pointer or something? Exactly what I told you. Have you seen it? This is our classification. Okay. It's a very, very simple classification. So, what is that segment? What is that segment? Huh? What is that segment called? C3. From now on in the dissections, you carry on, guys. You will learn all this. Don't worry, okay? You carry on. You keep on doing your dissections, okay? So, what is that segment? Excellent. What is that? What is that structure? What is that structure? Posterior clinoid process. For those of you who are very, very good, I'm going to ask you one question. Okay? There is an artery which takes off from C4, C5 junction, this artery. What is that artery? Which trunk? Meningohypophyseal trunk. Okay? The meningohypophyseal trunk takes off from the C4, C5 junction. Can you see the same thing here? Here, can you see the same thing here? C5, paraclival. C4, okay? C4, horizontal intracavernous. It's a bit deformed. That is C3. That is C2, and that is where all your distal dural ring and proximal dural ring will come. This much is cavernous sinus. Can you see that blue there? From here to here is cavernous sinus. Okay, we're going to expose that. Huh? So you got a clear understanding of carotids. You got a sketchy understanding of what are the structures coming lateral. Okay, you say know your enemy. Okay, right. So I'm going to ask you questions. What is C5? Huh? Paraclival segment. Excellent. C7. Parapharyngeal segment is anterior to what structure? No, that is eustachian tube is lateral to C6. The eustachian tube comes lateral to C6. Okay, lateral to C6. And GSPN runs parallel to C6. These are two structures you have to associate in your brain with C6. But what is the structure here behind the C7? Cochlea. Okay. So when you're drilling, you're coming from a mastoidectomy approach. If you see cochlea, you're in trouble. If you see the promontory of cochlea in the facial recess, anterior to that is your C7. Thank you. Oh. It's a very gentle. Huh? Yeah. ना कोई बात नहीं, कोई बात नहीं. हम इधर करेंगे, कोई मुश्किल. Okay. So that is anterior clinoid process. That is intradural. Good. Thank you. That is intradural C2. Okay. So all your paraclinoidal aneurysms are here. So if you don't cut the distal dural ring, proximal dural ring, and take off the ACP, can you clip those? So you're going to show you some videos also of paraclinoidal. Once you do this, once you finish this, when you're going to show you some videos and you will understand much, much more. Are you getting more ideas about the skull base now? Both endoscopic and lateral. Endoscopic, I told you how. Now, can you show me a picture of the endoscopic? Can you guys, how did you project this? Can you project endoscopic picture? Then you will understand much more. So from the endoscope, you're seeing C3 there, C5 there, right? So that's what you're going to see, C3, C5, and then you drill infralaceral. You drill off the petrous infralaceral, then you will see the C7. All right. So now, once you understand the concept, we're going to show you how to expose these segments. Remember, neurosurgery or anything is not a direct affair. Imagine you want to marry a girl. These days, the way to do it is directly you go shake hands and say, "You want to come to my home?" Doesn't work in neurosurgery. Neurosurgery, you have to start with good dress, all your old generation love affair. Do you know? Most of you guys won't know. You'll have to dress up and you'll have to stand in front of her for maybe many days. And then when things are okay, you need to go and probably give a rose or something on a Valentine's Day. You might get a slap, but you will have to do that. Okay? Then you will have to talk about, that's the beauty of it, you know. It is not the final thing, that every culmination is not the reward. The beauty of it is beautiful skin dissection, beautiful bone dissection, beautiful, beautiful arachnoid dissection and reaching. All right. So remember, skull base surgery is like an old generation love affair. You got to stand with roses. You got to work a lot. So there is no direct route to anything that you want. Your route starts from the positioning onwards. Okay, starting from positioning. After that, your strategy. Okay, so that is how. So so excellent. What is that? Which layer? C3, excellent. That is C4, excellent. That is a horizontal intracavernous. And what is that? Are you sure? No, C7 you will never see. So don't worry about C7. C7, unless somebody is done infralaceral drilling, you are never going to see. Now, what is that structure? Pituitary is in which? So what is that? Clear? What is that structure? It is not actually, you're not seeing the clivus there, but if you remove a little bit, that you'll start seeing the clivus there. So that is actually paraclus. You guys are getting better and better, isn't it? We saw it from lateral. And if you're seeing it from lateral, you're going to see what is that entire structure there. What is that strabiculae? What you're seeing? That's a cavernous sinus, right? So C3, C4, C5, this is the cavernous sinus. All your nerves, one nerve almost touching the carotid inside, medial to V1. That is the no. 6 nerve. Medial to V1 is 6 nerve. Third nerve is above here. Third nerve will come above here. Okay. This is a different angle. This is from you are looking from below like that. You must remember, perspective is very, very important in endoscopy and lateral skull base. Perspective. You know what is perspective? If I look at this guy from the front and take a photo, and if I come to the side, you keep looking there, and I take a photograph. Both are different. Endoscopy and lateral skull base, if you don't understand perspective, you will be fooled. Okay. So to understand perspective, it's very easy. Okay. You figure out where you're looking from. Then it's easy. Okay. You didn't finish the OZ, right? You finish? Oh, right. Right. Excellent. Very good. Very good. Okay. So focus on this now.
Yeah,
Take the temp. Now take stitches there. Take stitches. Neil Kamel and Reddy. Good man. Very good show. Come. Take stitches now. Take the muzzle away from here like that. Okay. Right. All the way. All the way. Come. Cut down there. Yeah. Cut down there. Excellent exposure. This is the kind of exposure that you guys need. See, you guys are already understanding things much even before I say. I'm so happy with the new generation. Okay. You guys were being misled with writing and all that. Don't follow all these Western guys who tell you about writing. Follow guys who are pure surgeons. All right. We are in neurosurgery. We are not neuro publishers or neuro manuscript writers or something. Okay. We are neurosurgeons. All right. Okay. No. Don't, never, ever. Okay. Just pull it down. All right. Now, do you want to take a break and ask somebody else to help you? Or do you want to continue on? This fellow wants to hog it. Right. Okay. Come. Expose the client, I mean the zygoma clearly, very clearly, and with a yeah, that's right. Expose the zygoma very clearly. Take stitches and expose. You got the Manman right now? You got the Manman drill? Okay, excellent. You got the cutter also? Cranium also. Excellent. All right. We're doing some things with them, okay? We're doing something. The drill, this is ready. I mean, I know it's right now we cannot compare with a Esculap or a Medtronic or something or a Karl Storz, but you guys use it and you will understand how good it is from before. And the good thing you must understand is we are capable by ourselves, okay? I'm not following the Make in India rule and all that, but we are capable. If you think, you know, what is third world? Third world is in the brain. Huh? Third world is in the brain. There's no third world. Third world is always in the brain, in your head. People tell you you're not capable. The other guy can do it, you cannot. Because he's got all the facilities and you don't have. Always debunk that. If anybody tells you, ask him to go take a break. Tell him you can do it 100 times better than anybody in the West. Okay. We have done it before. 5,000 years onwards, we started doing it before. Now also you can do it. All right. There's no neurosurgery which is impossible for you and possible for them. You will see that. All right. Okay. Now ready. Clear it off. Take stitches here. Now come, all of you. What has he exposed? Maybe you should come here, all of you, old style. Everybody? What has he exposed? He's exposed the lateral orbit, zygoma, pterion, frontal, temporal. The temporal base is parallel to the zygoma. Okay, so you've exposed the temporal base and the cavernous sinus is going to be there. The inferior orbital fissure is going to be there. And that's the orbit, right? Your route to the cavernous sinus is this way. Yes, it's a frontal, temporal, and that's a root of your cavernous sinus. So that is what you are going to expose. All right, take it towards there. Good, 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 good. So this is the prerequisite to an anterolateral skull base approach. The first thing, all of you can do this. This fellow, he had done it. I'm sure all of you can do it. Okay. Before everything else, before even we start a skull base, now I would want in 10 minutes, you guys put your gloves on. Okay. You have a feel of how this is done. Okay. Or are you confident about this part? Everybody? You don't need to do this, right? Okay. So the next step that we are going to do is actually giving the flower. All right. We're going to do the one piece OZ. Chaitanya, you're there, right? Okay. Nilkamal, Reddy, and you will do the OZ. You got any problems, then I'll scrub in, okay? Yeah, sharp actually. There is a sharp dissector. You take the sharp dissector and periosteum all the way from superior lateral to all the way down. Very important because the cutting is going to be there. Okay. So you need to dissect the periosteum. Okay. Inferior orbit. We just had a transbasal approach, maybe just 2 weeks back. So we were showing how that one piece mini OZ is done. Okay. Right. So you dissect that periosteum all the way across. Go ahead. No, not like that. Take a back. Do you have a dissector? Use a knife. Use that scissor, curved scissor. Take the the periorbita away. They take periorbita away. That's right. That's right. That's right. Excellent. Laterally also. Laterally. That is done. Laterally also take the periorbita away. Yes. Don't go minimalistic. You'll be in trouble. Okay. Minimalistic is what you do inside, not outside. Huh? So don't worry about the black coloration of the eye and all that. That will go away. But if the bugger doesn't have an eye, then there is a problem. Okay. Okay. Neil, he is always about organization and all that. Right. So I'm going to, okay, done. Shubhareddy, I'm going to tell you the number of holes here. First hole is keyhole. Okay. Clear? For OZ, first hole is keyhole. Second hole is just above the posterior limit of the zygoma. Clear? Now those two holes. And then there is drilling. The drilling is between this hole to that hole. You are going to take a cutting drill and drill all the way. Never try to cut. Say 2 holes, 1 drilling, and then few cuts. I'll tell you. So 2 holes, you got it? Then is the drilling from keyhole to that. Can be done? Next cut all the way from this posterior hole all the way till here, lateral to the lateral to the supraocular, all the way down. If you don't reach here, you can go do a reverse, which means you put your cutter like that and then come from there. That is the first cut. Second cut is here. You put the B, you put the B2 here, go down. Clear? The second cut is here. The third cut comes like that towards the keyhole, towards the keyhole. Is that clear? So 2 holes, 1 drilling, first cut, second cut, and third cut. No, zygoma, you really don't need to. What you can do is, if you want zygoma, you can make 2 cuts on this zygoma and then take it down along with the muscle. That heals very easily. The classical your OZ is not needed to be done. It's not needed. Okay. So you can make now with the cutter, you can make 2 cuts and take this muscle, instead of cutting it here, you cut it here, right? Instead of that, you can take, along with that, you can take, can you cut right now? Cut right now. Make a cut right now. So, cutter de do.
Yes. Cutter.
Are you understanding, everybody? Anything is unclear for anybody? So we are targeting the entire population. It's not like vaccination where you can have herd immunity. No, we don't have herd immunity in neurosurgery. Okay. Anybody is there who has not understood?
This line what you told.
Yeah.
Will it connect to the inferior orbital fissure?
No need. That will be extensive. That for connecting the inferior, you have to cut here.
Yeah.
That's an extensive OZ. Okay. That I will tell you, there are very, very few indications for that. All right. You need to do only a mini OZ like here. So first you cut here and here. Make a cut there and there. Come. Yeah, the foot switch, please. Gently. These machines are good. They're not like the old manmans.
Irrigation.
Pani? Yes. Make a V like, yeah, 1 second, please. Yeah, make a V like that. Okay, make a V. All right. Yeah. Hold your other hand, steady things. Okay, always use 2 hands when you're drilling. Good. Yeah, yes, completed. Completed. Come. Okay, now another one there, posteriorly, most posteriorly. Yes, cut it. Don't go to the TM joint, but excellent. So you take off that bone along with the muscle. Use a large dissector. There is a large, that thing, give it to him. No, yeah, that thing, give it to him. Yeah, give it to him gently. Take off. You see, now a lot of people talk about infratemporal fossa from endoscopy. What are you exposing right now? There is Sunil Verma. Come. You talk about when Narayan tells me about transmaxillary infratemporal fossa. But do you need that? See, you have already, that's infratemporal fossa we are exposing. Okay, that is what we are exposing. It's infratemporal fossa. I'll be seeing the lateral pterygoid plate there. If I go like that, I'll see the lateral pterygoid plate. Are you understanding me? So do you need endoscopy to get into infratemporal fossa? If anybody tells you infratemporal fossa, you take off, you unroof the infratemporal fossa by giving a zygoma cut, and you are in the infratemporal fossa here, isn't it? See how easy it is. Huh? So anybody, don't use endoscopy to get into infratemporal fossa. Okay. So, and infratemporal fossa, above the infratemporal fossa, what is there? The temporal plate, and all your fifth nerve schwannomas, which will be there in the temporal fossa, going in the infratemporal fossa, tumors there. You don't need to even open the skull. You just need to make this, and you can do that. And if you need, you can make a small subtemporal craniotomy and you can take it out. Are you guys understanding? So lateral skull base, you are able to do, you are going to be able to do a lot of things now. Yes or no? Yes. Right. You see the basal exposure that you got there? Huh? Right. We will show. Now, okay, now holds now. We will show you right now. We will show you right now. So these guys, yeah, come. First cut. Yeah, you have to press that. If you want to reverse it, you can do it like that and then reverse it so that you can come out. Okay. First one in the keyhole. Okay, give him space, guys. Give him space. Don't space him out. So the keyhole should be frontal temporal orbit. Okay, you should be able to see the frontal lobe, temporal lobe, and the orbit. Okay, so there'll be a large hole. Yeah, don't put it to this thing off. Take this thing off. Always be uncluttered. No, don't increase the speed now. Keep it there. Then increase the speed. Once you are steady, increase the speed. Increase the speed. Go. No, that you can do it later also with a kerosene. Don't worry about. Make a hole there, and after that, you'll be fine. Okay, don't worry. Irrigation. Go. Nothing to worry. The camera, maybe they are not able to. We'll have to move out, guys. So we'll have to move out and
everybody, please take your seats. You can display it on the screen.
every one of you will get to see it each time. Okay, each time you will come and see it. Any doubts for anybody? Any discussion points? Anything?
Ready?
The cuts, you mean the procedure, right? So I don't understand where it is in each. Where is the zygoma here? That side, right? Not able to. Which is the front? Which is the back? Ah, right. I understand the perspective now. Okay. So why is it not? Oh, it is okay. Here we can see. Okay. So that is the orbit. Yes. That's the zygoma. Yes, guys. So the first hole is in the keyhole. Okay. Second hole is just above the posterior limit of the zygoma. Okay. Then you have to drill between this and this. Completely drill and see the dura. Okay. That is your first drill. 2 holes and a drill. Okay. 1 hole and a drill doesn't work here. So 2 holes and a drill. Okay. Beg your pardon? Yeah, you can drill all the way like that. You can drill all the way like that. So you'll get into the temporal base straight. And after that, your first cut goes all the way from here to here. Clear? Second cut comes on the zygoma like that, down, and then comes in the keyhole. Okay. Clear? And then you can, only the orbital roof remains. Sometimes if it is thick through the keyhole, you can put in a chisel and just give it a little bit of a bang and then it will break off. Okay. Most often you don't need to do. We'll see here. Okay, how it is. So that'll be your one-piece OZ. You will see now. All of you should be able to do your one-piece OZ after today. If you got any doubts, we're going to stop, because there's no point talking about basilar bifurcation if you don't know OZ, right? So we will figure out what is an OZ, all of us, every single person. Okay. And then we'll go to the next step. perpendicular, perpendicular. Just press a bit, nothing, not to worry. Irrigation. Where are you from, Shubha Reddy?
Sir, I came from Bangalore, Narayan Hotel.
Right. Good. Little bit more. Let it stop. Let it stop. It will stop. It will not. Once you reach the dura, it will just stop. So you don't have to worry. Excellent. You're reaching. Any discussion points here till now in whatever we said about the carotid, about the endoscopic view, about anything that we still till now discussed? Any points that you would want to clarify? Huh? Anything clear? Okay. How does GSPN become the VDN now? How does GSPN become the VDN now? That guy is a technician, huh? He's an engineer. You should know more about that. You should push him, okay? So, one of the things you must understand, if somebody is good in town, he's not your enemy. Okay? He is your biggest ally because he should push you to be better. Okay? So you team up with him, and as he improves, if everybody is mediocre, everybody is happy. That is our culture. Okay? Our culture is that in the room, if everybody is mediocre, we are all happy. Because there's nobody better than me. Everybody is bad. That should not be the attitude. If somebody is above average, everybody look at them like, they make a mistake, personal life, any life. They make a mistake, you burn them at a stake. Okay? This is a bad habit, okay? It's a very, very bad habit. You should take inspiration from those guys. Okay, that guy knows this much, no problem. He is pushing me. When you go, if you have seen in France, what is the biggest cycle race in France? Do you know? Tour de France? Do you know it's a team? And there are guys to keep pace. So for the champion, there will be one guy who's always trying to overtake him. So that guy will push himself harder. Even in marathon races, they've started it right now. Okay. There'll be one guy who will be putting pace for the eventual champion. Right. So you guys, your attitude will decide who will be the eventual champion, but it doesn't matter. What matters is that you have a team of very good people all over India. If you have mediocres all over India, and if you are happy about being mediocre, our neurosurgery will always be worshipping whatever is done in the West. We will always be going to those theaters, standing like that and watching them. It is not going to work for you guys. That's because all of you should get out of the belief that mediocrity is in your head. So when that guy talks about greater superficial petrosal nerve joining with deeper petrosal nerve, okay, and then becoming the VDN nerve, which is a landmark for C5 paraclavial carotid, C5 carotid turning away from you to become the C6 petrous carotid. The petrous carotid is coming at you like that and turning to become the C5 carotid. Clear or not? And that point where it turns and comes up, That point, the turning point is called foramen lacerum. Lateral to the foramen lacerum is your median nerve. The median nerve, fortunately, doesn't turn up. The median nerve comes straight at you. Right? So the median nerve, if you find out, lateral to the median nerve is which nerve? V2. So you have median nerve, you have V2, median nerve, and then you have the C6 carotid becoming the paraclival carotid. Okay, C6 becoming C5, foramen lacerum. And one question, 5-star question. What is the ligament lateral to this? C5 becoming C6. There is a ligament which holds it. Now give me one of your hands. Come. Chaitanya Godbole. Here. This is C6. You're not seeing C6. This is foramen lacerum. This is C5, paraclival carotid. You're seeing it. You're not seeing C6 because C6 is going like that for you, endoscopically. Median nerve is here. And there is a ligament here. No. Huh? Petrolingual ligament. Now, since you talked about Dorello, I'll tell you that also. This is a petrolingual ligament. And you must understand, this is C6, this is C5, right? This is C4. Yes? So, parallel to C4, medial to V1, there is a nerve going there. That is your sixth nerve. And that sixth nerve comes up through the Dorello canal, which is a ligament from the petroclival or petroclinoidal ligament. Okay. Are you understanding? That is Dorello canal. This is petrolingual ligament. You should know all your ligaments, okay? You should know when you do a petroclival meningioma, this is so important. You made the cuts? Yeah, okay. All right. Right. Irrigation. Irrigation, lots of irrigation. When you don't give irrigation, what happens is burnt bone comes onto the cutter. Okay. And then it will make it completely blunt. It will make a very polished piece. You will not cut. It will be a polished piece. So if it's burnt bone, actually, ideally, you should have boiling hot water onto that, and then you should clean it. And that is when your cutter will become better again. You should know all this, otherwise you will struggle. Okay. If you are allowing without any irrigation, if you are allowing, the cutter will become very, very blunt. Okay. You should know the physics of neurosurgery also. Huh? If you don't know, this guy can teach you the physics of endoscopy. Very good. Learn from him. I always learn from him. Okay. And it is very, very important for us, the physics of neurosurgery. Okay. That is how we describe the cleaning and cooling pathways, you see. Huh? You will find out when you discuss the panel discussion, we'll see. Okay, guys, good. But get the orbit out of the way. You made the cut?
Yeah, I made the cut.
Fantastic. So now drill from that. No, not with this. Not with this. You should take a 8 millimeter or a 6 millimeter drill bit. Large drill bit. Give it to him. You have one more larger? You don't have. Okay. Medtronic has a larger drill bit?
That is a smaller, very small. We want larger.
Yeah. Hello.
Subba Reddy, I think we should give chance to someone else now.
Somebody else, please. Yeah. Come on. All of you will get your chances. All of you. Okay. All of you. I mean, I want each one of you the next volunteer should be ready. Okay. Good job, Shubha Reddy. A clap for this guy. Good job. Very good job. Okay. I am really blessed with these guys, Trishant, Nilesh, and Nargiza, Manuel, and Nikunj, because, without a team, you cannot do anything. Huh? You remember that? Without a team, you cannot do anything. If you ever practice on being one man show and all that, doesn't work in neurosurgery. Neurosurgery, we are wolves. Okay, we hunt in packs. Okay, we hunt in packs. We cannot, because one day the stress will be too much for you, and then you will decide that is my level. I am not going up from that. And money is not the criteria. Believe me, you can make a lot of money working alone, but you will never be top notch. If you want to be top notch, have a team. 2 guys make a team. 3 guys is a better team. 4 guys is even better. 5, 6, 7, 8, 9. Then there will be a lot of conflicts. You need a leader who is, he understands things. Okay, that is important. All right. Otherwise, there will be conflicts also. So always think about making teams. Go institute way, not the corporate way. Huh? These are all not important to cadaver lab, but this is important to life. This is what I learned over the years. What I learned. So I'm really proud of these guys, Nilesh, Trishant, Nikunj, Nargiza, Manuel, all these guys I'm really proud of. So this cadaver lab would not have been possible if it was not for these guys. Okay. And everybody's got a separate quality. That is the beauty of it. Right. So how are you going to make the cut? No, let him start off. Let these guys get it ready. Okay, right. Yeah, with the irrigation. Get it with the irrigation. Come on, guys. Come. You're assembled? Right. Good. Always use the drill with irrigation. Where is Manman? You guys need to get the water knife onto the drill. Okay. Very, very important. You guys have a fantastic tip for irrigation. So get that for the, yeah, but get that. Whether you're using endoscopic drilling, whether you're using lateral based drilling, any drilling underwater, suction and water should be there. You're not drilling like that, then you are in serious trouble. All right. Why is that? Why is that? Number 1, thermal injury. Number 1. Number 2, bone dust can cause problems, very low in the priority. Number 3, bluntness of the blade. Yes. Then you want to see through the bone. You want to see through the bone. You understand? People don't think about seeing through the bone. That is not X-ray vision. But if I am on the intrapetrous carotid, or if I am on an aneurysm, extradural aneurysm, I can see the color changing of the bone. The bone, as you come down and down and down, when you exhale the bone, you can see structures through the bone. Under the microscope, under good light, you can see. And for that, most important thing is water. If you have a dry surface, you cannot see. Earlier times, very early, when we were children, there used to be bowls where you can put water and you can see Taj Mahal. Have you seen that? Have you seen those toys? Where you take a small marble bowl, you pour water, and then in the water you can see Taj Mahal, because the water brings out something. So remember that. You put always be underwater. When you're doing an aneurysm surgery, when you're doing a drilling, always wash off everything, and you will see. I'll show you a video of how the bone color changes when you're doing extradural clinoidectomy, and when you're coming to the last layer of the clinoid, the color changes. Completely changes. Okay? Very important. These are all finer surgery when you go into high magnification, very good optical, very good high intensity light, and then water. This will do magic. No, I'll show you where to drill out. So from here, to here, you have to make a drill.
Okay.
All right, you have to make a drill like that. Okay. Ah.
You have to put one hole into the orbital.
No need. Just see, like we are cutting it from here, like we're cutting it from here. So you cut all the way from here to here. You would have needed a larger drill bit. You don't have a larger drill bit? Why, Bhavi? You don't have a larger drill bit? Yeah. The largest drill bit that you have. That is what you need for this one. Ah, okay. Use it with irrigation. We need at least a 6 millimeter drill bit. Light there, light there. Yeah, good. Another small advice, not related to cadaver lab. You know what makes you a good neurosurgeon? There have been, people have measured some things. And, there's one of my friends called Garnett. He's measured some things. And you know what makes a good neurosurgeon? Anybody? 5-star question again. Huh? Of course, patience makes a good neurosurgeon. Yes, patience you should have. I'm talking about pure surgical perspective. Pure surgical perspective. What makes a good neurosurgeon?
PIP.
Yes, of course, use of both hands. Actually, use of 4 hands. Your assistant should be as good as you. Okay. If not, use of 4 hands, definitely. But what is the quality of a very good neurosurgeon? No force, less force. Anybody who uses force, you should know, is a beginner. Some people remain beginners for their entire life. I see people using drill like that. I see people putting so much force, even for arachnoid dissection, trying to do this. You will rupture aneurysms. You will tear arteries. Sometimes, if you are lucky, you may take out a tumor with sheer force. But you want to be a neurosurgeon, a pure aesthetic neurosurgeon, remember, no force. You should figure out a way without using this advice. I'm telling you, will improve your neurosurgery 10 times. Figure out a way to do something without a force, whether it is arachnoid. So that is why sharp dissection is important. Sharp dissection is important because in sharp dissection, you don't use force. You don't need to use force, right? So always when you're drilling, when you're dissecting, when you're doing anything, find a way to use less force. All right, clear? That is why I don't like spine surgery. You have to use force. But maybe the best spine surgeons may not be using force. Okay, you need the correct instruments probably. Don't make a ridge like that. So what you need to do is, show me that. You need to cut like that. Okay. Or you cut the dura there. You cut the dura there. But don't cut the dura because that will screw our entire approach. Okay. Don't cut the dura. Keep on irrigating heavily. Take off all that bone dust. And then, see, now you're seeing much more clearer. See, that is what I told you. That is exactly what I told you, because with the bone dust, you will not see anything. Now you're seeing dura, the 2 cuts in the dura there. Yeah. Now you're seeing the bone separate. Always irrigate. Okay. Otherwise, you're not seeing anything, right? Now you're seeing it clearly. Yeah. Irrigation is very, very important. Now you can see the color of the dura. Where is even in a cadaver, you can see. Okay, on a in live surgery, if you irrigate and take off all the bone dust, you are so clearly you will see. Okay. Don't make a ridge like that, Rishabh. That ridge you should take off like that. Okay. Huh?
microscope?
Not in the craniotomy stage. Maybe that'll be like the Japanese, huh? They start using the microscope from skin, Well, good habit, huh? But I mean, maybe I've become old school. So I mean, I wouldn't use a microscope for craniotomy. We can do a decent craniotomy without a microscope. What happened? Eye? Oh, just help him, man. You want some irrigation on your eye or something? No, seriously. I mean, this is a irrigate there, irrigate completely there. These guys are doing a very good job. Excellent. Break that completely so that you see the dura everywhere. No need to hurry also. No need to hurry. Just keep on. Yes. Keep on breaking it completely, slowly. Any questions now? Any questions? Anybody? Yes, Gaurav. Yeah.
He's drilling now.
See, comes with experience, okay? Comes with experience and comes with your style. I mean, you should not classify anything for anybody. These kind of things you should not classify. Some people say matchstick. Some people are comfortable with cutting. Some people are not comfortable with cutting. They use diamond from the beginning. Whatever you're comfortable with. Okay. If you're comfortable, I like when I'm using when I'm going mastoid, I like very small drills so that I can take out sculpt each part. But a lot of people say, why are you wasting time? Okay, they put the largest drill bit. For example, Luis Borba, he'll take the largest drill bit and finish it off in 10 to 30 minutes, he'll finish it off. For me, I like at least 2.5 to 3 hours sitting each semicircular canal, everything. I'd like to sculpt it. That is what I like. People have their different likes. So drill bit size and all that, you don't need to differentiate too much rules into it. Okay, it's very simple. But generally, I would like a large cutting burr in this part. I would like a large cutting burr. And to take off that ridge, I'd like a matchstick because matchstick is side cutting.
Yes.
Okay, it's not end cutting, so it will not go and screw the dura. Yeah. Yeah. What is the advantage of one cut? Oh, that'll be going too low. You mean the bone flap going all the way up to the zygoma? Yeah. Right. Yeah. The problem with that is sometimes the vena flabbae is in that line, getting attached to the. Yeah. So if you are doing something, then you can produce an extradural damage of the venous sinus, and that can be disastrous, especially in some cases, can be disastrous. Okay. You don't want to do that. You can do it. As you said, it's a good idea. It's aesthetically very pleasing. I understand what you're saying. Lot of bone dust. I mean, sorry, a lot of irrigation. You can see the dura everywhere. Right. Drill a little bit. See, drill a little bit like that. Yeah. That is a sphenoid ridge. See that? So drill a little bit there. Clear that bone. No, not there. This entire bone, clear it off. Okay, yeah, right. Are you understanding what I'm saying? Huh? After this, the microscope should come into place and then we'll start the transcavernous dissection. Okay, but before that, I want all of you to have a look here. I want all of you to have a look. Now, are we very clear about all the concepts that we talked about? Skull base, axial unlocking, sagittal unlocking, the carotid and its surrounding structures, everything. No doubts at all? Huh? These are all things that you know. I just arranged it in a specific way. Okay, that's all you need. You should see the lateral margin of the orbit there. Huh? Should see the lateral margin of the orbit. I mean, the periorbita should come into your vision. Like dura, the periorbita should come into your vision there. Gently, very gently. You are understanding? Till now, any problems? You can do this, Ozzy? Everybody? Okay. Once the periorbita comes into your view, you are going to take the cutter and again cut. Okay, let's get introduced to you guys. Where are you from? Huh? Sion, Mumbai. Good, good. So I know this chap. What's his name? Your vascular surgeon? Huh? Yes, yes. He's from Gujarat. I know him very well. Okay, I know him for a few years. You, I know from Meerut. Where are you from?
My name is Ankit. I'm from Sion Hospital.
You're from Sion too. Right, you? BJMJ Ahmedabad, all the way, huh? Right. Right. You? Nair, Mumbai. Right. Right. You got a big Sion team, huh? Right. Right, right. And you?
I'm Aryan Patil, sir, from Sangli.
Sangli. Right, right. Good. Nair, Mumbai. Right. Nair also has sent a big team, huh? Good, good, good. Of course, I know him. Yeah. You were faculty, you were from here. Right, right. Ache, you're a Malayali. I see. You are Malayali then. Anybody who's lived in Kerala, they consider them Malayalis. I mean, like now, I was telling them now I'll become a Maharashtrian slowly. Huh? So, you? Right, right. Good, good, good. Pune. Ahmedabad. So Ahmedabad also. Huh? How did you guys come? You had to do probably 3 RT-PCRs and all that. Okay, right, right, right. You? Oh, no, no, sorry. Yeah. Doctor? Oh, I see. My regards to him. Kokilaben. Right. Pune. Where is that? Hyderabad. Oh, that is another, it's a long, but you have a flight to Kolhapur. Right. You came to Kolhapur. Right. Oh, right, right. So who is managing medical trust now? Ah, he was in Brunei before. I remember taking Harun to Russia maybe 8-9 years back because Harun, I had taken him as ACNS faculty to Russia 8-9 years back. My regards to him. You? Where? Dharwad. Where is that? Yeah, Hubli. Okay. So we got a wide ranging audience. You got the cut? I don't want to put it near the cadaver lab. Okay, you made the cut? Yeah. So you go ahead and make with the B1 a cut all the way down. You guys are understanding this step clearly? Yes or no? Right. Yeah. Okay. No, 1 second. You just protect this eye, make the cut like that, and make the cut all the way to your this hole. Okay, gently. Yeah, so make the cut like that all the way till here and then reverse it. Can you do that? Right. Go ahead. Come, turn now, turn now. Okay, no problem. Don't worry. You don't use force. Gently, gently, very gently. Make the turn now towards the first hole that you made. Clear? Everybody. Is there anybody in this audience who has even the slightest doubt of how to do this? Anybody? Everybody clear? Tomorrow you can go to Hubli and do it? Huh? Okay. Done? Rishabh? Okay, go, 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 go. Don't use force. Come gently. Keep on doing it. Full speed. Full speed. Full speed. Yeah, and then it's easier. Now, if that is a problem, the drill that sphenoid ridge a little bit more. Try start mobilizing the bone flap now. Put a dissector and start mobilizing the bone flap. See how it mobilizes. If it's not mobilizing, you know where it is. Put the larger one. Put the larger. Yeah, that's right. Yeah. Hello. Hello. Workshop. When you are mobilizing this, always find out there will be some places where you're not drilled completely. That's going to happen mostly in the sphenoid ridge. So in the sphenoid ridge, you have to drill and get into that dural surface and get into that orbital surface. Then it will break easily. If it is very thick sphenoid ridge and you have not drilled, it will be very difficult to break. So you don't need to use force to break. You just have to take a drill and keep on drilling and thinning it out. Then it'll easily break. Okay. Don't be impatient. It's very easy. 2 holes, one in the keyhole, one behind the zygoma. You join these two. That is your drilling part, not a cut. It is not a cut. That is drilling, completely drilling. You must see the dura everywhere. First cut from the posterior hole all the way lateral to your supratrochlear nerve. Okay. So from here all the way like that. First cut. Second cut across the zygoma, and then third cut towards the keyhole. That is all. All right, you get it. And if the orbital roof is thick, then a chisel cut. Okay, inside the hole. That burr hole should be big, and inside the hole, you just break the lateral margin of that orbital roof. That is all. Come guys, break it. Yeah, it's broken already. It's gift wrapped for you. Huh? No, go to the medial side. See there. Come here. Yeah, that is where he's breaking it. That is where he'd have to break it from. That's right. Show them the bone flap now. Dissect it out and show the bone flap. Now, all of you guys, you seeing the bone flap? Dissect it beautifully and take the bone flap out. Don't damage the dura there. On all our transcavernous approach will go for a 6. Don't worry, the dura will be usually adherent. It's you have to just make sure that you keep the dura there. That is all. Some dura there. Otherwise, you already exposed the cavernous sinus, then there will be nothing left for me. And intraoperatively, if you do it intraop, then it will be a disaster. Okay. Cavernous sinus is unforgiving sometimes. John, are you there, man, or you've slept off?
No, I'm here.
Hira is there, I guess, too. I'm sure Nilesh went to. He's here. I thought these fellows were working 2 nights and 2 days. These fellows were working hard. All these guys are holding up the fort. So, all good, Rishabh? All good? Good. Slowly take out that bone flap. And then you will see the OZ bone flap now. And I want every one of you to see that. Okay? Go there. Don't see it on a TV. Go feel it. Okay? Put your gloves on. Feel it. Feel how that flap has come off. Then you will start understanding things. Okay? You start understanding how basally, if you can do this bone flap, cystonostomy is so easy. But you don't need this bone flap for cystonostomy. But you can do this. You are right into the base, where the orbit meets the frontal and the temporal lobe. Right. You're right on the, just middle to that is cisterns. Okay. No, don't worry. Don't worry. Don't worry. Just don't worry. Yeah, dissect the dura away from the orbital roof. That is what you need to do. Okay. Inferiorly dissect. Like that. Right. See that? Yeah, that's what you need. Excellent. Very good. Take it out. They've taken the entire orbital roof along with it. You don't need that, okay? You can cut the orbital roof as a separate flap with a B1 or with your guard taken off from the B1. You can cut that roof separate. These guys have taken it as a single part. Okay, you guys get ready. Watch, go see how it is come out. So you'll see how it is come out also. Put on your gloves and everybody have a feel of it. 5 minutes. Adherent, eh? Do you have the exoscope ready? Endoscope's ready? Stores? Are you guys getting a feel of it? Yes or no? You see the bone flap now? Can you see the bone flap?
Yes, sir. What exactly you said? He should not have come.
This should not have come out, but that is why you should have made a cut through that. You see, you should have put a chisel through that and broken it. Yeah, you break it, then it will break from here laterally. You understand? So this entire, almost the entire optic roof came with here. So if that is a keyhole, show me the keyhole. That is a keyhole. So from the keyhole, you put in a chisel like that down, and then you take the chisel and break it there laterally. Then it will break off from laterally itself. This should not have come out, but that is okay. Even if it comes out, only thing is if it goes all the way to the clinoid, then there is a problem.
How will this get disconnected, sir? In that.
Yeah, that is what. So if you go from the keyhole, take a chisel, now put it in the anatomical position, and yeah, put a keyhole and take a chisel and just break it, just bang it in. So if you break till here, it will break from there. You understand? That is all. Yes, you can drill it. You need a very small drill, but that is, if the with the periorbita and the dura on each sides, it will be a bit of a, you can use a small sagittal saw. In fact, we are making something called the tumor scoop, where if you touch the dura, nothing will happen. If you touch the orbit, nothing will happen. It will only cut the bone. Okay. And we are thinking that it will completely replace CUSA and drill, because we can take, Trishant has used this in theater. Where is Trishant? Trishant, do you remember how it cuts the bone? Yeah. It will cut the bone like butter. Okay. It's a mechanical actuator. Bone CUSA's principle, but you are decreasing and increasing the amplitude and frequency. In CUSA, you can only increase the amplitude, not the frequency, because the piezoelectric crystal only has one frequency. So we are doing a you saw the other day. Yeah, so the bone, you can cut it like butter. Okay. So drill and also tumors can be taken very easy with that. Is the tumor scoop available? Yash, is the scoop available? Get the scoop ready, man. Get the scoop ready. We will do the drilling, anti-reclinoid and all with the scoop now. You will see something new. Yeah, I'll show you. Give me that bone here. Give me that bone once. Hold the bone like how no, not like that. Away from you. Yeah, like that. You see the keyhole now you made? You put the chisel there, and bang, 2 bangs in, and then you would have orbital roof would not have come. Okay, but that's okay. That's all right. You've done a beautiful job. Okay, all of you guys done a beautiful job. Clap for everybody. Okay, you've seen OZ. You've seen. Everybody is clear with the OZ. No doubts about the OZ at all. Now I think I'll take over. Okay, for some time. Can somebody else comment? Because I cannot do both together. Who's going to take over from me? Gloves now, microscope now. On.
Okay, what are we doing now? Hello?
Yes, John?
Yeah, what are we doing?
Yeah, everybody is seeing the cut. And after that, I think I'll have to put it. See, everybody is seeing the cuts made. And after that, we are going to go ahead and I'm going to go ahead for the transcavernous right now.
Okay.
Give me gauze pieces now. Okay. Gauze pieces now. This camera should be out, and then we can dissector now. Yeah. Dissector now. Microscope ready? You guys must understand that Dura was really friable there, right? How do I like? To dissect.
So sir is trying to separate the dura from the sphenoid ridge so that he can have an excellent extradural bone work later on.
Okay, microscope now. And the scoop now. Give me wet gauzes, please. Wet gauzes. Wet gauze, microscope, and my seat, please. Another wet gauze, please. Another wet gauze. Thank you. Microscope now. Give me a bone biting, please. This is going to be a major impediment, so you need to take this edge off, okay? Do you have a bone biting or a drill even? Drill is, this is not the correct drill, but yeah, maybe I can use this one. Give me that foot plate, please, the other one, please. Yeah. It's, yeah. You are in my field.
Sir, I would like to copy your statement as you say that drill has to be used like a paintbrush. That is
Yeah.
what exactly probably you are doing right now.
Yeah, I mean, always. Drill should be like the painter uses his paintbrush, okay? Should be free with your hands, no force at all. Cutting drill. If you're not getting a hold at some places, I'll give you a small hint. What you do is, supposing this is a surface you're not getting hold. So what you do is, with a cutting drill, you understand that it is rotating like that. So you come to a surface and then keep it there for some time. You understand? And then see that? And then you can drill, because you made a cutting surface now. You understand? Again, I'm going to this place and just staying there. And then I can drill. Are you understanding me? Not right on the carotid and all that. Right. So that part is taken off. All right. With all. Right now, microscope now. The dura is. Very important that to save the dura. Very adherent. You boys have done a fantastic job, because I can see how adherent it is. See, slowly we have managed to move away the dura. Can you see that? Yes. Microscope is ready? Fantastic.
Sir, the bone scoop is also ready if you want to demonstrate.
Right. Now, why is the joystick not working? The joystick is not working. The joystick is not working. For some reason, the joystick is not working. And there is no way to get this microscope. Yeah. Well, if we don't get it, then we have to use the exoscope for the dissection. That's all. Everybody will get to see it in 3D then. The joystick is not working.
Hello. The joystick is not working right now. In the middle of the dissection.
Why is that fellow not here? Yeah, it's working. Fantastic.
Yeah, it started. Don't worry.
Okay. Yeah. Come. Move it a little bit and then. Okay. Now, can I sit down, please? Can I sit down so that it's a bit of a, yeah. This distance is a bit of a trouble here, but that's all right. It's like having to do a sitting position. Suction to me. Not that suction. Something which is. Give me a plastic apron, please. Can I have a plastic apron? Here, can you put this on for me? Yeah. Okay. Okay. Right. Okay. Suction, got the suction. So you remember our, is the tumor scoop ready?
Yes, sir.
This microscope is not so bad as I thought, it's good. I'll focus. I'll focus first and then you can focus. Okay, I am focused now. Are you focused? Okay. Are you focused now? Excellent. So,
We are focused but not oriented exactly.
okay. So, that is the frontal lobe. That's the temporal lobe. Are you oriented now?
Yes, sir.
That's the frontal lobe. That's the temporal lobe. Clear? That's orbit. That is orbit. Clear? Okay, give me the tumor scoop, please. Put patties all around covering that soft tissue. Yeah. Tumor scoop and this. No, the tumor scoop. I will get the tumor scoop. See, what I'm doing is I'm trying to slowly separate the dura away from here. Are you seeing what I'm doing?
Yes, sir.
Everybody is seeing?
Yes, sir.
See, I am taking off the temporal dura away from the superior orbital fissure region. So, superior orbital fissure will come here. This is the orbit. Can you see the orbit? Can you see that? Give me the tumor scoop, please. So now I'll come into low zoom and then it will be very clear for you. Okay. Now, tumor scoop. Where is the foot pedal? Can I have the foot pedal on my left side? Yeah.
This instrument is designed by Sir Professor Aib Charyan for the first time. Sir, if you can just brief about the principle, how it works.
And now can I do it later?
Yeah, no.
Finishing the transcript. So see how I can scoop off bone easily. Irrigation.
This scoop is actually in the developmental stage. It is based on the principle of mechanical actuator.
It is
There's a-
coming up. Yash, this is coming loose. Yeah, okay. So we need to, you see how the bone is removed there? And if I touch the dura, I touch the vessel, nothing there. Can you see? So that is the advantage of this thing. You see how bone is being removed? Very safe and very easy.
All of you must have seen the concrete cutter. When it breaks the slab, the scoop is based on the same principle. It will vibrate and it will break the pieces in small pieces, break the bone in small pieces, and it will take it off. We can change the frequency, amplitude, all of this, and depending on that, we can use it for the debulking the tumor, taking the bone out, or anything like that.
See how I'm reducing that thing with very easily. You see that? And I can work the way I want. Unlike a drill, I can turn it and work the way I want. The same works for the same in CP angle tumors, meningiomas, heart meningiomas. This is a godsend. Okay? So the last bit, eggshelled bit, I'm taking it off. Yash is coming loose. Give me a dissector now. Irrigation, lots of irrigation there. Dissector now. Slowly, slowly. Are you oriented now? I'm going into high zoom now. So are you oriented? Everybody? If anybody is not oriented, let me know, okay? So that's frontal lobe. Biting, small biting.
Nibbler, nibbler.
Get the scoop ready and give me a small biting, please. Yeah. So once this kind of thing is reached, hard bone actually, really hard bone. Maybe Rushabh and or Reddy might have found out. Really hard bone. This is not the. But you see how the scoop was taking it off, no? Even I thought it is thin and you can take it easily, but it's not so. So you got to find out angles and just keep on. All right. So what am I seeing now? What am I seeing? That band. Yes. Can you see the meningoorbital band there? What is the meningoorbital band? Come, scoop ready now.
The scoop is broken, sir.
It's gone.
Broken.
That is the problem with prototypes. I mean, you've got to be very careful with that. Now the drill
Metronic.
small handpiece drill, small handpiece drill.
Smaller.
No, not the extra long one, not that extra long one. This is too long. This is too long. It's okay. It's all right. Irrigation. I can't see. Irrigation. Irrigation. What drill bit is this, boys? Huh? Is there a matchstick diamond? I mean, fine diamond or coarse diamond? Ah, yes. Irrigation, lots of irrigation. Yeah, lots of irrigation. Focused irrigation. Yes, excellent, excellent. MOB is the point at which the orbit, the frontal lobe, and the temporal lobe meet. Irrigation, irrigation, lots of it. Irrigation. ठीक है कोई problem. Huh? Very careful, sorry, with the take your time, aram se time, don't worry. That ghost piece overhang is a very, very bad thing. Always wet it and keep. And what happened to my assistant? Eyes. Okay, wash, go wash. Open your hands, open it and go wash. You can keep on repairing the drill. I'll just dissect at that time. No, I'll just dissect during this time. See, what is that I'm dissecting? What is that? What is that I'm dissecting now? Frontal base, right? Orbital roof. Yes. That this is the frontal, this is the temporal, and this is the orbit here. So the meningo-orbital band is between the frontal, temporal, and orbit. So can you see there is an artery there? So once we open the meningo-orbital, see what is happening to the tumor scoop? And I really like that drill which you gave me now. Now give me a knife now. Give me a knife. Everybody can see what I'm doing? No doubts till this so far? No doubts? That is cutting the meningo-orbital band. Can you see the artery there? It's not the carotid, huh? Okay. Right. You see why there is a bleeding. So come, give me a dissector now. Give me the knife should be kept like that and then away from everybody's hands. And then you can start dissecting the rest here. And if you, next 5 minutes, if you are not looking, you will miss the entire thing now. Yes, sorry. Can you see what I'm doing, guys? Everybody dissected to me now? What is that? What is that? What is it that you're seeing in the depth? Yes. Releasing a little bit more of orbitomeningeal band. Can you see it release now? And voila, you're in the cavernous sinus, right? Anybody wants it? Come, give me that knife once more, a little bit more. Knife, yeah. Yeah, thank you. Awesome. Right, dissector now. Generally, you use an ophthalmic knife for this one. Much, much more sharper. And what have I exposed here? Huh? No, it is that is the clinoid that we are exposing right now. Okay. Anterior clinoid process is being exposed now. See, that's a cavernous sinus which contains the third nerve. Okay. So can you see that this is the membrane that I wanted to preserve. Can you see all the nerves through that membranes? 3, 4 and V1. 3, 4 and V1, yes? And that's the clinoid, okay? That's the clinoid. So we're going to dissect this. So this is Dollings. This is Dollings. So see, you have reached the clinoid, and you can take out. Who wants to do a clinoidectomy? Somebody who's not been volunteered till now, they can do the clinoidectomy with the tumor scoop if it's available, or drill. Please don't damage the entire thing. So if you are up for it, willing for it, can you see the third nerve? Clearly, fourth nerve. See, that's the clinoid, okay? So we have irrigation there now, please, irrigation. Yeah. See how beautiful. Clinoid and the cavernous sinus, okay? That's a Gazerian, we are towards the Gazerian ganglion now. Yes? Everybody is seen. Who wants to do the clinoidectomy? Yeah. You guys come and do the clinoidectomy, but you protect the frontal lobe because the brain is very tense, okay? So now what I'll do is I'll give you one more additional exposure. Give me that thing so that the temporal lobe, if you take it off all the way here, you can reach. Yes, temporal lobe can be taken with stitches. Come, guys, take off the temporal lobe base all the way. Protect this dura. That is what I was worried. Okay, this dura has to be protected. Otherwise, our entire approach will be gone. Very gently. See, put force on this bone and then dissect out this dura. This dura is extremely tough to dissect, but it's possible. Okay. Take out this temporal base all the way like this, and then you will see that you can retract this dura back, and then you will see the bit and everything. This dura, this temporal lobe also, this dura also, you dissect, nicely dissect away from the temporal bone. Okay, take it out. Cavernous sinus, every one of you. No confusions in that. How I cut the orbitomeningeal band, you saw. This is unlocking. I have now unlocked the cavernous sinus. It's very easy to carry on dissections now. This is the key step. Here is where you can cut the third nerve, you can cut the carotid, you can cut everything. Okay. And if you don't preserve that membrane, then you will have bleeding. Okay. So that is the most important. The membrane which is seen over the cranial nerves. You are not seeing the cranial nerves clearly because that membrane is there. I had to preserve that membrane. Then only it become bloodless. So our technique of bloodless pericavernous dissection is based on the fact that this membrane is preserved. This membrane is not preserved. You will have cavernous sinus bleeding in its full fury. Okay. And if you bipolar that, then you will have ICA bleeding also in its full fury. All right. So this is the point. Each one of you can sit down and look at and maybe take out the clinoid very gently. All right. Huh? No. We are going in front of the temporal lobe. Gently. Can you see the cranial nerves now? Down. Show the cranial nerves. Reverse your retract. That is. See the membrane above the cranial nerves? See that membrane above the cranial nerves? That is the true cavernous membrane. Preserve that and you will have no bleeding. Third nerve, then the fourth nerve, V1. Third, four V1. That is how the behind, like that. V1, you follow V1 and you will have gazerian. Beautiful, right? Show me the anterior clinoid there. Can you see? Dissect the anterior clinoid, and medial to the anterior clinoid on that side is the extradural optic nerve. Okay, that side where suction is there. That is the extradural optic nerve. Is the scoop working? Yeah. Oh. Okay. No problem. Don't worry. We will see if there is anything, any way you can do it, okay? Because I would have really liked to demonstrate it here. Because anterior clinoidectomy, you see that scoop that we used? It would be the best for anterior clinoidectomy. You know, you can just shave off the clinoid like that without any problem. No heating, nothing, okay? And it will touch the extradural, the carotid ocular motor membrane, no problem, nothing will happen, okay? Because it's vibrating like that. It's not vibrating like this. It's a saw vibrates like this, okay? This is vibrating like that. So you use this movement when it is vibrating like this, and you will be able to shave it off beautifully. You see how it came off, that bone came off, right? Like that anterior clinoidectomy, I wanted to show you. Be very, very gentle, be very careful, huh? Don't worry. Be comfortable first, and then. No, you should have your control. Never. No start please for drill. Huh? Bad habit. Abhinav. Always your control, under your control. Gently. No problem. Just relax. Get your hand in, get your eye in, and then slowly start. Right. Beautiful. Absolutely no force. You saw me using the drill? absolutely no force at all. Okay, I'm enjoying it and doing it. No, I'm not pushing it and trying to do a job. Okay, I'm enjoying it and doing it. Okay, hands should move freely with the drill. Okay, the hand should completely, you should not be stuck up like that. Okay, the hand should move completely freely. Careful, 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 careful. You're catching the dura, catching the brain. Get a large wide brain retractor for him. Wide brain retractor. Do you have a wide brain retractor? The spatula is there? Is there a spatula?
No, no, no. You can use the periostem elevator.
No, let's get a spatula from theater. One spatula from theater. Let's get one.
That won't be able to use in live surgery.
No, no, there's no problem. You just sterilize it. Nothing will be sticking onto it. Okay. One wide spatula, please get it from the theater. One wide spatula. Because it's very important. Be very gentle and be very, go from the most superficial part to the most deep part. Yeah, you're drilling it, right? You have drilled it. Yeah, you can drill it. You can bite it off and go along it to the anterior, callinan process. You can do that. We are now doing just a tailored drilling of anterior clinoid because I have exposed the anterior clinoid completely on both sides. Yeah, that is why I can do a tailored drilling. Yes, yes, that is what exactly what he was asking. But this is the usual scenario where you have not opened up. Here we have opened up the clinoid completely from inferiorly, laterally, and superiorly. There you can do a tailored drilling of the clinoid. You don't need to remove that sphenoid ridge. But if you want to remove, you can. You are free to remove. There's no problem. Yeah, that is the carotid oculomotor membrane. Okay. That carotid is underneath that. So keep on taking the. Anywhere. You can just do it anyway, whatever way you want, you can tell. But you see after that cut how it opened up, that is unlocking. Okay, that is the secret of unlocking. Careful, careful, careful. Drill up, drill up, drill. That's right. Drill upwards to that bone. Careful, careful, careful. That's third nerve there. Careful, careful. Never. This is Lawton. Last time when we had a meeting combined, Lawton was telling he'll go for it. I'll never go for it. I'm primarily a skull-based guy. Okay, who does vascular. But so I will never, even my paraclinoid ruptured aneurysms, I never go for intradural clinoidectomy. Extra. Nilesh?
Hello.
I will never go for an intradural clinoidectomy. You know why? Intradural clinoidectomy is really dangerous actually for me because you are exposing the aneurysm. There's no dural layer between you and the aneurysm. You have exposed the brain, you have exposed the aneurysm, and you have to cut the dura and go into it. If you know how to release all around, then you see this is so easy for me. People say you have no control. It's actually you have no control in intradural. If intradural you go and touch the carotid, what's going to happen? You really don't have any control. If a drill touches the carotid, whether it's intradural or extradural, you'll have a problem. Now the point is whether aneurysm ruptures. When you're doing a craniotomy, the aneurysm can rupture. When the patient is walking, before you are going to clip, aneurysm can rupture. So that is nonsense. If you are pushing and pulling too much, of course, then it will rupture. You don't have to push and pull too much. Did we push and pull too much here? It is a very, very tight brain. Do you know? It's this cadaver brain is a formalin fix. It's really tight brain. It's like cystonostomy. Very, very tight brain. Okay. But we didn't have to. In a tight brain, people say that you cannot reach the ACP. But you see, after you unlock, see how it is so beautifully you seen. Okay. Yes, that is why. That's called axial unlocking. So you see, entire anterior part of the cavernous sinus is exposed. Therefore, what I did is I unlock like that and I unlock like this. And then the clinoid is completely, base is completely seen. That's the whole concept of this skull base. Okay. This is skull base. This is the concept of skull base, unlocking. All right. No, you should see the optic nerve on your medial aspect, and laterally the entire clinoid should go out. The oculomotor nerve should be the roof. I will show you now. Okay, once you guys are done, then I will show you how you go about it. Okay. Once you do the clinoidectomy, then I'll go posteriorly now. I will need stitches and rubber bands now. A lot of stitches and rubber bands. Yes, absolutely. Read our paper. We submitted it to ACNS 4 years back into 2014. Maybe 6 years back. They published this only into 2017. So ACNS has I was the executive editor during those 4 years, and I never wanted to push my article. So it has a history of bad publishing. So you give the articles to it, and then it'll get published only 4 or 5 years later. That's the problem with AJNS journal. So they published in 2017. So read up, Google the article called Orbitomeningeal Band to the Key of Bloodless Pericavernous Dissection. We have written it. Okay, we have written it. We have described this technique. Okay, now it's being followed everywhere. You can do a small mini pterional like that, and then I can take you all the way to cavernous sinus and petrous. Okay. We will do that later on, like slightly more than burr hole. If you want to do it, we can do it tomorrow. If you are interested in doing it, small craniotomy, we'll do the same thing, and we'll go all the way up to the Gazerian ganglion, all the way up to the petrous apex. Okay, because the corridor that I need, I'm not using all that big craniotomy. See the corridor that I'm using now. Careful. Third nerve is right there, where you're putting your. Good. You guys are doing very good. Enjoying it? Seeing the cavernous sinus and doing a clinoidectomy. Good. So you're going to do end-on drilling, right? Right. Go do end-on drilling. Careful, very careful. Careful. Now take out end-on drilling. You must always take out and put water all the time. Put water now. Lot of water into that region. Yeah, take out that white of that bone dust. Take out the white of that bone dust. Right. Again, do end-on drilling. Gently see it and do end-on drilling. Like a brush, drilling can be done like this, on side and on. Okay. So if you want to sweep tissue away, you sweep it like that. If you want to get anchor into something, you get anchor into something and then sweep. Okay. And then you can do side-on drilling. Side-on drilling is just on the sides. This part is protected because the matchstick doesn't have a tip. What happens is the matchstick, even if it touches the dura, nothing will happen. So you can do a side drilling. Okay. You should learn the brush strokes. Like with your brush, to learn painting, with your brush strokes, you should learn. Sometimes you do that with the brush. Shubhajo is an artist. Huh? You know how you do that with the brush, right? So that is end-on drilling. That's what he's doing right now. Ah, careful, careful, careful. Dissect, dissect further, dissect further. Expose the. कौन है? Who was Baba Kateb, no? Huh? Baba Kateb had called, yeah. What happened?
He's saying he has, yeah, he shared me the screenshot.
Huh.
He was not able to register. And that,
Yeah.
but the
Dissect more, and then you can easily drill the clinoid further, further and away. No, no, you have something in the drill tip. Clean that, clean that, clean that. Yeah. उसको डायरेक्टली तुमको ही कांटेक्ट करने के लिए बोलेंगे तुम्हें. मैं सर्जरी में हूँ या मैं दिल में. One more thing I want you to see while he is doing the clinoidectomy, I want you to see how you can see scans differently. How do you see scans now? In 2D, right? You see scans in 2D so that you assemble all that 2D and get a 3D image, right? I want you to buy something called the Oculus Quest. And we will show you. And take a scan, and this computer will, it will 3-dimensionalize it for you. Then you can walk in, look in, where is the vessel, where is the aneurysm, where is the tumor, all that you can look around. You will be in a room with the tumor and aneurysm and all that. So my boys has already seen it. We've got it here. You guys should get it. So no more seeing scans in 2D. Okay, you've seen it, right? So we are developing it so that the whole idea of the scans and print should be on a VR, so that the neurosurgeon should be inside the brain. And then you'll see everything in 3 dimensions. Okay, we have it right now. So we will develop it. We're trying to bundle it so that the guys bundling it in United States is selling it for 1.5 CR. Okay, we'll try to probably come at least 1/10 of it. We need a very powerful computer. That is a limitation. And of course, the VR, Oculus VR headsets also. Now, if we get some Indian company to manufacture all this, the price will come even further down. But right now, we're trying to get it done. For us, trying to get it done for 15 lakhs, and I'm sure it will be much more lesser once that also comes down. You guys are software wizards, so try to get it down, okay? So that every hospital should have it, okay? And no patenting, nothing. You guys want to do it your way, you do it, and okay, you do it and improve it. Okay, you come and see how we have bundled it. All right. I called the guy from Pune who's done it. Fantastic job. So you guys come and have a look at it. Okay. How things going? Yeah, you shelled out the anti-recliner, right? Dissect more, dissect more, dissect medially more. Medially and top, the plenum, towards the plenum. No, with the dissector, Reverse your, that's right. Beautiful. Go above. Ah, that's right. Yes. Go further above. Go further above. Yes. Beautiful. Dissect, dissect, dissect. Go on the anterior clinoid process and dissect. Dissect. Yeah. Good, 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 good. Now that orbitomeningeal band, a little bit of it is seen. See that? Yeah. No, the band is, that dura is still seen, little bit. So you have to release it, see that anterior clinoid process only remains, only it a little bit remains. Okay. Go, 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 go now. Go under high zoom now. I'm going to zoom it for you. Okay. It's zooming? Oh, sorry. Okay. I'm going to take the joystick and put the joystick so that it'll center. Otherwise, other way, other way, other way, other way a little bit towards this side. That's right. That's right. So you're going to zoom it furthermore. It's a maximum zoom. Huh? All right. So you're under maximum zoom on this microscope. Always remember, do surgery under 40 zoom. If you're doing aneurysms, microscope, Zeiss will say only 25 zoom is available. No, 25 zoom is old school. Old school, okay? Do zoom under 40, okay? Mitaka is bringing 77 zoom. Try to do it under 77 so that you should not see the entire aneurysm. You should see only one part of the neck of the aneurysm. That is how you should do it, okay? When you do it, that is when your surgical skills will go to the next level, all right? Do it under high zoom. Learn to do it under high zoom. Now this guy is already, for an extradural procedure, he's already using the highest zoom, okay? Can you see the cranial nerves now? So beautifully. No, no, not with the drill, not with the drill, not with the dissect. Take your dissector, dissect around. Take stitches now. Take stitches on the frontal and the temporal dura and pull it towards you. Pull it towards you. Okay. Take it like that. Pull it towards you, and then it will be easier for you. You see? Take stitches. Deep down, take stitches and pull it towards you. It will be easier for you. Take at least 4 stitches, 5 stitches. Okay. Don't use retractors. Retractors use up your space. Sutures give space to you. Okay. You're understanding till now, no problems? You guys are not feeling sleepy or something? The same thing can be done in theater. The same thing. You will think that, oh, this is only cadaver lab. We'll show you videos of what we do. I mean, all cystonostomies, we do the same thing. Okay. We don't do the clinoidectomy and all that, but we show the anterior part of the cavernous sinus completely. Cut the orbitomeningeal band. It will not take any time. Okay. Once you get into the hang of it, it will take you no time at all. Otherwise, you don't do this, you will never graduate in your whole life. You will not graduate to that level. You will always be doing, you'll be the Sylvian guy. Okay, using Sylvian dissection to get into the base. Okay, that is good. That should always be there. But along with that, extradural. Okay, Dolench was a genius. I have in 2014 or something, I have given a lecture in his Ljubljana on the modified Dolench in his department. I remember. If you meet him, the man has a charisma. You know, he's a fantastic chap. Yes, 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 yes. Very good. Very gentle stitches, okay? That dura is very friable. And that dura, so you should not pull it. That's what I was telling you. So take superficially. Don't worry. Don't worry. Just don't worry. Take a good bite and without pulling it. Take a good bite and without pulling it, just put a little bit of pull. Use 4 or 5 of them, okay? And then it will pull. You know, now the tide is changing. For the last 40, 50 years, neurosurgeons were into writing and publishing. Believe me, no neurosurgical procedure. What Yasagil has stopped, The buck has stopped there. Nothing advanced. Only people have gone back. UK had guys who had doing fantastic surgery. Now, if you go to UK, there's not a surgeon that you can trust for an aneurysm surgery. Okay, not a single guy. Maybe a few, perhaps. I mean, Tom and Ramesh and all will take offense if I say that, but otherwise they must be listening. So, but it's gone backwards because of the stupid writing tendencies, and the people who were honored were people who were writing, people who were collecting, publishing in these so-called hallowed journals like NEJM and all that. It's all nonsense. Okay, believe me, I'm telling you on air. I'm telling you, it's all nonsense. Okay, don't believe this. First thing first, get your skills right. If you're a professional footballer and you're playing for Barcelona, if you're well published, will they take you? Will they take you? If you're driving for F1 and supposing you are the most well published guy in F1, will Mercedes or Ferrari take you as their F1 driver? So like that, your patients deserve to have the best driver or the best footballer. It's a professional sports. Okay, if being well published doesn't help anyway. So don't think that you'll be a professor, well published professor, and you can earn that way. And that's not the way to go in neurosurgery. Okay, have skills, worship concepts, worship skills. Then only the whole purpose of you being a neurosurgeon is fulfilled. Otherwise, you become one of those guys like in the West. Okay, they'll be coming here talking about p values and all that. What p values do we have in neurosurgery? Nothing. Okay, we need to learn this. Come to the cadaver lab, learn this, do good surgeries. Then you can talk about p values later. I'm not telling that it is not necessary, but that shouldn't overtake your skills part. Okay, skills is most important. Right, guys. Where are you? You're comfortable. Show me the clinoid now. So he's zoomed out. See the picture now. See how deep he is. Are you understanding? Okay, now give a little bit of a pull on one. That is enough. That's enough. Angle your microscope right and go into the. If you're not drilling, put a patty there. That will help you. Okay. Put a gauze piece there. Put a wet gauze piece on there and that'll help you. If you're not drilling. If you're drilling, don't do that. See the clinoid? Dissect further. Dissect all around the clinoid. See that you're going into the extradural optic now. Can you see that? Go medially and you will see the extradural optic now. Now the whole concept of academic neurosurgeons, anybody academic neurosurgeons means he doesn't do surgery. Those guys are the p-value guys, okay? Huh? I would rather call them academics, not neurosurgeons. Huh? People say we are attacking them. It is a truth. You have to call a, you know, in life you must learn to call a joker, and if there is a joker in the pack, you have to call the joker. I mean, you have to be kind, of course, but if there is a joker in the pack, you should know that is a joker in the pack. Okay, you should know what is your aces and what is your joker, and definitely there's no academic neurosurgeon who sits and writes and does p-values. No, don't go that way. It's wrong. Okay, I've seen a lot of guys from Africa and all trying to publish things. Learn to do an ETV, learn to do a proper cystonostomy, learn to do an aneurysm surgery. Then things will change. Good. You're doing side and end on drilling, right? Excellent. You're getting the hang of this. Are you realizing how deep he is doing it? When he zoomed out, do you realize? Harshad Parekh, he wants to say something. Good. See, the clinoid is coming off now. Take off a little bit of the frontal base also. Yeah, that's right. There. Don't get into a tunnel. So take off a little bit of that also, gently, very gently. Imagine you are doing a paraclinoid. And after this, immediately after this, we will show you a paraclinoid aneurysm. Okay? And then you will understand much, much more what I'm doing. Okay? You will understand much more. Can you put up on YouTube a video, boss? Hey, Nilesh, can you put up a video on YouTube?
What, I gotta put the YouTube on there?
Huh?
Are they putting the YouTube there on there?
Yeah. A YouTube video. I wanted to show, because after this drilling, can you see the optic nerve now? You are on the optic nerve. Can you see the optic nerve? That white thing is the optic nerve. And you are going, what this is the strut. This is the optic nerve. There's a carotid there. That is the strut. That is optic strut. This is the extradural optic nerve. And this is the carotid is here. So here, this is the strut. Clear? Very clear. Okay. You guys want to have a look at it? You guys go have a look at it. The operating guy, you are clear? Can you see the optic nerve coming here? The extradural optic nerve. That is the frontal dura and that's the optic nerve. Can you take, so the clinoid is out, it's a strut now, optic strut. So when everybody talks about strut drilling, people think it is hallowed. It is not, you see? Okay, remove the strut, come. Yeah, it's all clinoid. That entire bone has to come out, boss. There should be no bone there. Careful. Little bit of endon. That drill bit is now too large. You are going between the carotid and the optic now. That drill bit is too large now. They have small drill bits. Smaller drill bits, Medtronic. Smaller drill bits. Anything for discussion? Anything for any points that you want to highlight or anything? This is what you're learning. This is cisternostomy. Now you open the dura, you're right into the cisterns. Okay. But you don't have to do all this. You don't have to. You remember the first time that I unlocked? Then you are into. Then you can open the dura, you're into the cisterns. Even if you don't unlock, if you can put a little pressure on the basifrontal lobe, you're into the cisterns. Okay. Sometimes you don't need any skull base work. You just need a good terminal craniotomy, biting of the sphenoid all the way up to the orbitomeningeal band. Open the dura and then you get into the cisterns. Okay. So these guys are the experts. All these Nilesh, Trishant, Nargiza, all these guys, Manuel, all of them have seen it. You can you can come to the cadaver lab. Here we will expose the basilar, everything we'll expose on this one. Okay. Entire cavernous sinus, basilar. Then we'll go posterior. All right. You got? You got something on the drill. You got something on the drill. Take it out. You can still see all the 3 cranial nerves. Clear? So the cavernous sinus with clinoidectomy, Dolenz, done completely. So it's debunked. Big procedure in skull base, Dolenz approach, debunked. Any doubts? You guys can do Dolenz now. Yes or no? Start in a cadaver first. And then you can go on to do the Dolenz, okay? It's nothing big. Yeah, good, 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 good. Go on to the roof of the optic now. Yeah, there. Yeah, that's a cutting drill. That's not the greatest. Yeah, there. Drill it so that you don't get into a hole. Yeah. Good. Come all around there. All the bone, you take it out. Gently take out all the bone. What I want to prove is anybody can do it. Okay. There is no fun of me sitting and doing the drilling. Then you will be bored. Okay. I want each one of you to do it. Okay. You're okay? Huh? Good. Yes. Okay, can you stop the drilling for a minute? And after that, we're going to show a paraclinoidal video. Can I control it, please? Can I control that? Mouse, eh? No, not this video, da. Mouse, kidhar hai?
Yeah, I can't control it from here.
No, John, I'm doing it actually. Can you see what we are doing?
Yes,
Exactly the same thing that we are doing. I mean, what he was doing. Can you see the cavernous sinus being exposed? Yes, guys. So that is temporal lobe. That is frontal lobe. And that's the orbit. And what is that? Meningoorbital band. Okay. Let's come into the paraclinoidal. It's a ruptured paraclinoidal artery aneurysm. And what am I drilling now? It's a clinoid and optic roof. Okay. Now I'll need to be more clear about it. No, can I? No, I want to go back to the shut down this video and then go to the another. Yeah, because this is a neurosurgery TV presentation. So just family. Eh? With this, just remind me tomorrow that to show that paraclinoidal paraclinoidal aneurysm. Okay, so that we are very clear about where we are drilling extradurally. Okay, take off all that bone. Yeah. Okay, guys, can I have a look now? Right. So gloves now to me, please. Can I have a look? You've done a fantastic job, boss. Good. A big clap for this guy. Huh? The other fellow also who was doing it before. You were doing it before. Clap for you also. Okay. Excellent. Okay, sector now. Irrigation, lots of irrigation. That's a dural layer, and that is clinoid 2. And the moment I break it off, where have I reached? No, that clinoid I have taken off. That is the optic strut there. You know what is that structure? This structure? Yes. You guys are realizing it? Can you see the fourth now? Can you see the third now going back? That's a carotid, right? Give me the drill, please. Everybody clear about everything? Can somebody hold, no, hold that one, hold it up. Yeah, that's right. So no weight on my hand. Oh no, this is not a good drill actually. Can I have the matchstick, please? Can I have not the matchstick, the coarse diamond? The coarse diamond? A small coarse diamond? Yeah. Okay, where is the, yeah. No, hold, no, don't pull it down. Don't pull it down. I need, yeah, that's okay, that's okay. Take it, suction, irrigation, suction. Yeah, dissector to me now. So, oh, this is too large. Do you have a pen field number 4? You have to take this bone off completely. That is optic now. There is optic now. So I'm going in below the optic now into the strut. So that is the bone I have to take out. I really wish I had the scoop now. No, I can take it out like that. That is the beauty about. Broken the strut. Can you see? Don't do that in real life, huh? For God's sake. And what are you seeing now? That's the optic now there. Carotid, dural rings there. Third now, fourth now, V1. Yes? Now, I need somebody to remove this bone bit. Yeah, this bone bit. See, the head is not even turned. So it's a bit of a issue. The head should be turned ideally. Okay. Then it is much more easier. But we are doing it in a tight brain with no head turn. Okay. So it is a bit of a challenge, but yeah, careful. Yeah. Very good. Excellent. Excellent. Okay. Very good. Can you see the V2 now? Can you see the V2 there? There. So I have taken that dura away from the one second. I will come here a bit. I wish I could have a little bit more of a head turn, but that's okay. Yeah, that's beautiful. That's enough. Give me a patty, please. Tight brain. Huh? And then you have to remove this bone. So to see the V3 and now that's the gastrin ganglion, okay? Cotanoid now. Yeah, that's enough. Those pieces enough. That's excellent. Beautiful. One second. Yeah. Yeah, that one. You can keep on removing. So can you see starting from the extradural optic nerve? Can you see the extradural optic nerve there? Clearly? Can you see the carotid there? There. Can you see the carotid clearly? Guys, yes or no? Zoom in. All right. Right. Yeah, you can do it. Yeah, and now you have to come to this side. No, opposite. Right. Focus there. Focus there. Can you see the optic carotid?
Yes.
Dural band there.
Yes.
Last bit of clinoid there. The clinoid has not been completely taken, so the last bit of clinoid has to be taken from there. Give me a micro scissor, please. Oh, no, the micro scissor. Can you see me cutting the distal dural ring all the way? This cannot be done with simple scissors. Okay, can you focus it, please? Center it, please, for me. Joystick or whatever stick it is. Yeah, right. And now I'm going to zoom it up. Zoom, yeah. No, zoom in. Center it again. No, center it again now. Center it again. No, 1 second. Yeah, it's brilliant. That's brilliant. That's brilliant. Now I will focus it once more. Beautiful. Can you see the distal dural ring clearly? I'm cutting the distal dural. Give me a micro scissor, please. I cannot cut it. No micro scissors? Blade is fine. Yeah, blade is fine. Blade is better. Yeah. Away from the carotid.
So this blade where that is distal dural.
See, that is falciform ligament. I'm going to cut off that dura all the way like that. So, and I'm going to, I want you to dissect that dura and then remove this bone, this entire bone. You see? Can you see this entire bone? This bone, remove it, okay? See the dura I've cut off? And then we go all the way down. So that's the carotid. Can you see the carotid? Can you see the optic now? Everybody? That is the opticocarotid window. You will see the ophthalmic artery there. I want you to take off this roof, drill off this roof, and then expose the optic nerve there. And then cut this entire this dural ring and free the carotid. All around the carotid you can cut it and free it, okay? And then come down with the joystick. Can you see the third nerve? Big nerve there, lateral to carotid. Yes. The small nerve which is overtaking the third nerve. Yes. So this clinoid has to come out. And then you will see the extradural carotid also properly. Okay, this clinoid has to come out. Can you guys do that? So third, fourth, the fourth overtakes the third at the superior orbital fissure. Okay. Now we are going to make a window between the fourth and the V1. And between the fourth and V1, what part of carotid you will see? Intracavernous. That's a C5 carotid. Can you see? That is I'll show you. Irrigation, lots of irrigation and a dissector for me. Oh my, this dissector is too big. This dissector is too big. That carotid is C5, paraclival carotid, okay? So I'm dissecting between the fourth nerve and V1. You can come here and feel the carotid. That's a carotid, okay? That triangle is called what triangle? No. And that what nerve is medial to V1 there? Sixth nerve. You can see the sixth nerve already there. And that will be the Doralus canal there. Okay. Right. Right. So you guys, all of you take turns, please. I want you to understand this concept very, very clearly. Okay. Everything is seen. remove that bone a little bit more. And you saw the optic nerve, carotid, third nerve, fourth nerve. Huh? V1. You saw the Parkinson's triangle. You saw the clinoid being removed. That is your dolens.
Oh, fuck
Huh?
off.
Between the fourth and V1. You dissect all the way. And tomorrow, remind me, I'll show you where I will open. This is not a cadaver video, it's a real video where we open between the fourth and V1 into the cavernous sinus in the Parkinson's triangle and clip off the meningohypophyseal branch, which is supplying a DAVF. Okay, so a transcavernous, not a pericavernous approach like this one, a pure transcavernous approach where we go into and then we clip off the meningohypophyseal branch in the Parkinson's triangle, which is supplying a DAVF. So remind me to show that video also. Remind me to show the paraclinoid video also. So that is the fun of it. You understand this and then you understand that much more. And once you understand it, you can start doing it. Okay? Don't laugh, don't laugh. You will do it. No question. Otherwise, there's no point of you coming here. Okay? All of you will do it. There's no question. Clear, all of you? Huh? Any more doubts? I think now you guys, they should do. You have a cadaver for them to do? Now, do you have 2 cadavers? So one batch you can divide into probably 3 batches. Divided already? So no, let them do it. You guys do it now. Okay? Huh? Yes. Once see, you go medial to V1 and the 6th nerve will be there. The V1 you saw, right? I was dissecting between the 4th and V1. So we go medial to V1 and lift up the V1, the 4th nerve, the 6th nerve will be there. Okay.
Dr. Srinivas Soidas sir had just arrived here. Doctor, we welcome you on.
Dr. Rohidas, Charian. So good to have you here. So Dr. Rohidas also is a very reputed and famous spine surgeon. So you guys can have the full of, whatever you want to know about spine, you can have Dr. Rohidas discussing things with you. We're not on a very formal basis here. You guys can ask things, and if however you want the arrangement, you have the exoscope, you have endoscope also, whichever way you want things done.
Let's see.
Okay.
Well, Art, do you mind if I ask a question?
Yes.
Yes, we have Adrian Mendoza asking, where is Dorellos Canal?
Dorellos canal, if you trace the 6th nerve proximally, then you will see the Dorellos canal from where the 6th nerve is entering from the posterior fossa into the cavernous sinus below
Amar.
the Gruber's ligament. That is the Dorellos canal.
Thank you.
Right. Okay, now I think you guys can start doing the dissections. You can see the 3rd nerve. You're drilling right above the 3rd nerve.
I think most of them have already divided into groups. Each one has 1, 2, 3.
That's a strut. That strut is taken now.
On the registration, you haven't been told about the groups. Okay, just 1 second. 1 second.
Just follow them.
Yeah.
We have divided you guys into 3 groups actually. 1, 2, 3. So we'll just name who is in 1, who is in 2, and who is in 3. Similarly, we will have 3 cadavers. So 1, 2, 3. So we'll get the number. You just remember your number. It is 1, 2, or 3, right?
Scoop was fantastic, but you guys need to figure out this problem. It was
Yeah. Group 1 will have Dr. Aryan Patil, Dr. Devdatta Patil, Ankit Agrawal, Kartik Multani, Rahul Srivasan, Hari Singh Parmar, Aniruddha, Dr. Rahul Singh, and Dr. Dheeraj Pant.
what we have done here. One group continues to look what we have done here. Try to do a little bit more dissection here. Next group goes and start OZ and starts unlocking the orbitomeningeal band. Whenever you need me, you can call me. And the other group also starts that. Now, Professor Rohidas wants a spine. If anybody wants to, I mean, how do you want to arrange it, Nilesh? You guys
Yes, sir.
see how it is done, okay? Huh?
We can turn this Group 2 will have Dr. Sushil Bogawar, Dr. K. Sudhakar, Palve Prakash, Sparsh Pandey, Dr. Jatin Kumar Mawani, Dr. Jayant Gaud, Subba Reddy, Shrikant Kalbagwar, and Anup Shastri. Group 2. Group 3 will have Dr. Mandar Patil, Dr. Nikhil Talati, Saurabh Dubey, Rushabh Cheda, Pradeep Gupta, Dhruv Kumar Baru, Rahul Sharma, Murtaza Dadla, and Narendra Motarwar. One, two, three. Three cadavers are all there. This is for just looking. Okay. 1, 2, 3. The cadavers are like first, second, third. First, second, third. This is cadaver 1.
Cadaver 1, cadaver 2, and cadaver 3 last.
Instruments will be covered.
This is 1, this is that one is 1.
Rudra, Sagar, please take your positions and distribute the instruments. This is first. This is second, third. तिकडे कोपऱ्यात. Third कोपरा. हा तिकडे हा नाही सगळे आहेत.
Dr. Sagar and Dr. Advait are here. They will help you up with the instruments if you want. These guys are here. Just have a look at them. He is Sagar and he is Advait. So he'll give you up the instruments which you want. Sagar and Advait, can you just distribute the instruments on each cadaver? 1, 2, 3.
If anybody requires some help, you can come. Yeah, everything is here. If anybody requires help, they can contact me or Dr. Trishant or Dr. Nikunj. The Metronic and Manman guy will help with the drills.
Batch who is really interested in yes.
अरे अमर
अरे मी डेमॉन्स्ट्रेशन करायचं म्हटलं तर काय आणते का काय आणते दे मग इंस्ट्रुमेंट कुठे आहे
Hello, anyone there? We lost the audio.
John?
There we go. We got it.
Yeah, we are not lost the audio, but we have started with the hands-on workshop with the all the delegates are busy in workshop and we are just observing that. So
Oh,
for
okay.
meanwhile, just only the video will play. Nobody will
Okay.
talk
Oh, for how long?
for maybe 2 hours.
2 hours?
Yeah.
Okay,
In between, if any online participant has any question, you can ask.
okay.
We will have to vacate this cadaver lab by 2:30. So plan your dissections accordingly.
Excuse me for a minute. So the people in the lab are going off to do dissections now? Is that?
Yes, yes, yes.
Oh,
Pramod,
so
can
how-
we show?
Oh,
Can
so
we
there's
show
more than
the
one,
video
there's
of this
more than
lab?
one, there's more than one cadaver?
Yes, there are 3 cadavers on which the participants are doing the hands-on, and the one
Okay.
cadaver which is under microscope, they are just seeing the anatomy.
Okay, so we're at the
External
main,
camera.
we're at the main cadaver, right?
हम्म.
With the overhead camera.
तिकडचं दाखव त्यांना एकदा.
त्यांना ब्लॉक हवाय कॅडवेअरच्या खाली.
आपले दीपक मामा त्याच्याकडे आहे block.
Oh, there's a money shot?
Yes, there are almost 25 participants here,
Oh, very good.
and they have traveled all over all over the India.
Oh, mostly India, huh? Oh, there we go. That gentleman with the camera there, that camera is a long shot, huh? And that's the good old overhead. Could you show us the overhead?
Yes.
On the other camera? Yeah, that's good. That's good. Where is the overhead? Because you did some work getting that together, right?
Yes, yes.
Because, this can be used as a model for other centers, how to set it up, right?
This is only in the just initial stages of the building this cadaver lab. Right now, we are not even 10% done. We are planning this cadaver lab will be like one of the in world class.
Oh, good.
Right now we have just got just this room and a few tables and few cadavers. Everything
Right.
else is arranged from the outside.
Right. You just,
Within next 6 months, we will be fully equipped with at least 10 microscopes, drills, suction machines, and everything is all set up.
well, you know what might be an educational thing is
Yes.
to explain to the audience what a cadaver lab needs.
Yes.
Just, can you go over that? Can you talk what a cadaver lab needs? Using your lab as an example. Hello?
1 second, John. I'm taking on a call. One second.
Oh, okay.
अभी ये लोग आएंगे, अभी कोई आएगा नहीं, वो अभी वो चालू किया है। हाँ, चलेगा, ओके, एक बार चलेगा। नील कमल को कॉल कर सकते हैं, मुझे कॉल लग नहीं रहा है उसका, उसको बोलना कि माइक्रोस्कोप पर कवर चाहिए क्या सर, बाहर माइक्रोस्कोप पर कवर चाहिए। हाँ हाँ हाँ, उसका कवर कवर चाहिए, प्लास्टिक कवर रहता है ना अपन जो ओटी में यूज करते हैं। हाँ वो चाहिए। हाँ वो चाहिए अपने को यहाँ पे एक्सोस्कोप में यूज दिखाने के लिए। अपने एक्सोस्कोप का डेमोन्स्ट्रेट करना है, बट एक्सोस्कोप को आप गंदा नहीं कर सकते। हाँ हाँ हाँ, ओटी से देखिए जाइए बस आप। हाँ। बोलो ना क्या हुआ। हाँ हाँ देखना है। आ गया। बराबर सर को दिखाना है। Slightly anteriorly. उसको अपने को माइक कवर मिल जाएगा। अभी पॉसिबल नहीं है। Just give a lecture. Next time we will plan with the instrument and all this. But like वो जब आ गया है जैसे दिखा। हाँ 16 हाँ बोला विषय करता आता एक नाही आता कुणी बोलणार नाही तुमच्याशी बरोबर जेव्हा आपण आता 2 वाजता घ्यायला चालू करायचे तेच आठवून घेतलं आता थोडं थोडं घेऊ तिकडे तुम्हाला कोणी रिकाम कोणी असं वाटतंय ना तर त्यांना इकडेच घ्यायला लागेल हा नाही चांगला की बॅकग्राऊंड घ्या की चांगलं लाईट सेट पूर्ण इथे अरे दिया है सबको, अरे है सबसे टिफिन लाया है अपन सागर को पूछो इधर रखा रखा है सब कुछ इसलिए पहले बोला तो तुमको सब अरेंज कर आपला स्क्रीन तर प्रोजेक्ट करू शकतो का आपलं ते लॅबचं 2 बजे से पैकअप करना चालू करना पड़ेगा। तो अभी बता दे बोल मैं आना से 1 घंटे मुझे बोला कि विल पैकअप एट 2:30 तो प्लान में लेकिन वो उधर से उधर खाना रेडी है बोले रोहित सरांचं लेक्चर आहे डेमॉन्स्ट्रेट नाही करणार का ते बघतात इंस्ट्रुमेंट नाही प्लॅन केला होता प्लॅन म्हणजे प्लॅन नव्हतं असं फक्त लेक्चर साठी हो म्हणाले लेक्चर 4 वाजता अपोजिट साइडला ओपन केलं हा काय नाही अपोजिट साइडला उद्या दाखवायचं सेम कॅडावर मध्ये बोलो लंच के लिए और मुझे हमको 1.5 घंटा लगेगा डेढ़ घंटा 1:30 से 2 तो बजे ही जाएंगे. Those guys who has completed the dissection and wants to have lunch, they can go to the cafeteria. The lunch is ready there. Gloves पहन ले और माइक्रो सीजर दे मुझे. Yes.
कूपन हमको भी लेके जाना
हाँ नहीं आपको थोड़ी
नहीं
आपको तो ऑर्गेनाइजिंग
अच्छा अच्छा
माइक्रोस्कोप का कवर. No. So नहीं वोटिंग वापस रखना होगा 50.
Interview. That's what I was doing here with you.
माझ्या बॅग मध्ये ठेवून दे. माझी बॅग आहे ना तिथं तिथं नको ठेवतात म्हणजे कोणी ते खूप महत्वाचं सामान आहे त्यासाठी तुला दिली ना मग अशी बॅग.
हेलो
देना नहीं है मेरे बैग में रख देना है.
ठीक.
मेरा बैग
हेलो 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 चेक हेलो चेक हेलो.
Hello, who are you talking to? Hello, is anyone there?
सागर उसी इसको पता है आगे इसको पता है कहाँ पे रखना है. निकुंज आपको मिला आपको ओटी का कवर? अरे वो वाला कवर नहीं, जो ओटी के इंट्रॉप में यूज करते हैं ना, प्लास्टिक कवर जो अपन ओटी में यूज करते हैं वो। यस यस यस, हाँ 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 हाँ, ओटी में अपन यूज करते हैं ना, जो इंट्रॉप में यूज करते हैं, ताकि उसको खराब ना हो। यस, हाँ वही, हाँ 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 हाँ। प्रवीण सर ना कॉलम में देख ना दे लवकर। Yes. लाओ लाओ लाओ। Yes, sir. All the delegates are requested to come here. Cherian sir is demonstrating some anatomy.
Can you give me that drill again, please? And the drill doesn't have the drill bit. So, everybody,
Metronic guys.
yeah, so irrigation, lots of irrigation there. Lots of irrigation.
Rudra, Advait, one of them. Rudra.
Lots of irrigation
NS
there.
couple.
So, guys, can you see? Give me a dissector. Can you see the third nerve there? Everybody?
No, sir. No, sir.
Huh? You can't see? Can you see the V1 there?
Yes.
V2? V3?
Yes.
Gazerian ganglion? Petrus apex. So that is the Meckel's cave is in the Petrus apex. Do you know that the Meckel's cave is in the Petrus apex? That's a Meckel's cave. Can you see? And can you see? I've just drilled out the carotid, the C6 intrapetrous carotid, and that's the intrapetrous carotid. Can you see clearly? That is a C6 carotid, horizontal carotid. Okay. So you can see V1, V2, V3, Gazerian ganglion, carotid, and this is the Kawasaki triangle. This is the cochlea will be here, that is where the carotid will go down to become the parapharyngeal C7 carotid. Okay, so this is cochlea, this will be the cochlea, and this is the this bone. If you can remove it all the way, that is the internal auditory matrix will come there, and this bone, if you remove, that is the petrous apex. Okay, you can drill and remove this bone. Clear? You want to drill? So anatomy is very clear. Now I'll come to you. I'll show you. Optic. No. Yeah. Optic nerve. Optic nerve. Carotid. Yes. That is carotid. Zoom in. Zoom in. Optic nerve. Carotid. Come down. Third nerve. Carotid, cavernous sinus. Third nerve. V1, V2, come down. Come down. Somebody wanted to see the sixth nerve. Irrigation here in this region. Somebody wanted to see the Dorellos canal. So the carotid has been opened here. That's okay. See the posterior clinoid process. This is the posterior clinoid process. Okay. This bone. No, generally, sometimes I drill it between the optic and the carotid. Sometimes I drill it between the carotid and the third nerve. But extradurally also, this is the PCP. Okay, this bone. This bone. Can you see? I'm collapsing it now. And the Dorellos canal is there. There is the Dorellos canal. Behind the PCP, the sixth nerve comes. Yeah, focus there. Can you see the sixth nerve coming there?
Yes, sir.
Can you see that nerve coming?
Yes.
Irrigate and take off that blood. You can see the sixth nerve coming there. Can you see? Clearly see? Can you see?
Yes.
That's a petroclinoidal ligament, Gruber's ligament above the sixth nerve. Can you see? This nerve. Yes or no?
Yes, yes.
This is the sixth nerve. Okay. You can see it arising from inside the posterior fossa. Posterior fossa mein idhar hai, dekha? And that sixth nerve is coming here and it will go medial to this medial to V1. Dekha?
Yes.
On the carotid. This is the carotid. This is the C5 carotid. Okay. So sixth nerve dekha, everybody? Okay. Right. So V1, V2, V3, come, zoom out. Zoom out. Yeah, and then come down, please. So sixth nerve is seen, third nerve is seen. Okay, V1, V2, V3. Yeah, and then that is the carotid. Okay. I take that dura off, and that is the carotid. That is the carotid. Okay. C6 carotid. There. Thoda niche jana, udhar. Thoda aur niche jana. That's the carotid. Can you see? That is the carotid. Petrous carotid. You can drill off all this. All right. Will you drill it off without harming the carotid? Okay, good. Anterolateral approach. Sorry. देख लिया? हाँ?
नहीं नहीं, अरे वो मर्ज के साथ today itself, tomorrow. Any stores guys here? Anyone from stores? आएगा ना? तो मन चेक का ओ एनास्टोमोसिस अभी आज कल इंस्ट्रूमेंट्स कहाँ पे? वो घटिया वाले। क्या की?
IPS. So you will have a 6-nerve palsy. So this is why petroclival meningiomas, we used to go with, after the petrous drilling, we used to pack the inferior petrosal sinus and go on to the clivus. But these days we don't do that because we understand that that will cause a 6-nerve palsy. Okay, because the 6th nerve is in very intimate relationship with the inferior petrosal sinus. Okay, so going to the clivus on this approach may not be the correct thing. Okay. You have already exposed everything needed for a petroclival meningioma. In fact, you have exposed everything needed for a sphenopetroclival meningioma. You have to just take off a little bit of bone towards the internal auditory meatus also, and then you are done. Entire anterolateral corridor, starting from second nerve, third nerve, fourth nerve, V1, V2, V3, and then now you 6th nerve also you saw. Now, if you drill the IAM, you will see the 7th, 8th complex also. And if you drill enough down to Kawase, you will see the 9, 10, 11 also. Only now which you will not see is the 12th. I will, after Dr. Margyasi, I will these guys keep down in the
Hello, Omar.
Hello, Dr. John. How are you?
I don't
I'm
know.
fine.
We lost the screen there.
Yes, no problem. I
Yeah.
recorded. No, means I see recorded.
Yeah, I'm
How
trying
are
to
you?
get this. Good, good.
Okay.
Trying to get, let me get on the screen here.
Very nice, Alexa. I know.
Are you getting,
Now live.
do you get anything out of this? Is it useful? Is it useful?
Yes, useful. Okay.
It is
But,
useful. It's okay.
It's okay, but I need some speaking about this cadaver during working. It's better.
Okay, okay,
Okay, thank you very much for you.
okay.
Chetan sir, mic dekhi. So there is some online query from online participant.
Okay, so you're working on getting a good shot?
John,
Yes,
there was someone who wanted to talk to Chetan sir. The Dr. Chetan is here.
I'm sorry?
Right
John,
now
they
some-
have a query. They have something to ask.
I don't believe at this point, I haven't seen anything on the panel. Has anybody seen anything on the panel?
Okay. Okay.
No, we're all set.
So John, right now what we have done is we have done the anterolateral corridor, which means we have exposed the second nerve, the third nerve, the carotid, and the cavernous sinus. We've exposed the sixth nerve. We've exposed V1, V2, V3, and the gazerian ganglion. We have done a petrosectomy also and showed the C6 or the petrous carotid also we have shown. And then we are drilling towards the IAM. The neurosurgeons here, they are drilling towards the IAM. So 7th, 8th nerves will also be seen. IAM is seen? Very good, very good, very good. So they have already seen the 7th, 8th nerves. And once the petrosectomy is done, they can cut the 10th and see the 9th, 10th, 11th nerves also. So this is what we were exposing, some second nerve to 11th nerve. So once that is done, then we can, that is the anterolateral entire corridor is finished. And then tomorrow we'll go for the posterior petrosectomy, mastoidectomy and posterior petrosectomy or whatever, depending on what the boys want, we can tailor it that way. Nilesh?
Yes, sir. कराड़ में पहुंच गए थे, बाहर घूम रहे थे, कराड़ सिटी में चले गए वो।
सब लोग स्पेशल लोग हैं, इन लोग को भी तो लंच कराना है।
हाँ, उधर ही लेके जाना है।
वो पहले बस गेस्ट हाउस में अलग से किए लंच में उसको खाएगा
उधर ही हाँ।
Can I ask?
Go ahead.
For seven cranial nerve, facial nerve at petrosal pathway, if is cutting, can we resuture it, the seventh cranial nerve? The pathway is inside the petrous.
You know, I'm not sure they're listening to you. I'm not sure if anyone's there. Is anyone listening there?
I asked about the cranial nerve 7, facial nerve.
Yeah.
Is pathway inside the petrous. Okay.
Okay.
If it's cutting from trauma, can we suture the nerve?
Okay, I don't know if they're listening. Is anyone listening there?
Yes, John.
Oh, yeah, we have Omar from Syria has a comment. Go ahead, Omar.
Okay, my question is the facial nerve inside the petrous bone after trauma is cutting. Can we suture it?
Yeah, I mean, your answer is where it's a damaged facial nerve, whether you can suture
After
it.
trauma, head trauma, yes. There's bell palsy after trauma. And after multi-slice, we see a fracture of the petrous bone, okay?
Yeah, I understand your question, but
Okay.
I have never done it in my entire career. I have never done this in heterom. I have never sutured the facial nerve.
Oh, okay.
I have never even exposed it. So I really don't think I have the experience to talk
Okay.
about that actually.
I ask
sorry.
only as other question. If any compression of the facial nerve inside with sequestration, bone sequestration inside the canal of the facial nerve inside the vitreous bone, can we remove the compression, the compression of the facial nerve? Can we with this drilling the
Yes,
canal
yes.
of facial nerve? Can we?
Yes,
I put the-
theoretically, yes. Theoretically, what we are doing right
Yes.
now, I can do it through a small subtemporal window and I can completely decompress the facial nerve. But I don't
yes.
know whether that will be of help in a head injury because I don't have any experience with that.
But
So, but
I ask,
maybe there are people who has experience in decompressing the
Yes.
facial nerve.
I
And-
ask on others. I have I see this operation at 2007 at Syria, 2 microscope, eye microscope, ear microscope without surgical neurosurgical microscope. I do that after 2007. 2007 I do this operation. This I prepare for resuture the facial. It was being is compressed with sequestration bone. Sequestration bone. This is very nice. This is extradural. I do extradural. Extradural intracranial. This drilling is very nice, very easy to less the time. Okay. Thank you very much for listening.
Hang in there, Omar.
Okay.
Anup Shastri is coming only for this petroleum because he has a case of petroleum in Jama posted. So he wants to practice in 5,000 rupees. He is getting full practice.
Oh, okay, you have a question. Okay, Landry. Are you there, Landry? Maybe. Is there anyone there? I can answer a question.
Yes, I am connected.
Oh, good, good. We have a question from Landry Conan. He's a neurosurgeon from the Ivory Coast that's actually given a presentation on this channel. Anyways, Landry asked, do we need a lumbar drainage to help retracting the temporal lobe during this procedure? Did you get that? Did anybody get that? Is anybody listening? Omar, you're the only one listening.
I understand the question. We must to enter the vitreous bone and like زحف in Arabic, story without food, without I go story under the temporal loop, extradural, story, slow retraction, and the gravity to make the without just very gently to make the retraction, the temporal lobe extradural, okay, slightly, because we have we have venous drainage, you know, venous drainage on the vitreous bone, like triangle. You must to be careful during that operation. And we, as I guided the fracture, I ask about there is trauma, this fracture. We go slowly to go when we see the metastasis, where the point we must to enter with drilling. Micro drilling is very good. I haven't been drilling before. Only Carison, small Carison, and micro dissector. I do that. But the temporal loop, not nothing, and not to make too much compress because they make another operative make something. If you retraction the temporal loop, makes psychological or other things complication.
Okay, I'm not sure. Did Landry, did that answer part of your question or no? If it didn't, that's
No.
okay.
No,
Okay, go ahead.
So my question was about retracting the temporal lobe, the temporal pole, to be more precise, because as I do that, I do this procedure on cadaver. I didn't have the opportunity to do it on living patient, but
Right.
we need to retract the temporal lobe. We put some stitches on it to retract the temporal lobe. So I was wondering, when we are retracting with those stitches, will it be easier if we have the lumbar drainage to make the
Right.
brain more relaxed? That was my
Okay.
question.
Okay, can you, I don't know if you can understand, Omar. Omar, can you answer that? Did you hear the question from Landry? Maybe not. We'll see if,
Question CSF.
yeah,
What
well,
is question?
there's a language problem, Landry. I don't know if Omar understands. Let me get Dr. Nisula. Dr. Nisula, are you there? It's whoever's doing the dissection, they may have stepped away.
Dr. John,
Yes.
what's the question, please? Because the nurse comfort me not listen to this question.
Okay, well, I don't know, Landry, you want to repeat that, what you said?
Okay, yeah, I can repeat. I will go slowly.
Okay,
So
listen, Omar, listen. Omar,
Okay,
listen
okay.
to him. He's
Okay,
gonna
okay.
he's gonna speak slowly.
Okay.
Okay, go ahead, Landry.
Okay, thank you. So my question was about retracting the temporal lobe, because
Okay.
when we do this procedure on cadavers, we put some stitches on the
Yes.
temporal lobe to help retracting it.
Yes.
So when we do that on living patients, I
Yes.
guess we will need to add more strength to retract the temporal lobe. So my question was to know if we put a lumbar drainage, will it be easier to retract the temporal lobe?
Yeah,
Is it
of
something
course.
that you
Of
do
course.
or you don't need?
Of course, sir. We must to see SEB intracranial pressure to must in mind during everything. You must do
see,
the risk.
joining,
Okay, okay.
you will see the ICA joining the basilar.
Okay.
So you
Okay.
take out this bone, you will see the ICA joining the basilar. Okay. And oh, you've done some extensive drilling.
Sorry about that. Excuse,
No, this is the V3.
Wait.
This is the V3.
V3. No.
This bone, that's a petrous apex. This is yes, of course. You have left a lot of petrous apex.
Landry, we'll ask Ike later.
So this petrous apex has to go. This entire petrous. This is the cochlea will be here. Okay.
Yes.
So the cochlea you drilled off. Most cochlea also you drilled off. That's
Yes,
okay.
we see.
But you can see the ICA loop and the 7th, 8th complex. That's the 7th coming there. Can you see the 7th coming there? That is the 7th coming there. Okay, that's the lateral margin of the brainstem, and that is the 5th nerve. That is the root entry zone of the 5th nerve. Can you see? That is the root entry zone of the 5th nerve.
Excuse
That
me,
data can be removed, and well, you have a.
Ike, we have a question.
Medial extent of
Can
the
you hear me?
petrous apex.
Elevate the right Caesarean ganglion.
See, that is the Meckel's cave.
Hmm.
So, and the Meckel's cave, lateral to the Meckel's cave, you have the carotid. Okay. Lateral to the Meckel's cave, the carotid, I have drilled. See, can you see that carotid? This is the carotid. Can you see? This is a carotid canal. So this is, I am removing off the petrous apex, true petrous apex. So, and that will reveal the entire carotid. I mean, see, this is the carotid, and this carotid will turn here
Yes.
into the cavernous sinus here. That's
Yeah.
okay. So that is the foramen lacerum region, that one.
Yeah.
So this bone you have to go out, and then you will see the carotid turning here.
Yes.
Okay, and then this is the seventh eighth complex. This bone also has to go. Okay.
Yes.
So can you do that? Okay, you do that, and then you will see the entire anatomy.
This do siphon phenomena, anti-siphon phenomena. You know, anybody siphon phenomena for the carotid.
Did you hear that, Ike?
Siphon, anti-siphon phenomena for the carotid during his curving inside. I asked, when I have the second year neurosurgery, I asked my teacher, what's the siphon, anti-siphon? He don't know. I do so much doing to understand anti-siphon phenomena for this carotid, for this area. Very good for not to make blood, same level for the.
Somebody is asking me about the classification of the carotid.
I believe so.
Physiological, I speak.
Yeah, so in the classification of the carotid, think about
Yes.
three perpendicular lines.
Yes.
C3, C5, C7 from anterior to posterior. C3 is paracellular, C5 is paraclival, C7 is parapharyngeal. And then C3, if you see C3, it's paracellular. So behind C3, there is a horizontal segment. There is a horizontal intracavernous carotid. And then it connects to C5, a vertical segment, which is called the paraclival. So if you say C4, C4 is seen in the Parkinson's triangle as we just showed it. So you can see the sixth nerve. I showed you the sixth nerve, and just medial to the sixth nerve, you can see the C4 horizontal segment. And then you can see the C5, and the C5 is the paraclival segment. C6, I just drilled and showed you the C6 segment, the entire C6 segment I showed you. So, and that is the petrous segment. And behind the cochlea, in fact, anterior to the cochlea, the C6 dips into C7, and that is a parapharyngeal segment. So these are the classification. This classification is actually, it has been given in textbooks, it's been published. It is part of many textbooks actually. So it is our classification. We classified it based on the Fisher's classification, our modification of Fisher's classification. I hope that clarifies it.
So yes, come.
Good to see you. Dr. Sherian.
He is working.
Yeah, in Kolhapur. Good to see you. We should have maybe we just
Hello, Ike. Hello, Ike, are you there?
and we showed the extradural carotid, all the dural rings we removed. Then we showed the proximal distal dural ring, cavernous sinus. Then all the third nerve, fourth nerve, V1, V2, V3. Then intrapetrous carotid. And then we drilled these guys are taking it. They're enjoying.
Okay. Hello, Ike. Are you there, Ike?
Yes, John, tell me what is the matter?
We have a question that we may not have answered by Landry Conan. He's a neurosurgeon from the Ivory Coast. He says,
Yes.
do we need a lumbar drainage to help retract the temporal lobe during this procedure?
Yeah, so earlier for petroclival meningiomas, we used to put in a lumbar drain. Still, if the brain is very tight, I put in a lumbar drain. But generally what I do is, you saw that I went very near to the cisterns when I was doing the anterolateral approach. So if I open the cisterns there, it's much more easier than a lumbar drain. We get a lot much more CSF. And then after that, for petroclival meningiomas, this dissection is rather easy. So I believe now Luis Borba also does the same thing. So Luis was telling us during the last conference, now no more lumbar drains. But of course, yes, if there is a tight brain and cisternal access is not difficult, it's unnecessary sometimes. So if that is the case, then we put in a lumbar drain and then we go ahead and do the dissection.
Well,
Yes.
like you're showing me that you can interact with the remote audience and answer questions in real time during a dissection.
That's excellent.
During a
From
dissection.
all over the world, we are doing that. So that's pretty good. My regards to Landry. I was in Ivory Coast in 2013. I went to the world's largest
I
cathedral.
remember.
You remember? I was there in
Yes,
2013,
I
7 years
remember.
back. I was there. I had given a lecture, but
Yeah.
everything was in French. So, but still we gave a lecture. And Gilbert Deschamenoy, he is a very close friend.
Yes, thank you. I will remember.
This is our chapter.
So you answered my question, but you said you opened the system, but at which level? Because this procedure is mainly extradural. Do you open at the level of the optic nerve, or do you open it when you open the tent?
Yes. I open at the level of the optic nerve, because when I do this procedure, I generally don't come from subtemporal. I come from anterolateral corridor. I do a clinoidectomy and then I go posterior. So same way as Ali from Arkansas does it. So whenever we are doing these petroclivals or whenever we are doing these basilars or anything, we come all the way from anterolateral corridor. So there I can open the cisterns very easily, just like we do in cisternostomies. So we open and then we come back and open the cisterns, the brain will be very lax. So once we don't need to open extensively also, a small dural opening is enough, and then we can open the cisterns.
Yes.
Okay, thank you. I understand now. Thank you.
Right.
Any who doing can speak what we do, what he search, why he is better for the others, please.
Can you understand that?
I understand for the others to understand what's the microsurgical anatomy here.
Medtronic.
Hey, what you do like this, okay. Not for me, it's for others. Other colleagues. Every step, the resident to know what we always make these things. I like French school.
Oh, really?
Speak
You know
more.
French? You know French?
French school. Speak more. Every step to make the discuss what I do this, how I do this. It's better.
Abhinav sir, we have to take the microscope to other cadavers. Let's go. Anyone from the anatomy department here? Deepak Mama. दुसरं कोणच नाहीये. ते मायक्रोस्कोप तिकडे शिफ्ट करायचं.
Does anybody have any questions in the panel?
इकडे या पहिल्या कॅडेवरला.
I've already showed that he can answer questions in real time on an anatomy dissection. which is a big step.
Dr. John,
Yes.
Dr. John, for this patient alive, not cadaver, we must prepare ourselves good anesthesia, lumbar drainage. But,
हमें just चालू के लिए department fully चालू नहीं है.
can I speak? Can I speak, Dr. John?
Well, you know, I'm sorry, Omar, I don't understand.
No. I asking for this is cadaver. About live patient, we must prepare good anesthesia, good relationship between surgeon and good anesthesia doctor, and drainage, lumbar drainage, and to prepare everything before the operation, surgery. Okay.
Okay, I'm sorry, I didn't understand you. Does anybody understand, Omar, that can answer the question? I don't know, Omar.
Okay, thank you.
Okay. Okay, there's a lab set up. There they are in Karad with the soon-to-be world-class anatomy lab. This is just a temporary setup from Karad, from Krishna Institute of Neuroscience in Karad, India, south of Mumbai. I'm told about 8 hours driving, southern India. And there is the overhead cam setup they got. They fashioned together. Are you there, Dr. Nisla? You probably could explain it. You see that camera? Because that looks like it's probably part of another. Oh wait, is that the microscope? I guess that is a microscope, right? What is that? Oh, what machine is that? I'm not a neurosurgeon. I see some lenses. It looks like it's. Oh, we're getting an unofficial tour. Oh, there's another cadaver. These are popping up everywhere. And that's the overhead cam. This is exciting, everybody, because this could be the lab that educates the third world of neurosurgery. This could be the lab. Look at that picture. I mean, to have, Ike, are you there, Dr. Nisla, anybody there? But to have a picture like that to interactively show in real time with the ability of you panelists to ask questions. This is big. You know, I don't know how many people listening to me have been to an anatomy lab. There's not many neuroanatomy labs around. They need a good refrigeration system. All cadaver labs, naturally, it stands to reason. If you're going to have cadavers around, they have to be preserved in formaldehyde or whatever preservative liquid they use nowadays. I think it's formaldehyde, but they need to keep the cadavers relatively low temperature so they don't degrade. Oh, okay. Nada, thank you. Okay, I see your input. Does anybody else have questions? Because let me see if I can get a hold of, is anybody, Nisla, are you there? Let me text them here. Because does anybody want to have any questions they want to ask?
बोलो.
Yeah, hello, is anybody there?
Yes, John.
Oh, good. So you can answer questions?
काय झालं? चालू होत नाहीये.
Can you answer questions now?
हाँ का अभी चेरियन से नहीं है बोलना उसमें. लाइट चालू करेगा तो चालू होगा ना.
I don't think they're ready to. Is anybody ready to answer
सर
questions?
गए उधर
कहाँ?
खाना खाने गए.
खाना-
जाना जाना है
हाँ, मैं-
मतलब
मैं-
आप जाओ.
अच्छा उधर कौन है और जाके सर और
माजक के सर है, रोहिदास सर है,
किसके साथ ही है?
अभी निकल गए, अभी जस्ट लिफ्ट में ही होंगे. क्या हुआ? खाना वगैरह था? अभी एक एक करके जाओ, खाना खा के जाओ. Yes.
So उद्याला इथे असेल
उद्या इथंच.
आणि असंच वर्कशॉप काढावं एनाटॉमी झालं का
उद्या एनाटॉमी नाही आहे, एंडोस्कोप आहे आणि स्पाइन आहे.
स्पाइन त्याप्रमाणे available आहे.
हम्म, हम्म, हम्म. We will start winding this up. We'll have to vacate this hall at 2:30. कोण आहे इकडं? आहे ना, 1-2 मुले. एकाला थांबवा कोणाला तरी इथं. कुठं लागतंय? वॅकन्सी भरपूर आहेत रे. तू ये इथं. आपल्याकडे अजून मोठं बनवायचं आहे, आपल्याला मोठं हॉस्पिटल बनायचं.
पूरा न्यूरो का बिल्डिंग है.
नहीं नहीं, ये तो एनाटॉमी का बिल्डिंग है. न्यूरो बिल्डिंग बनेगा और
खाली एनाटॉमी का बिल्डिंग है.
ये फर्स्ट ईयर कॉलेज बिल्डिंग.
कॉलेज.
अरे अद्वैत, वो प्रिंट आउट आया क्या? अरे फोन कर उसको. अरे तो नहीं तो मुझे को तो प्रिंट आउट लेके आ. 2 बजे चालू हो जाएगी लेक्चर. ते प्रिंटर ठीक है.
Hello, is anybody watching this with me? And perhaps you panelists can help me because we're trying to structure this so that it's a good learning experience for you, the panelists, as well as people watching it on the internet. Now, is this valuable to you, or it's not really worth it? Can any of you panelists tell me? Hello, panelists, could you please help me?
For this level of magnification, it's not really useful. We don't see well what they are doing from this angle of view too.
Okay, so it doesn't help that much?
Yes, it doesn't help.
Hey, hi John.
Yes.
Yeah, right now we are going for the lunch, short break for the lunch, and we will come back at 2 o'clock with the live lectures.
Okay, well, you're coming back in how many minutes and how long? An hour
In 15 minutes we are coming back.
to the lectures.
Yeah.
Okay, we'll be here.
Yes. Thank you.
Okay, we had some feedback. Can you answer the feedback, or do you have time or no? Okay, what did you say about the magnification again? Whoever said that, could you please identify yourself?
Yeah, it was me, Landry. I said at this level of
Oh,
magnification.
yeah. I just want to hear your constructive criticism. You're saying the
Okay.
resolution is not good enough now?
Now, yes. To
Okay,
see.
okay, let me see if we can improve that. Hello, Dr. Nisla, are you there? That's something we'll work on maybe. Okay, Dr. Landry? what I'd like to do, Dr. Landry and others, is that I'd like to get on the screen like we are now and then say, hey, try this. You know what I mean? We need to have a session so that we can make it valuable to someone watching. And we'll get together with someone sometime, okay?
Okay.
And maybe get an interactive session, and we can mention, you know, that no, this is good, this is not good. You know what I mean? I have a feeling we'll have to do this later. I guess
Yes.
we have lectures in 15 minutes,
Okay.
everybody. And I'll actually put the,
So even actually, I don't really know if they are working on the orbital roof on the subfrontal side, or if they're working on the temporal side. It's hard to see. I think one of the suggestion that I can do is every time we go back to the dissection, they should tell us where is the anterior side, where is the frontal side, where is the temporal side, just to orient people.
okay, Omar, there's the schedule. Can everybody see the schedule?
Okay, I see. Must take picture for this.
Okay, this is the schedule, Omar.
Okay, see.
Okay,
I see.
it's 2 o'clock, Dr. Servadai.
2 o'clock GMT.
Yeah,
GMT. I see that for
he's the president of the WNSS. So that starts at 2 o'clock, and then Dr. Kato, Dr. Hernes Niemi,
Okay,
Dr. Borba, Dr. Benez.
Yes,
It's
yes.
quite a lineup.
Very nice. But as a schedule, please can you send to the messenger to me, Dr. John, messenger, the schedule with GMT.
Okay,
You can.
what do you want by messenger? What are you sending me?
Messenger. As I said, send me the schedule to the messenger with
okay.
GMT.
So yeah, okay.
GMT, not to 4 time.
Yeah. Let me send you the schedule.
We are at Syria, you know. We are 2 GMT now, 2 GMT at winter time, summer 3 GMT. Can I go? I have so many patients now.
No, I'm gonna send this to you now, okay?
I can go, okay. Thank you very much.
Okay,
So
I'll
many
see you
patients
then. See you
waiting.
later.
Thank you very much for you. Thank you.
Okay.
Thank you very much for all.
I send you the schedule.
Okay. I'm ready. Thank you. Bye-bye.
Yeah, bye.
Goodbye. Allah bless you. Allah bless you, Doctor.
Okay, camera's back. Hello? Is there anybody there? We're just gonna hang out in the room with cadavers.
Hello.
Hello?
Yeah, hi, I'm Sanjeev. I'm Dr. Sanjeev from Nobel, Viratnagar.
Good afternoon. How are you?
Good afternoon, sir. Good afternoon.
Okay,
I'm
so, okay, so we have, what's the schedule? We have time now? What are we doing now? Hello?
Hello, sir. I think I'm also just a participant. I have joined from Viratnagar.
Okay, so we're waiting for the lectures to start, right?
Yes, yes. I'm waiting for somebody to speak out from there. From
Oh,
Karad.
okay, so we'll just wait, that will be starting shortly?
Correct, sir.
Yeah, okay.
Somebody is dissecting, but I think they are not describing what they are doing, right?
Yeah, I don't, we really can't see too much. I don't know if it's useful at all. There's Dr. Dio Pujari.
Okay.
Hello, Vlad. And Dr. Kato and Dr. Dio Pujari. I believe we start in about 10 minutes.
Hello.
10 minutes.
Yeah.
How are you?
Thanks, John.
Who's there? Who's that?
Dev Pujari.
Hey, Dr. Dio Pujari, how you doing?
I'm good. I'll join you soon.
Okay, we recorded your other conference.
なんかこういう作業は非常にやりにくいんだよね。いや、結果一緒なので。
We're waiting for the moderator. Hello, Dr. Thacker.
Yeah, hello. Hello, John. Hello.
How you doing? You're in the lab now, it looks like, right?
Yeah, I'm in my lab, right?
Yeah, you can say hi to Dr. Dio Pujari. Dr. Kato is there, correct, I think? And when are we starting and who's going to be the first lecture? Are we starting with the regular program? Let me get it up here. Okay, beautiful.
どうしちゃった
Let me get the schedule. Can you see the schedule okay?
Hi, how are you? John?
Hi, Dr. Kato, how you doing?
I'm fine, thanks. Thank you very much for yesterday also.
Okay, we have the schedule up here. This at 2:00, correct? Dr. Servadai is lecturing,
Yes,
and then Dr. Kato at 2:15, correct?
yes, right.
Okay, and then Dr. Hernandez-Yemi.
So what time is it now?
Right now, it's 4:30 in Miami. I believe it's around 2:00 in India, correct?
Okay, so my lecture will be at the start in 15 minutes.
Yeah, let me check with the people there. Are you there, or Dr. Nesala, are you there? Before you go away. I don't know.
ちょっと今少しまだ時間があるので。
Is Dr. Who's going to moderate? Dr. Thacker, you're going to moderate? Well, just hang in there,
Not
Dr.
really, sir.
Kato, for
I'm-
instructions. I imagine I'm just going to moderate, right? I'm just hanging on, Dr. Kato. Don't know what's going on. Oh, it's time to start. Yeah, according to the schedule.
COVID patient. So you will not be compensated. You will not get. Because you are, government has told you to start to see the normal patient. अभी उसको कैसे समझाए कोई कोविड पेशेंट आएगा तो पहले किधर जाएगा तो हवा में लिखा हुआ नहीं रहता उसके फेस के ऊपर कि उसका कोविड है और चलिए वो तो देखिए ना क्लिनिक में जाएगा ना बाद में वो डायग्नोस कौन करेगा पेशेंट को समझ से हर एक पेशेंट को तो नहीं कोविड है वाला कोविड नहीं है तो बच्चे वाला रिपोर्ट भेजो 8 तारीख की रिपोर्ट बोलती है कोविड नहीं कल रात को पूरी कोई हॉस्पिटल में बेड नहीं मिल रहा नहीं मिल रहा नहीं बेड कोई हॉस्पिटल में नहीं है माय सन-इन-लॉ इज अटैच्ड टू 4 हॉस्पिटल तो उधर सीधे भी अभी चेक में खुली उधर पगला उधर आ फिर उसको उधर करके पेशेंट को भी एडजस्ट करके क्या 2 बेड क्या भी बेड नहीं गवर्नमेंट ऑफ स्कूल टू स्टार्ट द क्लिनिक
Hello, Ike, are you there?
Good evening, Dr. Kato.
how are you?
I am good. Thank you very much.
How are you? Thank you very much for your educational activity. Thank you very much, especially the endoscope.
No, thanks. We unfortunately are into another wave of corona. Our
Oh,
state is very badly involved right now.
really? So
Yeah,
is it a third wave or fourth wave? Is it a third wave or fourth wave?
No, the first thing went away about 4 or 5 months ago, and there was a good period of about 3 months. And suddenly this month things have started getting worse.
Oh, bad.
Most doctors are vaccinated, but it is still not a good atmosphere.
So what is the cause? Maybe some
Really
virus
don't
change?
know. I think young people have been completely indisciplined, and you know, this is the time of social gatherings, the wedding season, and all that. So
Yeah, right. So Japan is the same, but just today we finished the lockdown. So from tomorrow, yes, but we are very worrying about the fourth wave.
we are probably going in lockdown from tomorrow or day after. That's what the government says. Let's see what happens.
Oh, I see. Okay. But you look very fine.
Yes, so far. Okay.
In Miami, the beaches are full.
Oh, okay. Fourth.
No social distancing.
Okay. So when we can start traveling, how do you think about? So face-to-face education, how do you think? When we can start?
Wow, that will be a while.
Hello, everyone.
I'm seriously not sure what is happening. Colombia.
Yeah, Latin America is really getting hit hard.
Oh, I see.
Yeah, Mexico is really getting hit hard.
Oh, I see. So Vladimir, thank you very much for your chair. Thank you so much. Thank you.
Welcome.
So, but the glioma topic is really difficult.
It was difficult to understand. Gliomas are not my topic. It was not easy.
Good morning, Vlad.
Good morning. How are you?
Okay. Not a good time still.
No, not at all. Yeah, locked down.
Oh, I see.
Dr. Kato would probably tell us what is happening to. Are we going to Colombia at all?
Colombia is a big conference?
The World Congress.
Oh, okay. When is that?
End of August.
End of August? So it's planned now for in-person conference? I haven't heard too much about Colombia. I'm not sure how it is. We're waiting for Dr. Nisla to come. I think we can start.
Is Dr. Sarvedi already with us?
I don't see him in here yet. Because I think we could start now with Dr. Kato. She's here. Let me check with the moderator, Dr. Nisla.
So what time the Czech, Vladimir? What time is it now?
9:30.
9:30 in the morning.
AM.
AM. Okay.
Yeah.
Japan is 5:45 PM.
Quite ahead of us.
Yes, right.
How is Japan, Yoko?
What?
How is Japan now?
Japan is just the start of the spring. Now we have a start of the blooming of the cherry blossom.
Oh, good. Hera, you're here. Hera. Hello, Hera? Maybe not. Because we can start now. We should start. Because everyone's here. Hello, Hera, are you there? Oh, no, it's not answering.
So usually this time is the best season to visit to Japan.
For us too. Well, we still have freezing during the night and we still have some snow in the garden. So it's quite cold this year.
Oh,
But,
I see.
otherwise, this is spring, the best time of year, the same as for you.
I never been to Prague.
Yeah.
So I must visit your place, I think. I want to see your father.
Oh, he was 100 in January, and he is still doing reasonably well.
Wow.
Incredible.
Congratulations.
Thank you.
So you can be maybe 120 years old.
I wouldn't like that. It's too much.
We all hope so.
Yeah. You'll see.
Mm-hmm.
Hi, John.
Oh, good, Hera. Good.
Hi, Hera.
Hello,
How are you?
Professor Kato. How are you?
Hi, how are you? Everything fine?
Okay, Hera, you ready to start? Ready to start, Hera? Are you going to moderate, Hera?
Yeah, I'll try my best as long as I'm up.
We might as well because Dr. Kato's here, Dr. Srivade's not here, but we could start, right?
Yeah, yeah.
Yeah, okay, so we'll start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, go.
Hello, everyone. Welcome to the Neurosurgery Coach meeting hosted by Krishna Institute of Medical Sciences by Professor Cherian and his team. We would like to start off our session and invite Professor Yoko Kato, who is the president of the Asian Congress of Neurological Surgeons, to give us the opening address. Madam, please start.
Thank you, Hera. So I really wanted to see you for last 2 years. So I'm very happy to see your face. You haven't changed at all. So even you had a beautiful the girl. Congratulations.
Thank you so much.
Yes. So I think I don't see the Dr. Ipe face, but even I congratulate Dr. Ipe to lead the new place, the Krishna Institute of the Medical Science. I saw the pictures, so many pictures of the university, but it's huge and it's very beautiful and modern. And I think he can do as many as possible he wants, I think. And also he has such kind of ability, and also he can lead not only the neurosurgical daily work, but also in a scientific aspect, I think. And also he stressed every time he wanted to educate more and more for young doctors in the world, I think. Especially he has a special interest of the anatomy with Dr. Vladimir Benesh and Imad Cannon. And I think he has a strong will, and also that he has a great ability to perform. I think he can follow his dream in next few years, I think. So as a fellowship, maybe we can collaborate. We can support him and also exchange the student and also the young doctors after Corona, the period, I think. So anyway, my great congratulations to the IPE, the stay at the new place, and wish him and his great team has continued his successful his dream in the future. I thank you very much for your kind invitation. And also the Hira, you do your best for the medical student and the resident and the young doctors. Thank you so much. And also, can I share the several slides? If there
Yes,
is,
please, ma'am. Yes, please.
yeah. So when I visit the India, his place, he has a great family, the beautiful wife, and also the two daughters. The first daughter's name is Yoko. I don't know what's the meaning in the Indian name. The meaning I don't know, but anyway, he has. He seems very happy with the family. Sorry. I'm sorry because cannot be.
You can't change it?
I cannot. Oh, I can change it.
You might have to start again. Start it again. Yeah.
Once again?
Yeah, start again. Try that.
Hi, John. Can you hear us?
Okay, so it cannot be. Anyway, so I visit. I was invited by Hira for the gathering of the medical students. More than I think 100. It was really a nice meeting, and the day it will hold the next generation, next few the decade. So I think we can educate them. I think it's great our mission, and in that means I think the Dr. Ive can lead such a field. I think. Thank you very much, Dr. Ive. All the best. Thank you. Thank you so much.
Thank you so much, Professor Gato. It's an honor to have you with us and have your support in every project we do. And we would like to have the same in the future projects also.
Yeah, madam, thank you. I remember being in Fujita in 2007 as a fellow. I remember learning the basics of aneurysm surgery. So you will always remain, you and Sano Sensei will always remain to be our teachers. We've learned all the important tenets of microneurosurgery from you. And I must say that tenure there really changed our lives. So thank you very much. We are indebted to you. All the teaching that you've done all over the world, this is what inspires us. So thank you very much.
Thank you.
And I'm glad to see all my friends here, Vlad Banesh and rest of everybody here who's joined in. Thank you very much. And I hope we had the cadaver session right now. We really enjoyed it. I hope the boys enjoyed it, but I really enjoyed it. And
hello, Dr. Yoki Kato. How are you?
Yeah. So we hope to have a academic feast over the next 2 days. And we hope to do this much more frequently. We have some very good spine surgeons and vascular surgeons amongst us, local faculty. So we hope to keep on improving, keep on learning, and make sure we set the bar higher from India. Thank you very much.
Hello. The next talk is from Dr. Franco Sarvadi. Is he joined here? Okay. David. Sir, yeah. You share with me, sir. I will send it.
What are we trying to do?
I don't think we have Professor Franco with us, Dr. Nilesh.
Yeah, he's
Okay.
joined it.
He's not here yet.
Okay, he has sent a message on the Professor Ipe's phone. So we are
All
sending
right.
that. Yeah. We are,
What are we doing here?
yeah.
John,
Professor
we have a
Franco
message.
Sarvadi hai.
Yeah, we have a message by Professor Franco Servadai, and it's with Professor Ipe Cherian. So he's going to present it from his phone.
I just sending you a welcome message to this important meeting organized by my friend Dr. Cherian and supported by the ASEAN Neurosurgical Society with its president, our president, Professor Yoko Kato. In these difficult times, we learned that we can keep our educational efforts alive by using a form of live streaming.
I'm sorry here, we're not getting the presentation.
YouTube, webinar platforms, meeting platforms, anything.
Okay.
The worst part of our life now, fighting this pandemic, has found at least one positive aspect. These webinars can reach neurosurgeons all over the world, even in countries where we have limited resources, where before it was impossible to attend Congress and meeting. So I wish Cherian's Institute and Cherian's meeting all the best. Please attend this meeting with attention for our neurosurgical education. Hello to everyone. Stay safe. All the best.
Thank you, Franco. Thank you for that message. We go on with the next speaker.
So Professor Goel is here. He has already logged in. Yes, yes. And Dr. Dev Puja is also here.
Yes, yes. So all the big teachers are around. I am still a little bit upset that Professor Goel couldn't make it here. We would have loved to have him here, but there's always a next time. And I know with the corona and everything is difficult. So let's see.
Dr. Goel is here.
We are waiting for his message as well as Dr. Dipujari's message.
Professor Goel, so we are waiting for your message opening.
My message is that I can see the hall, I can see the beautiful auditorium, and I can see I am sure it will be a wonderful symposium.
We're getting a lot of feedback from your system.
Can you hear us, English?
Yes, sir. We can hear you, sir.
Yeah, so I'm just watching, let's do it. And I'm watching your show. And thank you for inviting me. I'm sorry could not come. But next time will be very soon.
Okay, Dr. Goel, you should be okay, Dr. Goel.
Yeah.
Okay, it should be okay. Okay, go ahead.
Okay. So my best wishes to Ipe and his entire team. And I'm sure this will be a great meeting, and we look forward to more wonderful work from Aip and his other partners in Krishna, in God. And this will be a great place for Aip to launch to greater and greater heights. My best wishes to all of you and to Aip in particular. Thank you.
Okay, John, we have Professor Yuha. He's trying to connect, and there are some technical issues on his side, but he's trying to connect. So can we just wait for a moment for him to join us?
Hello, John.
Yes.
Can you hear us? I think Professor Goel wants to talk something. You have muted him. Can you unmute her?
He has to unmute himself. I can ask him to unmute, but he's not unmuting. He has to unmute.
Professor Goel is talking next.
We're just having trouble unmuting him. I can't unmute him.
Yuha is logged in.
No, he's trying to. He's not able to get to the webinar. He's trying. He's online right now on WhatsApp, and he's trying now.
John, can you sort this out, please? Because a lot of people are unable to log in.
Yeah, Atul, let's take care of Atul first. We can't unmute him. Is anybody in contact with Dr. Goel?
Yeah, John, actually Professor Yuha is trying to log in, but the error he's getting is that the webinar is over. So he's not able to join.
Okay.
Yeah, can you sort
Okay, yeah.
And John, this is many speakers are complaining about same thing. They are not able to log in this webinar.
Really? Okay. Okay, I'm going to give another link.
The link you all shared the two links. Both the links are not working.
John, is it possible to send the direct Zoom ID and the link so that they can join us without the registration?
I think Professor Goel is unmuted.
Professor Goel is unmuted now.
Okay, John, my dear John, should I?
Yeah, go ahead. Go ahead, Atul.
Okay. Let me just, because I can see that. Okay. Can you see my slide? Hello?
Yes, well, we can see your slide.
Okay. So I'm going to talk on trigeminal neurinomas, okay? And trigeminal neurinomas are real skull-based tumors, and they are wonderful tumors. They are benign tumors located right in the skull base. And we have a very philosophical approach to remove these tumors. Just let me get my internet sorted out a little bit. Just give me one. Connection on today or no?
Yeah, we can see your screen, sir.
We can see your
Okay.
screen.
Okay, so this is carotid artery, this is trigeminal nerve, and this trigeminal nerve has been split. So we have to know the anatomy of the skull base, anatomy of the trigeminal nerve, Gasserian ganglion, carotid artery, skull base, and things like that to be able to remove these benign tumors beautifully. So trigeminal neurinomas are relatively rare. In neurinomas, they are second only to acoustic tumors. And quite rarely, they are associated with NF2, neurofibromatosis, as we know. In the year 2002, I had presented this article. 2002, I had presented 73 cases, which was the largest series at that time. And in the year 2017, I had analyzed my cases, and there were 260 cases in 2017. Now my series is beyond 300 without any doubt. So this is the largest series of trigeminal neurinomas. And this article of mine was, I will consider, one of the most beautiful articles on the subject. In this article, it was mentioned for the first time in the literature as a series that you can operate on trigeminal neurinomas and you can improve the trigeminal function, the sensation of the face after surgery. So this was the first article. In this article, it was mentioned that the trigeminal neurinomas arise in the region of Gasserian ganglion in the Meckel's cave. So these were two very important things that were discussed in this article. And also in this article, it was mentioned for the first time in the literature, the dural relationships of trigeminal neurinomas. So this article I consider as very important article on the subject, and it has been cited nearly 300 times in the literature. So this is the slide provided by my resident and now my colleague, Dr. Sukhdeep Jhawar. So this is trigeminal nerve over the petrous apex. Here is the Gasserian ganglion, V1, V2, and V3 divisions of the trigeminal nerve. Trigeminal nerve is located in the lateral wall of cavernous sinus. The V1 and V2 divisions and V3 division parts the company of cavernous sinus right in the beginning after the Gasserian ganglion emerges. So this is the third nerve, the fourth nerve, V1 division, V2 division, and V3 division is not in the lateral wall of the cavernous sinus. And this is the sixth cranial nerve, which is located right inside the cavernous sinus. In the middle fossa, the trigeminal neurinomas are of three types. One is when it is located primarily in the middle cranial fossa. So this is type A trigeminal neurinoma. We had described that these tumors are located entirely within the confines of the dura of the lateral wall of the cavernous sinus. So this tumor is located within the dura of the lateral wall of the cavernous sinus or is located interdural in location. So that is very important for the surgical issues, but because when we talk of interdural location, the cavernous sinus is lateral to the tumor and to the dura. Carotid artery is away and the dura separates the tumor from cavernous sinus and from carotid artery. So this location, interdural location, is a very critical location of these tumors. When the tumor is located entirely in the posterior cranial fossa, so this is another type of tumor. One is in the middle fossa and one is entirely within the posterior cranial fossa. More often, these tumors are dumbbell shaped in the middle fossa and in the posterior cranial fossa, both these dumbbell shaped tumors. So this is also a very common form of trigeminal neurinoma. So this dumbbell shaped. We had described that this middle fossa part of the tumor is interdural in location. In that paper in 2003, we had suggested that the posterior fossa component of the tumor is intradural or subarachnoid in location like acoustic neurinomas. But now we have realized that on several occasions, even the posterior fossa part of the tumor is interdural in location. So essentially, the entire tumor is covered with dura. Middle fossa component and the posterior fossa component both are interdural or within the confines of the dura. So this is the middle fossa part of the tumor. This is the posterior fossa part of the tumor. This is also not always, but frequently located interdural. And tumors which are extracranial also, this is the fourth part. One is either only in the middle fossa, only in the posterior fossa, dumbbell shaped, and the tumors which go in multiple compartments like extracranial tumors. When the tumor is extracranial in location, the posterior fossa component is almost certainly interdural in location. So this is maybe small middle fossa, large posterior fossa. These are extracranial extension. You see, this is extending along the V1 division of the trigeminal nerve.
Hello, Dr. Nisula.
Hello? John, you said something?
Hello.
Yeah, you said something, John?
John, unmute.
Okay, so these tumors may extend along the V1 division of the trigeminal nerve, along the lacrimal division. This was the first time we described such a, yeah?
John, the link has expired.
No. Okay, there's a link.
Hello?
There's a link now. I'm sending you. I've sent you. It's not expired.
John, is there any problem in the...
You see the link I sent you?
Hello.
Yeah, I sent you a link.
John. Okay, okay. Right, right.
Okay, use that link, okay?
John? John, can you hear me?
Sir, please continue.
So you are able to hear now, Nilesh?
Yes, sir, we are hearing you.
Can hear you, Atul. Go ahead.
Okay, sorry. So these tumors can go along the lacrimal or the V1 division of the trigeminal nerve. So this was a rare kind of a, location that we described earlier. This tumor can go along the V2 division. You see along the foramen rotundum by the side of the teeth, this is V2 division of the trigeminal nerve. And this is a tumor along the V3 division of the trigeminal nerve along the foramen ovale. So the issue is, what we said is that these tumors arise in the region of Meckel's cave. They can go in the posterior fossa in a form of dumbbell shape, or in the extracranial compartment. But whenever there is an extracranial compartment, there is always a middle fossa component always. The other thing that we mentioned is that even the extracranial compartment tumor is within the dural confines. So this is a very important surgical thing that we discussed, that extracranial part of the tumor is also interdural in location. So in my paper, this was the size distribution. As you can see, type A is only middle fossa, type B is only posterior fossa, type C is dumbbell shaped, and type D is when there is an extracranial compartment extension. So these are the percentages of these kind of tumors. Trigeminal neurinomas can be small and trigeminal neurinomas can be huge. More important is they have very characteristic presenting features. When there is predominance of numbness of the face and when there is predominance of the wasting of the temporalis and masseter muscles, these are more likely to be trigeminal neurinomas in this location. So where they have very characteristic clinical features. They can be quite huge and necrotic in nature. You see this necrotic and huge, but this is a trigeminal neurinoma by the characteristic and classical presenting features. So they can be huge dumbbell-shaped tumors like this. So size-wise, you can see many of my tumors were quite big, more than 6 centimeters, 4 to 6 centimeters, and small tumors were relatively less frequent. The other very important features of trigeminal neurinoma is they can be cystic in nature. You see, this is a trigeminal neurinoma where the middle fossa component is bright and posterior fossa component is dark. So cysts of multiple intensities. So this is usually found in craniopharyngiomas, this kind of multiple intensities of tumor, but even trigeminal neurinomas can have this kind of intensities. The other thing is that trigeminal neurinoma, the cyst can have a fluid level. You see a fluid level within the cyst? And these kind of schwannomas can frequently have fluid levels. And this is another beautiful tumor where you can see multiple fluid levels. There is a fluid level here, there is a fluid level here, there is a fluid level in the middle fossa component. So this dumbbell-shaped tumor having multiple cysts with fluid levels, and all the cysts are having levels. And these are very classical of schwannomas. And this is another huge trigeminal schwannoma. And if you see it carefully, there are multiple cysts in the tumor, and all the cysts have fluid levels. You see this fluid level, fluid level, fluid level, fluid level, fluid level. So there are multiple fluid levels. Trigeminal neurinomas can be bilateral. You see bilateral trigeminal neurinomas, and this is more common in NF2 situation. Not more common, they are always associated with NF2. This is another fantastic trigeminal neurinoma in an NF2 patient. You see there is a huge acoustic tumor and there is a trigeminal schwannoma, and both are almost touching each other. So these are, unbelievable kind of tumors. And these kind of unbelievable things are usually seen in NF2 patients. So this is NF2. This is another NF2 patient in which you will see various cranial nerve schwannomas. Like this is 7th nerve schwannoma. There is a 6th nerve schwannoma. There is a 4th nerve schwannoma. There is also a 6th nerve schwannoma, and there is a 5th nerve schwannoma. So there are multiple schwannomas in an NF2 patient. This is another very extremely rare kind of situation where trigeminal neurinoma has ossification. You see, there is bone formation in the tumor. So ossification in a trigeminal neurinoma has never been reported, and we have reported in my series 6 cases of trigeminal neurinomas with ossification. This is another very interesting case of trigeminal schwannoma. This is trigeminal schwannoma associated with another tumor in the retroorbital region. And this tumor was a hemangiopericytoma, and this tumor was a schwannoma. So there are two tumors, and both are relatively, hemangiopericytoma is of course a malignant tumor. This patient was blind in this eye, and this eye, as you can see, is completely bulging out of the socket. And this was first removed, and then this was removed. You can see this is a vascular tumor, hemangiopericytoma. This tumor was removed first, retroorbital, and then this schwannoma was removed, and both the tumors are removed in this slide. And this patient now, after several years of surgery, is completely asymptomatic, no radiation, nothing. Eyeball was intact. And when I saw this patient, the patient was in plastic surgery, and they were about to remove the eyeball with the tumor. So we not only saved the patient eyeball, but also we saved his face. Of course, the vision was, he was still blind in this eye. More common, these tumors are in middle age, rarely in very young people, and very rarely in older age group. So middle age from 21 to 40 is the more predominant age group of these tumors. Diagnosis of these tumors is very essential to make preoperatively, because preoperatively you have to know that you are operating on a trigeminal neurinoma. So they have very characteristic clinical features, characteristic symptoms of trigeminal nerve involvement, like numbness in the distribution of the fifth nerve, wasting of the temporalis and masseter muscles are very characteristic form of presentation in trigeminal neurinomas. We had identified pathological laughter in these kind of dumbbell-shaped tumors, and I had reported 4 cases, and now I am having at least 8 or 9 cases where the patient had pathological laughter. Like you see pathological laughter in hypothalamic hamartomas, but pathological laughter in trigeminal neurinomas can also be a very dominant presenting symptom. They have very characteristic anatomical relationship, and these are very important for us to understand if we have to decide and devise a surgical strategy. Trigeminal neurinomas are located, trigeminal nerve is located right in the petrous apex in the floor of middle fossa. It is covered by very thick layer of middle fossa dura, that is one thing. And second thing is, it is the entire trigeminal nerve, the Gasserian ganglion, has its own discrete dural membrane. So middle fossa has 2 dural membranes. One is middle fossa dura, and the second is dura of the trigeminal nerve. And the dura of the 3rd and 4th nerves are also discrete. So this discrete form of dural understanding is very important, because no matter how big the tumors become, they remain within the dural confines or within the dura. Surgery on trigeminal neurinoma, if you know, many of the people in the audience are obviously very young. Trigeminal neurinomas were not operated frequently about 30 years ago. They were not actually diagnosed properly before the MRI came into being. And even in the years 1980, 85, 89, 90, when skull-base surgery was actually born and came into being and existence, trigeminal neurinoma surgery developed and evolved, and ultimately, as you all know, it has thrived, and it has become one of the most favorite surgeries for a skull-base surgeon. In the year 1992, we operated this case. At that time, all these trigeminal, these large and huge trigeminal neurinomas were very difficult to diagnose, and all these tumors were operated in 2 stages. Actually, 1 stage surgery was first introduced by Leonard Mallis early in 1980s. Then, of course, various skull-based surgeons came into picture, and one-stage approach became the most preferred approach for these tumors. So this tumor I operated in the year 1992, about 28 or 29 years ago. And we removed first this middle fossa component, and then we removed this posterior fossa component, and this was removed in 1992. This was another tumor I removed in 1992. The strategy was the larger tumor was first removed, and then the smaller tumor was removed. See, this tumor, the middle fossa component of the tumor was removed in a second stage, and this was removed, both were removed as a two-stage surgery. But when the anatomy of this area developed, understanding of the skull-based surgery, understanding of the petrous apex evolved, these tumors were then removed in single stage, and our own contributions to the field of trigeminal neurinomas, I will say without hesitation, has contributed significantly in the development of surgery of trigeminal neurinomas. We said earlier that in the middle fossa component, you play with the dura. We remain with the inside the dura, play with the dura, and remove the tumor. Posterior fossa component, in the year 2003, we said that you play with the dura and play with the arachnoid because they are located in a subarachnoid location. So this was the initial picture. This is trigeminal nerve. You see, this is the Meckel's cave. There is a lake of CSF in the Meckel's cave. This is the Gasserian ganglion, V1, V2, V3. Majority of these tumors are, many of these tumors are middle fossa tumors. They remain within the dura. Tumors, when they go in the posterior cranial fossa, they have discrete anatomical situation. So we understood the dural anatomy. We approached the middle fossa tumors extradurally. We approached the cavernous sinus tumor extradurally, and we approached the trigeminal neurinomas interdurally. And all these things were discussed in my book, which we presented in the year 1996. And many of the articles of mine in this book are focused on the subject of dura. And the dura is the mother of brain. In the year 1995, for trigeminal neurinomas, we, on the basis of the concept that these tumors are interdural or within the dural confines, we described an infratemporal fossa interdural approach. You see the hands of the surgeon, remove the zygomatic arch, widen the foramen ovale. So this tumor we removed without craniotomy, just opening the foramen ovale. In 1995, you can imagine, we had a clear impression about that this tumor is within the dura, and we had a clear impression that this tumor was a trigeminal neurinoma. Only then we could have the guts 26 years ago to remove this tumor, which is in the cavernous sinus. And in that location at that time, 25 years ago, nobody was touching cavernous sinus tumors. Even today, not many people have enough information about cavernous sinus tumors. So in my book, in my paper in 1995, I gave this picture. So you see this tumor was removed without craniotomy. This was another tumor in my same paper. This tumor is going in the posterior cranial fossa and in the middle fossa, and this tumor we remove with this kind of craniotomy, just widening the foramen ovale without doing any temporal craniotomy. And we removed even the posterior fossa crane component by widening the foramen ovale. This was also in the book, in the same paper, where we removed this tumor by just doing widening of the foramen ovale. Essential is not the exposure, essential is the philosophical understanding that these tumors remain within the confines of the dura, and you can work within the dura to remove this tumor.
tumors, and you can more importantly, you have to save the trigeminal nerve fibers to preserve and improve the function of the trigeminal nerve. So we also described similar theory for oculomotor neurinomas. We said that oculomotor neurinomas arise from oculomotor cistern in this location, and these tumors, as they grow, they take the dura with it, and interdural location of oculomotor neurinomas. So these tumors can be quite difficult to understand, but if you know that this tumor is an oculomotor nerve tumor, and they are located within the dural confines. Oh, just a minute, please. Work within the dura, and save the dura. This is not the tumor capsule. Don't try to remove this capsule. If you have this concept, you can preserve the third nerve function, even if there is some tumor residue. So this is a third nerve neurinoma with a clear dural margin. The concept is open the dura, work interdurally, and you don't try to remove the capsule, and you will be able possibly to save the third nerve function. Similarly, we describe for C2 neurinomas that they arise outside the confines of the spinal canal. They are not inside the spinal canal, they are behind the C1, C2 articulation. And the tumors which arise from the C2 arise from the ganglion, and they remain within the dura of the C2. So this C2 neurinomas, we described 60 cases in 2008, and more recently I described 50 cases of C2 neurinomas. The concept was that C2 neurinomas are outside the spinal canal. Gasserian ganglion is outside the skull, essentially in the interdural compartment. The tumors of C2 neurinomas are within the dura, interdural. In the year 2008, we said that this part of the tumor is intradural. In 2003, we said that this part of the trigeminal neurinoma is intradural. But later we said that both these components are interdural. You see, this is C2 neurinoma and this is trigeminal schwannoma. Both have similar, they are interdural in location. This is C2 neurinoma, this is trigeminal neurinoma. Both are interdural in location. You work within the dura and you can remove these tumors without laminectomy. You work within the dura and you can remove these tumors without craniotomy. We describe this for the first time in literature. Removal of such tumors without laminectomy or any bone work, and removal of these tumors without craniotomy, essentially based on the understanding of dura. So NF2 are bilateral, even bilateral C2 neurinoma and bilateral trigeminal neurinoma. Ipe, my dear Ipe, can you tell me how much time I have so that I can actually continue for as long as you want? Can you tell me how much time I have?
Maybe the next 5 minutes.
5 minutes? Okay, let me show you quickly. So this is C2 neurinoma, you see, with extraspinal component. This is trigeminal neurinoma with extracranial component. Similar philosophy of dura, we have said about 7 nerve neurinoma. 7 nerve tumor is a difficult skull-based tumor, but if you have the concept that these are within the dura, not only the middle fossa, even the posterior fossa component is within the dura. And these tumors arise in the geniculate ganglion and they remain within the dura. If you have this concept, and if you think that this is not the tumor capsule and you try to save the course of the 7th nerve, there is a possibility of preserving the function of the 7th nerve. Regarding trigeminal neurinoma, we described for larger tumors in 1996, we describe basal extension of subtemporal middle fossa approach. My incision was like this. You see the incision going behind. And the other beautiful thing is the temporalis muscle was rotated anteriorly. You see, we do zygomatic osteotomy because the temporalis muscle obstructs your vision. So when we rotate it anteriorly, the the temporalis muscle does not interfere in your middle fossa approach. In that paper, we also describe the resection of the root of the zygomatic bone, the roof of the condyle, the roof of the external ear canal, and partial mastoidectomy. You see, partial mastoidectomy. Subtemporal craniotomy and mastoidectomy was incorporated for the first time in the literature. In 1996, we described this article. And we used this approach for trigeminal neurinoma. So this was after my exposure extradural, and then open the dura and remove the tumor trigeminal neurinoma. And if it is going in the posterior cranial fossa, then my strategy is to come intradural, open the tentorium, and then cut the tentorium and expose both the middle and posterior cranial fossa components at the same time. So this is the exposure, removal of root of zygoma, roof of condyle, roof of external ear canal. I don't do this kind of exposure now after my continued experience in trigeminal neurinoma. I do a very small craniotomy over the roof of the zygoma here in the squamous part of the temporal bone. But this was the exposure that we described, and this was my experience in long time ago. And you can see the condyle and external ear canal and mastoidectomy. Now we do just splitting of the temporalis muscle and do a small craniotomy over in the base of the skull, and then work within extradural compartment and then interdural compartment and remove these tumors. More importantly, lateral position, lumbar puncture are very important component of this lateral approach. So this majority of these tumors, they are not very firm tumors. They are soft and necrotic tumors. And on several occasions, they are cystic tumors. So you come from here, open, and you can remove this tumor in very quick time. Maybe in half an hour, you can remove this tumor. More importantly, when you remove this tumor, you have to see that you don't coagulate too much, because if you coagulate too much, then there is a possibility of damaging of the fifth nerve fibers, the fifth nerve fibers. So you cannot just damage the V1 division, which is a very critical division of the fifth nerve. If you damage, you create corneal ulceration and opacities, which of course will not be tolerated. This is another tumor. You come in extradural, interdural, debulk the tumor, debulk the tumor, debulk the tumor in quick time. Do not coagulate, do not coagulate. Carotid arteries away from the dura, separated by the dura. The venous complex is separated by the tumor, by the dura. Debulk, debulk, debulk. Do not sacrifice the trigeminal nerve, which are coursing through on the dome of the tumor. Essentially, this nerve arises from a fibril of the trigeminal nerve, and then it enlarges. Rest of the cranial nerves are saved up on the dome of the tumor, and you have to save these cranial nerves. Essentially, learn the art of demolishing the tumor, learn the art of breaking the tumor, learn the art of removing the tumor without coagulation, and that may be the trick of the trade in these tumors. So this is another tumor, pre-op, post-op, removed. For tumors which are essentially anterior, I come from this direction, from here. Tumors which are going in the middle fossa, I come from more lateral in the subtemporal area. So this tumor, you see how it has been removed long time ago, maybe 25 years ago, I removed this tumor. This is another giant dumbbell-shaped trigeminal neurinoma, which has been removed radically. So as I mentioned, my experience is nearing or maybe more than 300 cases of these trigeminal, which is by far the largest experience in the world on this subject. And because of this, due to my hospital, KM Hospital, which is a public institution, huge number of cases, has given me the strength and power to operate such tumors in quick time. Maybe if I operate this particular tumor in more than 45 minutes, I will be quite depressed or disappointed. So this is another tumor which will take longer time because this is going in the posterior fossa. I'll have to cut the tentorium. Maybe I'll have to cut the superior petrosal sinus. Or sometimes I work over the superior petrosal sinus and preserve the superior petrosal sinus. There's a big distinct possibility. So this is one tumor, pre-op, post-op, pre-op and post-op. Even when there is a small nubbin like this part is also within the dura, and that you must remember that this is not going inside the cavernous sinus or having some strange kind of relationship. So this tumor can be removed. Cystic tumors are and necrotic easier to remove, but you have to remove it radically and completely. These tumors are more likely to recur. So that is another negative part of these tumors. So this is pre-op and post-op. This kind of multiple cystic tumor, easier to remove, soft, necrotic, don't have to keep on coagulating in these tumors, but these tumors are more likely to recur. So you are seeing several tumors which have been removed and removed beautifully. This is a large cystic tumor which had been operated earlier, and then I removed, and then this tumor recurred. This is a recurrence of the same tumor, and then we reoperated this tumor. So this is another recurrence of cystic tumor. So cystic and necrotic tumors are easier to operate, but can be, there can be a possibility of recurrence more often. Extracranial extension, also there is dural presence, which we must remember. And you work within the dural confines, you can remove these tumors within the dura, and we remove this by cranial route, not by, you can of course remove this by nasal route, also by infratemporal fossa route, but we describe reverse skull base approach for these tumors. Like remove from the cranium, go down. So we had reported this 28 cases long time ago. Now we have several more cases of extracranial extension. This is another tumor with extracranial extension. This is multi-compartmental tumor, posterior fossa, middle fossa, extracranial tumor. And we recently published this, that even when the tumor recurs, usually the recurrence is apoplectic. There can be bleeding within the tumor. And the recurrence is also interdural in location. So this is what we recently published. So thank you very much, my dear friends. And I hope you enjoy this session in Krishna Medical Institute in Karad. And my best wishes to all of you, the young team of neurosurgeon led by my dear Ike. Thank you, Ike.
Thank you so much, sir. That was such a beautiful presentation, and we can see the extensive number of cases and the complexity of them, and with the ease you can operate. There's no match for you in this world. We are so pleased to have you on this meeting.
Thank you, Nilesh. Thank you, my dear Nilesh.
Is there any question from the audience?
So it is not just that you have your lecture as you promised, you have to be here for the full 2 days.
Okay, my dear Ipe, I'm here, don't worry. I want to see you in action.
So we will have the cadaver workshop tomorrow also. We had a good cadaver workshop today. For your lecture, and I hope Yuha is here.
I'm here. I'm here. Yeah.
Yes.
Yuha, thank you very much
I'm
for
here.
joining in. Small introduction for Yuha. Yuha is, like Professor Goyal, Yuha is one of the legends of neurosurgery. So we have all the legends of neurosurgery today. Yuha is a legend in vascular surgery. And I can so clearly say that because Yuha and we work together in one department for about a year. So I've seen you have operating speed is principle of clean, fast surgery. And it is wonderful to see him again here. My best regards to him. He's like a very good friend, mentor, and guide. So, Yuha, to you.
Thank you, Ipe. Dear friends, I will speak. Yeah, I will speak about lateral supraorbital approach in anterior circulation aneurysm. This approach was developed by me 40 years ago. I have operated around 6,500 aneurysms, so it has been used in more than 5,000 patients. So it is old approach and very simple and fast. So this is the background of my aneurysm experience. This number of patients is coming from 2 centers, Kuopio, Eastern Finland, where I worked 17 years, and then from Helsinki, where I was professor and chairman 18 years. So there are very good databases and long-term follow-up of these cases. I have operated more than 1/3 of these cases myself and have seen most of these cases. So Finland is a small country, 5.5 million people, big country, but small population. And it is possible to follow up the patients long times, years, 20, 30 years. So this we have done and published profusely. Now, since 3 years, I'm working in China. After my retirement in Helsinki 2015, I was going around the world, also with Ipe 1 year in Nepal. And now I landed here in Zhengzhou, in the heart of China, where there is an extremely strong endovascular team in the second largest hospital of the world. There are 7,000 angios a year. We are treating 1,200 cerebral aneurysms. 3/4 have endovascular treatment, and around 300 are operated on. There are more than 100 AVMs. Moya disease is common here, so more than 500 bypasses are done in our clinics, and then a lot of brain tumors, Janetta operations, and so on are done. Spine is done by orthopedic surgeons, so this is how it is in China. So I speak about the lateral supraorbital approach. I saw a video here. It is nearly unedited video because its length is around 7 minutes. I can open in less than 7 minutes, less than 10 minutes. Usually lateral supraorbital approach, it means it is very fast here. Very fast. And as mentioned, it has been done 40 years in my hands and has spread by the visitors. More than 3,000 people came to Helsinki, so it has spread around the world, and with some modification, of course. Everything what you do is not accepted by everyone, so those who came to see and spend some time went with this approach around the world. So it is a 1-layer flap, and then you just open the temporalis muscle in the upper part. So it means that you don't have temporal muscle atrophy, which I have seen in several patients with more opening of the temporal muscles. If you see the patients long time, follow them long time, so you see also the late sequences of different approaches. So this is safe. You will never have facial nerve palsy because you upper branch palsy because you just open in 1 layer. So it is safe inside the package of between the scalp and the galea and the temporal muscle. Then the There's something noise here. Can you manage that? Okay, now the noise disappeared. So this is what I make: one borehole in the superior temporal line, and then take the bone chips away with Gerson Ronger. And at the end of this removal of the bone chips, you see that I rotate the Gerson Ronger, so to detach the dura. This is very good trick and used extensively in all the craniotomies. And then a curved dissector, Jone, is detaching the dura. And after detaching the dura, which in older patients might be very, very much attached to the bone. So I make 2 bone cuts. I'm not going through here, because if you go through in older patients, you will have dura torn. So I make 2 bone cuts. I have opened always myself, positioning, preparing the operative site, and opening. This has been done always by myself in Finland. Here in China, Hugo, my good friend, is opening for me. So this is, he's doing in the same way. So it is no difference for me. But I have taken this opening of the skull that way that I'm preparing for the intracranial approach. So I concentrate for that, and also trust my hands when opening myself. So detaching the dura from the anterior part of the anterior fossa, and then drilling away some bone to the skull base level, not to retract too much temporal lobe. This is the rose drill, and then I continue with the diamond drill, which stops all the bleedings of the bone. I'm never using bone wax. I use this hot drilling. It stops all the most profuse bleeding in the bone, which you might have in the Petros bone, especially associated with AV fistulas, which are nowadays treated by endovascular means, but I have operated many of them, and they are profusely bleeding. So this hot drilling is extremely good trick in stopping the bone bleedings. So there's peroxide in these patties, and then a green linen is going around the operative area, so the light is not reflected from the white patties, and then careful taking the dura. Then you don't have oozing from the epidural space. All the bleeding should be taken before you continue anywhere. So it should be totally clean area. If you operate clean, then it is fast. And this is the principle: simple, clean, fast, preserve normal anatomy. This is very important, according to my experience, 48 years in neurosurgery. So this was the lateral supraorbital approach, and we see it in the next case. This is anterior communicating aneurysm. This was a Russian pediatrician who was getting blind. She went to Israel, but came back because they didn't dare to operate on her. So she came back to Helsinki, and here you see the aneurysm direction is downwards. It's going to the optic system, especially left optic and chiasm, and we go down here subfrontally now. Sharp dissection. You see that the Yasakil microschizo is like a crocodile because I'm using very high magnification here. So dissecting, and you see that the aneurysm is partially thrombosed. You see the hemosiderine inside the aneurysm. And what I'm now looking, I'm dissecting directly to the aneurysm, but I'm looking for the both A1s because I want to put temporary clips on both A1s to be able safely to dissect on the aneurysm. So what's happened now? Okay, now we go. So we dissect above the aneurysm. We should come to the right side, find the A1, put a temporary clip there. This is lamina terminalis. And now dissecting the base of the aneurysm, and now on the left side, dominant A1, temporary clip, and this goes to the right A1, and now it is safe to dissect the aneurysm. The aneurysm is more slack, and you have more time than 5 minutes because there is a backflow from the A2s. But of course, you try to do it as fast as possible. I put the clip on the base of the aneurysm. And when dealing with compression of the optic nerves, you should not try to take the aneurysm totally away from them. You have to leave the part of the aneurysm that is attached to the optic nerves. If you try to remove it, then you will destroy the vision. So this is very important. One of the important things is also if aneurysm is causing blindness or decreased visual function, it should be operated on, not done by endovascular means, like it is many times done. But if there is a compression of the optic system, the smallest recurrence will make the patient blind. And when you follow up the patient carefully, you will see that the best treatment is clipping of these aneurysms. So this prevents recurrence and makes optic nerves free. The same counts for oculomotor nerve in the posterior communicating aneurysms, or seldom in basilar superior cerebral artery aneurysms. So now I cut the aneurysm base through, and I go once more with temporary clips on A1s with the golden color, and I remove the first clip because what I noted in the dissection, so some base remained, and I changed the clip. There's a curved clip now taking all the base of the aneurysm, and the patient now it is good. It's good, clean. Checking with Doppler and checking with ICG that the arteries are open. A1s both sides, A2s both sides. So this is important. Then putting some papaverine here, and then closing carefully, the vision improved immediately, and the patient was extremely happy for that. I skip the next video. Take now this one, because it was also anterior communicating aneurysm. So now I saw very difficult situation. So this is subarachnoid hemorrhage of a left-sided posterior communicating aneurysm. It looks easy. You can say that even my mother could do it. This is an easy aneurysm to do. My attitude was not so. I'm always having a good attitude, and this is coming from positioning of the patient, opening of the patient, because you are concentrating for the surgery. So I'm dissecting now. It looks different because there is fresh subarachnoid hemorrhage, and inside the blood we will find the carotid artery. Dissecting with microschizoids, Yasakil type. They look big because of the large magnification, and the moving in the picture is coming from the mouthpiece in the microscope. Mouthpiece is making you fast in surgery, 40–50% faster than without it. And now with the help of temporary clips, I put a straight clip there, and now take a look what happens here. What happens here? Perfect clipping, but the aneurysm, there is a tear in the aneurysm neck. Why? It's difficult to understand because it was less than 3 millimeter aneurysm base, so-called easy aneurysm, and now we are in extremely difficult situation. So I try every trick which I have in my armamentarium, and you should have many tricks to manage the desperate situation. So I'm traveling now with the clips. I put clip proximally to the first one. So the first one is pressing the second one down, and now it should work, but it's bleeding. And now, of course, what goes in your mind? The patient will be hemiplegic, aphasic, or in the acute aneurysm surgery, if you close a big artery like carotid, then the patient will die, usually. This is the fate. So this is going around in your mind, but you have to behave calm. You have to behave calm. No shouting in the operation room. Anesthesia is doing the things, and you are doing your job. So this is how we are doing. You see the terrible tear. I try to manage with the tricks which I know. Double clipping, traveling with the clips, curved clip to take, but of course it's futile, later, but I try until you have always to try everything until you come to the last trick, last solution. So then it will solve the problem. Now it didn't solve the problem. So I have to continue with the temporary clips. I remove all the clips, and here is big, and what I'm doing now. This is a muscle graft. I put the muscle graft on the tear and put the clips there, and the clips hold it, the muscle graft in the place, and compress it against the tear. And now I can take the temporary clips out, and extremely happy for the patient, of course, for the team. We could manage this easy aneurysm with terrible complication. In the surgery, in ICG, you see carotid arteries beautifully open, and the patient made excellent recovery. I put some glue there to have the muscle and clips in the place. And this is post-operative CT angio. And then we go to the next case, also bilateral supraorbital approach. This video editing is by Johan Schocker, originally from Peru. And here we have a thrombosed, giant, left-sided middle-cerebral artery aneurysm, also anterior communicating aneurysm, but a large thrombosed MCA aneurysm was symptomatic. You see edema around the aneurysm, acting like a tumor. Partially thrombosed aneurysms are difficult because thrombus inside the aneurysm may occlude the branches, and you have to be very careful with operating on them. So now we go to the left Sylvian fissure. Now we put temporary clip and even 2 on the M1. And then M2, so the aneurysm remains trapped. And then I go with a knife inside the aneurysm. There is no return now. There is no return. You cannot regret that you began the operation because there is no return. You have to do it. You have to do it. And the best way to remove thrombus inside giant aneurysm or large aneurysm is CUSA. Here I use the cardiac surgeon aortic clamp to clamp main part of the aneurysm, so it is inside the clamp, and then I can take the temporary clips out to reduce the time of arterial occlusion, and then I take a ring clip to clip giant aneurysm. The ring clip of Drake is the tool to put as a first, and then because it doesn't slip away from the aneurysm, and so it stays on the aneurysm. And then again, I will go with the temporary clips and remove the clamps there and remove more thrombus there, and see the orifices of M1 and M2 and clip the aneurysm. The aneurysm looks empty now. The thrombus has been removed. I take a long clip, clip the aneurysm, happy. I know very well that you have to leave some base. But now after the clipping, what happens? ICG, there's no M2 showing. So the clipping is too tight. So even I left some base, so I have to go again and take the clips out. And with temporary clips, I check inside here. There might be some thrombus in the orifices of M2 or M1. I'm checking with the hook and then taking the temporary clips out to flush once more, and then put a ring clip here to take the base, but now I'm leaving more of the base to have patency of the M2s. And this is how it goes now. There's again a ring clip going, but of course if you have ring clips, you have to close the hole in the ring clips, so you have to add one one straight clip here. Changing with the ring clips, of course you can push one ring clip deeper and the other one not so deep, so the hole will be closed also this way. So changing the clips long time. Now the straight clip is going there, and hopefully now the arteries are open. Doesn't look so good, but when we do with Doppler and ICG, so the branches are filling, and we are, of course, extremely happy to manage the situation. So now it is good situation. Annulus has been done, gone, and the patient recovered well, and her ACAM annulus was operated 2 months later when she had recovered. And this is a post-operative picture. CT angio. So all these cases I still can do, but the world has changed. So I saw one giant basilar aneurysm. To do posterior circulation aneurysms with direct surgery, you have to be a chairman of the clinics. You have to decide which patients are operated on by microsurgery. So this is different. Sorry, I didn't forward. Now you see this giant basilar aneurysm, huge aneurysm. When I could decide how to do, then I selected microsurgery. And this is right-sided subtemporal approach. This is not lateral supraorbital approach. This is the approach I learned from Dr. Drake and Peerless in London, Ontario, and later in Miami when we wrote the book on vertebrovascular aneurysms 25 years ago. History of treatment of posterior circulation aneurysms nowadays in China, nearly no posterior circulation aneurysms are operated on because all go for endovascular. One of the important things in China is that there is huge number of atherosclerosis here, so it makes use of temporary clips and clipping more difficult. So this is the situation. So I went subtemporally, and you see that there are temporary clips on the basilar artery and becomes, and I'm now fighting with the ring clips around the base of the aneurysm, and then changing the clips because the posterior cerebral artery was occluded. So I was traveling with the clips distal from the base, and you still see there is some bleeding because the clip is not properly placed. But then after some adjustment, so the clips take all the base, strong base of this aneurysm, and you see I removed the proximal clip and then go travel distally, and now the strong straight clip is going there to occlude the ring, a straight clip, removing the temporary. This, now you see that there is ICG, shows the patency of the posterior cerebral artery. Doppler doing the same. And this is post-operative picture. This is angio of the case. Beautiful clipping of the aneurysm, giant aneurysm. This one you cannot do by endovascular means. Whatever you do, they will recur. So this is what my teacher, late Professor Drake, said, be so honest that it hurts. And I add, and it really hurts to speak about the complications, difficulties. Of course, you have good cases and they give you support in your life in neurosurgery, but you should be honest that this is extremely important. And this is the sentence of Dr. Drake about the complications. If only we could have back again many of those who were lost or badly hurt for a second chance in the operative room with what we have learned. This is a wonderful sentence. We should analyze our cases, good cases, but especially the poor cases where we had difficulties, where we struggled and the patient was suffering or even was lost. So we should analyze them and publish carefully to share our knowledge and to improve in neurosurgery. So even endovascular surgery is strong. I still stick to this sentence we wrote 25 years ago. We continue enjoy basing of the perfect clip around the base of those deadly sacs. The most important thing is here, the perfect clip. This is the best solution to treat the aneurysms, but the skills to place the perfect clip are decreasing in the nowadays. So thank you very much for attention. Thank you.
Thank you, Yuva sir, for such a wonderful lecture. Is there any question from the audience? I think there is no question, so we can shift to the next speaker. Thank you, Yuva sir. The next speaker
Thank you very much. Thank you. Thank you.
The next speaker is Professor Luis Borba. He is a president of Brazilian Neurosurgery Society and is a professor of neurosurgery at Federal University of Paraná. He is talking about the petroclival anatomy. Professor Borba, are you here? You can start with. John, please unmute.
Good morning.
Yeah,
Good morning, everyone. I think good evening there. Can you listen? Can you
Yes,
listen?
yes, we can hear fine.
Okay, good. Hello, John. How are you?
Good to have you, Lois.
Yeah, how are you? Good, good. Okay, and let's start to share my screen here. First of all, I'd like to thank Professor Sheeran for the very kind invitation. It's a great honor to me to be here. And I saw they have very nice dissection in the morning. And I just saw the wonderful presentation of Professor Juha. More than anatomy, I will show you case with anatomy. What's the decision making in this area. During the last years, the petroclival area and some area in the skull base has been discussed a lot about the treatment, what kind of treatment, if the tumor should be removed, should not be removed, just remove a little bit, do partial removal. I don't know. I don't know what's going on. Today the world is completely crazy. The pandemic is here, the corona is here, and sometimes the neurosurgery is here. But I want to tell you something. Harvey Kunsher said in his book, 1938, there is no more gratified than remove totally a meningioma with preservation of neurological function. Meningioma is outside the brain. Meningioma is extra brain tumor. If you can remove totally the lesion, you can cure the patient. And this patient will be happy forever. And the gratification for the surgery is not the trophy of a tumor. The gratification is to have the patient with neurological intact. This is our mission as a neurosurgeons. We understand that some tumor in the skull base, especially meningioma, there is very slow growth. And some of them, during many, many years, the tumor grows so slowly that you cannot really sometimes identify that it's growing or not. But does not mean that this cannot change and this tumor need to be removed. If some people ask me, why to remove these lesions? Why do the surgery for this guy? Why remove totally or almost totally the lesion? Because this. You have a lesion like this. You have a lesion like this. And if you wait, you have like this. The brainstem edema. Lost the PIA plan, and now the game is over. This patient with very not so many symptoms, now this patient will have symptoms despite of radical and safe removal. I don't know safe now in this situation. Let's show a case. It's a young boy, no, 25 years old, not young boy, you see, young adult, a lesion like this, just diplopia, but the patient was going okay. And somebody said that, no, don't do surgery, it's very dangerous. He's not feeling a little bit. You see here, the plan, the brainstem. He decided don't do anything and come back in 19. Look at now. We have edema in the brainstem. And look now in 20. My friends, now the game's over. There is no more possibility to remove totally this benign lesion without neurological deficit. You cannot lose the time to do skull-based surgery. Sometimes skull-based tumor has a little symptoms, but it's a matter of time. If the time goes on, the tumor starts to have symptoms. And sometimes these symptoms you never recover. What is the petroclival area? I see every day a lot of papers about the petroclival meningioma, petroclival schwannoma, petroclival anything. And petroclival tumor is the tumor has attachment in the clivus and the petrous bone. Very large attachment. The clivus tumor in the midline, the petroclival, petrous and clival. If the tumor arises from the tentorium, it's very close to the petroclival area, but it's not petroclival meningioma. If the tumor arrives to the petrous bone, posterior or anterior to internal auditory meatus, it's not petroclival. Sometimes it's very large tumor, but it's not real petroclival meningioma. The petroclival is this. We need attachment medially. Okay? And you can divide the petroclival area in 3 segments. The superior segment that go to internal auditory meatus to the posterior part of the cavernosinus. The middle petroclival that go to the internal auditory meatus here to the lower cranial nerves in the jugular foramen. And the inferior petrosal sign, that is the craniosacral junction, go to the jugular foramen to the border of foramen magnum. The approach would be different. They are very close, but the way to reach can be different. The attachment and the origin of the tumor will be different. And the way to get out will be completely different. Today we'll talk about this area here, the superior petroclival and the middle petroclival. Tumor that is located in this 2/3 of the petroclival junction. Sometimes the tumor has extension superiorly to the posterior part of the cavernosinus, or sometimes to the cavernosinus. But the great majority of them goes only to this posterior part of the cavernosinus or the Meckel's cave. That is not the cavernosinus how you saw in the dissection. The Meckel's cave is the area that is outside the cavernosinus that you can follow the tumor from outside to inside. In this way, you can remove the tumor without any deficit to the motor ocular nerves. How to reach the area? You can go by anterior petrosal, you can go by posterior petrosal, you can go by retrosigmoid approach. That is one of the most important approaches in neurosurgery. I always say you should learn, be master in 2 approaches for the skull base: the retrosigmoid approach and the paternal approach. Its variation. The posterior petrosal approach is a variation of the retrosigmoid approach. The anterior petrosal approach can be some variation, or sometimes can be add to the paternal approach when you want to go more lateral. But if you understand very well these two approaches, you can do it. But for petroclival area, you have three approaches. And now there is a new player that's coming. That's the endonasal. Endonasal approach, transclival to intradural lesions. Very nice approach. Very beautiful picture. The camera, the video, the view that you see in the camera, in the video is wonderful. But not everything that you see in the video is applied really to the patient. If you want to do a radical removal, if you believe that the treatment of meningioma is a radical total removal, radical total removal does not mean morbidity. Mean remove the tumor and preserve the neurological structure. If you go to do the surgery, radical removal, you have radical deficit, you cannot do radical removal. But now this new player, the endonasal approach, is coming from the midline. Look at that. Man, very nice idea. It comes here, is sphenoid sinus, remove this part of bone and go directly. But there is one thing that the people that does this kind of approach say, oh, there is a limitation, lateral limitation. What's the lateral limitation? 8.8 millimeters. I repeat, 8.8 millimeters. Is smaller than my finger. This is the approach. If you find a meningioma in the petroclivus area that's 8.8 millimeters, less than 1 centimeter, in the midline, symptomatic, you receive a prize. 8.8 millimeters in the midline, petroclival, probably it is asymptomatic. If this tumor is asymptomatic, don't need treatment. Maybe you don't need any kind of treatment, radiation, surgery, anything. Go home. But the tumor that we see is not this. The tumor that we see every day is like this. And sometimes it's like this. It's impossible to reach and remove safely by the nose. You can bite? Of course you can bite. Go there and bite. I call woodpecker surgery, you know? Go there, woodpecker, go there, bite a little bit, and go home. Everybody happy, surgeon happy, video beautiful. See, you can show in meetings, webinar, around the world. But the tumor is there. Lateral is there. And the patient is not happy because very soon he will need a new surgical procedure. And reoperation, redo skull-based surgery is the worst surgery you can do. Redo is the worst you can do. And you go to China, as Professor Yu has shown. You see this guy. This was 2016? 2017, sorry. 1,546 petroclival area meningioma. Around 50% he used transpetrosal approach. If this guy that has this experience say that we need to learn petrosal, the transpetrosal approach, you need to trust him. It means you need to learn the temporal bone. You need to go to the lab to learn this approach. However, Does not mean that if you learn temporal bone, you should go to temporal bone approach, transpetrosal approach in every case. Great majority of the tumor, not the real petroclival, but the petroclival area, this tumor are removed by the retrosigmoid approach. I show this case. The people say, oh, you need transpetrosal, trans something, transforaminal, transjoint approach. No, look at this. Sigmoid sinus, cerebellum, tumor here. And look the view. And look the view for the other approach. If you come here, the retrosigmoid approach, you go directly to the tumor. Here's the vertebral artery. Look the attachment of the tumor. The attachment is just over the tumor in the jugular foramen. Look at this. Vertebral here, lower cranial nerves here, the attachment is here. When you decide to do the approach, it's very important to understand where the tumor is coming, where the main attachment of the tumor. See, when you work between the nerves, can happen this in the immediate post-op. Okay. Okay. You see, you can get a radical removal because you understand that the attachment of the tumor was here in the posterior fossa. Was not up, was not anterior. Another situation. See, there is tumor inside dural tail here, inside the internal auditory meatus. What's the easiest way to open the internal auditory meatus? Or middle fossa, or retrosig. If you had tumor retrosig here, let's come retrosig and remove the tumor safely. Is direct way to learn to do this approach. There are situations in which you can choose. Some people like more petrosal, some people like my retrosig. I love petrosal approach. I do temporal bone a little bit fast. I train a lot in temporal bone in the lab. It's the only surgery that really reproduce is the temporal bone. There is no blood, it's bone. You should do it. There are cases that you can do this. This is the case. You could tell me, okay, you can go retrosig, remove this part, maybe leave this part here, maybe open the Meckel's cave and the porum trigeminalis, porum trigeminalis and follow the tumor, or you can remove this part and leave this to radial surgery because it is in the cavernous sinus. If you understand the anatomy and go and see very well here, look at this. It's not cavernous sinus. His fifth trigeminal nerve, fifth nerve. This is the Meckel's cave. If you just open the dura, you open the porum trigeminalis, the tumor will come. It's not in the cavernous sinus. Why I decide to do petrosal approach for this anterior petrosal meningioma? I decide to do because I want to work presigmoid, retrosigmoid, and follow the tumor from anterior to posterior. Here's the fourth nerve. Here's the presigmoid dura. Here's the sigmoid sinus. I will work anterior and posterior to the sigmoid nerve, to sigmoid sinus. See? If the tumor is inferior to the jugular foramen, it's easier to remove and safer to remove by retrosig. You see the fifth nerve here? From the posterior fossa to the middle fossa. See here? Let's see. The five. Okay, 1 second. The five from there totally liberate. This is the beauty of petrosal approach, the posterior petrosal approach. But does not mean that you cannot work retrosig in the same time. Does not mean that you cannot work anterior petrosal at the same time. Is the basilar artery, the arachnoid preserved? Give the options. Don't be like this. I do like this in every case. No, 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 no. Learn the variation. Learn the best way to do the surgery and decide for each situation, for each case. But you cannot do it is say, I will not use because I don't know. I will not use because I don't need. It's completely, completely different. Okay? In the post-op. There is another situation like this. This is a tentorial meningioma. You can come retrosig, of course you can come. Sit in position, go there and do it. But where is coming the blood supply? The blood supply is coming from the tentorium. If the blood supply is coming from the tentorium, the best way to treat this huge tumor is cut the vascularization. Cut the blood supply to the tumor. Go there, cut the blood supply to the tumor, and kill the guy. After you can do the job very easy without blood. You can do the situation like this, very similar. This you can do retrosig easier, okay? But I did the same idea. Cut the vascularization, cut the tentorium, the tumor will die, you can work ahead. But when you decide to work around the temporal bone, not only the bone should be careful. We should also understand the arteries and the veins, especially the veins. The communication between the sigmoid, the transverse sinus, the vein of Labbé, and all the venous structure of the tentorium. See? In this way, it's important to do the preoperative study, MRV, to understand well the anatomy. Because you don't want this situation here when you have no communication between the sinus. The situation that it's happened in Kuwait. I was in Kuwait doing a case. They sent to me this case. Okay, I do posterior petrosal approach. When I saw there was no communication, and the tumor was
Hello,
like
Professor.
this. Yes.
I think this is a very beautiful, but we are slightly running out of time. I request you to conclude this.
Can you see me?
No. We are slightly running out of the time. So
Okay,
I request you
I'm
to
going
conclude.
fast. I'm going fast. Okay. This is another situation, and you go the anterior petrosal approach. You see, in this situation, you use the anterior petrosal approach to remove this tumor. But there are tumors that you really need the petrosal approach, the posterior petrosal approach. You get this, you do the surgical position, you do the removal, you do the petrosectomy, you remove the petrous bone, you expose the sigmoid sinus, you get tumor like this, you go straight directly in the tumor. This way you can go and remove, cut the tentorium, and go like this. Or another situation, you go like this, posterior petrosal approach. What's the morbidity of this? High tumor. You go there, remove the tumor, show the whole anatomy in the area here. You see? You see the basilar, the bifurcation, you see the nerves, you see all the structure here by posterior petrosal approach. This is the direct view to the joint. It's the pre and post-op, and nice removal. Sometimes there is a price. You pay a price, you pay something. It's the diplopia, sixth nerve. You remove the tumor, you do the tumor, and the post-op patient has 6 nerves. This is a high price to cure this patient? I don't believe. 6 nerve palsy is a high price to cure this lady? I don't believe. Sometimes like this, 4th nerve, not so high price. But not in every situation you can do it. Sometimes there is tumor between the vessels that you cannot do the safely removal. Okay, like this, you remove this posterior part. There is a small tumor in the jugular foramen. You prefer to leave the tumor that is invading the nerve. It's safer to leave the tumor than to go inside the jugular foramen without plan. If you have plan and you get in the glomerular tumor, you can take it. But some meningioma tumor like this have no plan, and I prefer to leave this small piece of tumor. To end the presentation, skull-based tumor surgery is commitment. To bear skull-based tumor is the team. We need to work together to have a nice result. You go to the lab, to train in the lab, to go to surgery, after you can get fun and be happy. Thank you very, very much for the presentation. Thank you.
Thank you, Professor. Is there any question from the audience? I think we should shift to the next speaker. Next speaker is Professor Vladimir Benish. He is the head of department in the Central Military Hospital in Prague, and he is the chairman of the Department of Surgery in the first medical faculty at the Charles University. And he is also president of EANS, European Association of Neurological Society, since 2011. We welcome Professor Vladimir Benish. He will talk about skull-based meningiomas. Is Professor Benish here?
Yes.
Yeah, Professor.
Certainly. Let me share the screen. Do you see the screen?
Not yet. Well, we see. There we go.
Thank you. It's a great pleasure and honor to be here, and I really enjoy your company anytime. You know, like here in Nepal, and we have had one of our table tennis matches, and you are a fraction better, but you are kind enough to end all our games as a draw. So thank you for this, and thanks for the invitation. It's really great, and I really wish you all the best in Krishna Institute, and I'm pretty sure you will be doing well with your invention, with your personality, and with your ability to be finding unorthodox ways in neurosurgery. I was given a difficult task to talk on skull-based meningiomas, and it's a huge topic. So I shall run fast through. In my mind, meningiomas, especially the skull-based meningiomas, is a continuum along the venous sinuses of the skull. You see here that there are transition types, and you are going one to the other, and you always end up in the mother of all, which is the cavernous sinus. It's like the most important crossroads for meningioma. So the taxonomy of all these lesions is difficult to describe precisely. Over the past 20 years, we have had a total of more than 1,600 meningiomas, and half of them were skull-based. There are several facts which I would like to point out. There definitely is mortality in skull-based meningiomas. It's some 1–2%, not high, but there is, and I always am a little suspicious about the series without any mortality, and as well without any serious morbidity, which is always present. It's mostly recruited from patients whom I call too much too late. The octogenarian coming to the department with the decompensated tumor, probably decreased Glasgow Coma Scale, you must expect some more mortality and some morbidity. Minor and temporal morbidity, of course, handling the cranial nerves and handling the vessels in the skull-based region brings some minor and temporary. So let's come from cribriform plate down to cranial cervical junction. These are the cribriform plate tumors, and recently I believe that our aim is to preserve the smell. There are two types, and that's probably the most important slide of my presentation. You see the identical tumors in the cribriform plate. The difference is unilateral edema in this one and bilateral edema in this one, and the shift of the anterior cerebral arteries in this one and anterior cerebral arteries in the midline in this tumor. What does it mean? It means that in this case, the left frontal lobe as well as the first nerve are covered by 3 layers of arachnoid. So you really have a good border and good plane of dissection. Unlike in this one, where there is only one arachnoid covering each frontal lobe and first nerve. So these are much more difficult and much less chance of preserving the smell. This is the article we published. We are doing all these tumors via stereonal approach, and we were able to preserve in normosmic patients. We were able to preserve the smell in 62% of the patients. So this is really an issue by now. Let's see the video how it's done. Coming from the side of the tumor, they are not really symmetrical, all of them. And you see that at the end, the contralateral first nerve is preserved. So this is what can be done. On the other hand, there are large tumors which are located very frontal. We still come directly from the front with something we call interorbital approach. And even in this case, the smell can be preserved on the side where the tumor is small in volume. So in this case, we were lucky. It's not that frequent that in these giant tumors, the smell can be preserved. All right, let's go in.
Sorry about that.
John, can you...
Yeah, we got it. We got it.
All right, can I continue, John?
Yeah, I think it's okay now.
Good, thank you. Going to tuberculum cell meningiomas, which are rather frequent. There are two features which I would like to say that here again, arachnoid and Imad Khanan is saying arachnoid is a friend. It's really the important structures to be preserved. I lift the arachnoid from the tumor. I do not cut the arachnoid as long as possible. And although I'm coming from the contralateral side, the tumors are almost always a little asymmetric. So I'm coming from the opposite side. Let's see what is about the lifting the arachnoid. See the tumor, see the optic nerve, and see that I'm not cutting the arachnoid. I'm just lifting the arachnoid out of the tumor and preserving all the vessels and all the tiny structures and especially arachnoids. Then the contralateral approach, take a look here and see the video. It's another case. If you need to open the optic canal, which I believe it's almost always, you always do it better from the contralateral side because you come from the medial side, which means from the side where the tumor remnant will be located. And see how easily you can then resect the tumor remnant. This is the contralateral carotid, contralateral optic nerve. So these are two features for tuberculum cell meningiomas. This is the article which was produced by the EANS skull-based task force plus some friends, and what we did was really the recommendations for tuberculum cell meningiomas. And I believe that this article is something to be read because it's all very comprehensive, and I must congratulate Roy Daniel, who really organized this task group and who is behind all these articles. Going to the anterior clinoid, in my mind, I always resect the anterior clinoid, but I do not resect the tip extradurally. I leave the tip of the clinoid inside dura, and I resect it only later when I'm opening the fissure. You see orbitomeningeal band, which is transected, the beloved structure of Hypcherian, then separating the dura from the outer wall of the cavern of sinus, very limited dural opening, and you go down to the tumor. which you free first from the temporal side, exposing the third nerve, and if possible, carotid artery. I will show soon that it's not always possible. And then cutting the dura, removing the tip of the clinoid, which was left behind there. And then you cut medially. This is the uncus, this is the preserved arachnoid, and this is the carotid artery, obviously. And then you move medially to expose the optic nerve. Again, this is the space created by the clinoidectomy. This is the dural ring. Here's the tumor, which you just undercut. You see that again the arachnoid is preserved, the optic nerve and the carotid artery. Now the tumor is undercut, deprived of all the blood supply. You easily remove the main bulk of the tumor after the dissection, but this is usually the easier part, and you nicely see all the structures here: carotid, A1, optic nerve. This is the olfactory nerve, this is the Heubner's artery, again this is the optic nerve, and everything's very nicely seen, preserved and undamaged. Again, the arachnoid, I'm sorry to going back to arachnoid, but in meningioma surgery, this is the most important structures to me. The only firm arachnoid is outer wall, and then within the cisterns, it's Lilienquist membrane. All the rest are trabecules and sustentacules like this. You see the ambient cistern, you see the crural cistern, and coming forward, you get to the carotid, you have the posterior communicating artery, and see that that's not the wall, the cisterns which are described. It's really just the trabecules, but you use these as a border or as an indication that this is where the tumor ends. Anterior clinoid meningiomas, that's the issue where I go for again anterior clinoid resection without the tip, and you will see why I did it and why I'm doing it always, because pre-op radiology never tells you enough. This is again the dural ring. Tumor is still there, and the whole carotid is covered. Now the optic nerve is to the right, and the carotid artery is here, and you see the tumor which is growing all around the carotid. This is the Almeftis group 1 tumor. This is the dural ring, where it's tumor origin. And when I cut the tumor now from the in between the optic nerve and the carotid artery, you will see that it will start bleeding, because here is the blood supply, and you cannot really easily separate the carotid artery, and that is why I'm afraid to resect the entire clinoid from extradural space. Then the removal of the tumor, as usual, and now the remnants of the tumor all around the carotid and in the dural ring, and you will see that at the end we were able to resect almost everything. I wouldn't call it Simpson 1, but Simpson 2, definitely, because this remnant of the tumor on the carotid, which is seen here, was coagulated and separated from the dural ring as much as possible. Well, going backwards, and I will jump across all the middle cerebral and sphenoid wing meningiomas, going to CPA. CPA tumors are those which have the tumor origin posterior to the nerves, like this one. You see the tumor origin, which is slightly seen on T2. T2 images are neurosurgical imaging, because you see much more than on T1 with Gado. So always T2, study T2 in all 3 planes. And petroclival, which is a group of tumors, like Louis has very nicely shown before my lecture. In general, those are the tumors which are anterior and superior to the 5th nerve entry into the cavernous Meckel's cave. Again, study on anatomy. The only firm structure is the Lilienquist membrane, which is this third nerve, which is rather difficult because it's within the interpeduncular system, where it's easily endangered, and outside, where it's much better. The 4th nerve, the 6th nerve, going to the 5 and 6. There is the common carotid sheet for all the nerves in the CP angle. The fourth nerve, which is almost the most difficult one because it's very long, and in petroclival meningiomas, it's stretched mostly above the tumor, and you handle it rather difficultly. Fortunately, the sequelae of its damage or its section is not really that big. Then we go for CN9 and 11 down in the CP angle, and finally 12. And there are three general approaches to this region: supra infracerebral, retrosic, and far lateral or enough lateral, or the combination. This is the petroclival meningioma or petrous apex before and after surgery. And what's always helpful is to cut the tentorium, which allows you to expose the tumor on its superior margin, and you very early on, after the resection of part of the tumor within along the superior petrosal sinus, and very early on, you get to the brainstem, and you see the interface between the brainstem and the tumor. See that this is the remnant of the tentorium which was cut, and here is the superior aspect of the tumor, and you immediately see the brainstem, and you immediately see the plane of dissection, whether you will be able to resect the tumor entirely or whether you will have to leave a piece behind. That's another tumor, quite large one within the cavernous sinus, within the Meckel's cave, quite a piece of the tumor in the middle fossa. Again, this is the approach supra-infra. This is with the exoscope. That's why it's a little distorted. Here is the fifth nerve. Monitoring, of course, when you go forward, after the cutting the tentorium, you see the third nerve. And that's the limit of the tumor. The Lillienquist membrane always keeps the tumor at bay. This is the third nerve after the resection of the subtemporal and superior margin of the tumor. And then this is the sixth nerve, which I always look for very actively, since the damage of the sixth nerve, it's very, very unpleasant for the patient. And this is the tumor remnant, which will be suitable for gamma knife surgery if needed. This is a large petroclival tumor, which definitely goes very low for supra-infra, which definitely goes very high for simple retrosic. But you can easily do all three approaches combined. This is after the resection of the tumor. Take a look. This is at the beginning of surgery. You go supra-infra. The tumor is covered by the arachnoid. It means that it's really very anterior. This is the 7th, 8th, and this is the final. This is far lateral or extralateral. This is 9th and 11th, and this tumor is still there. So all these three approaches combined may be used, and it really helps. Here is the another patient with a large petroclival tumor. You see it here on CT. MR was not performed. This is the lateral aspect of the brainstem. And this is the patient who needed to take care of his house the day of surgery, unlike our patients who spent few days in the ICU. Remnant is always better than the deficit. So you see these two petroclival tumors, when the interface between the brainstem and the tumor was so firm that it was not safe to resect the tumor entirely. So this is what I left behind. And it's always better to leave the thicker portion of the tumor behind, because if you coagulate the vessels, you end up coagulating the vessels which belong to the brainstem, not to the tumors. And this remnant is stable, subject to observation only. And this remnant grew a bit, so it was subjected to gamma knife surgery. And both patients are symptom-free, doing perfectly well. This is another article which we put together under Roy Daniels' chairmanship, the ANS skull-base group, and this is about the extreme lateral supracerebral infratentorial approach, its use and versatility, and it's my beloved approach, and I really am using it very frequently, and the article is really very comprehensive and very, very educative, so make sure to read it. And we shall end up with CC junction tumors, which are not that frequent. They compose some 2% of skull-base meningiomas. They are rather nice. The approach is enough lateral, not extreme, nothing like a big condyle resection, because all the work you can do is above and below. You don't need to have the flat approach. This is the 11th nerve, this is the brainstem, here's the tumor. Probably the most important is to check for the 12th nerve, which usually is anterior to the tumor, and this is after 11th, 12th. And you see that the condyle doesn't hinder your approach, because you really can go above and below. So some of those extreme lateral and far lateral or transcondylar or whatever, I do not think that are that necessary in neurosurgery. Taxonomically wise and systematically wise, we have tumors which do not fit any nice and easy description. You see that this tumor is orbitosphenopetroclival tumor. So where to put it? Where is the tumor origin? It's within the cavernous sinus. It's always difficult to put these tumors into some system, and it's not really anything exceptional. It's really that mother of all meningiomas, where from you can go in any direction. My hobby are the beetles, and the taxonomy of entomology is in zoology, it's rather easy. You see, this is the beetle I caught in Mexico, and it's a very well-defined, distinct species, different from any other. So it's like, let's say, cribriform plate meningioma. This beetle from China, it's still the only one in the museums and in the collections. It was first described as Ecoptolabus beneshi, in my name, obviously. And later it was redescribed and put in a group of one species. It's like the group of anterior clinoid meningiomas. You can subgroup them. But the zoological taxonomy at the kingdom and going down, and the only which is acknowledged is genus and species. The genus could be sphenoid wing, and the species may be 3 of them, lateral, middle, and medial. But then you need all these small groups, you know, like subspecies, aberration, forms, variation, just to be able to compare the series. To determine an exact, you have the key, which is a simple sentence, you read it, and if it fits the specimen, you go to the next paragraph. If not, in a bracket, there is the paragraph where to go back, and you just continue, and you end up with a description. In meningioma, that would look like 1 would be supratentorial, 2 infra, 3 both. If the tumor is supratentorial, you go to the paragraph number 4, convexity. All right, you go to the paragraph number 9, parasagittal, and so on and so on. This is probably the article which should be published in Zootaxa, not in Neurosurgical Journal, but we are playing with this, and probably we shall find some way how to do that. To conclude, and not to be too long today, meningioma surgery is the most rewarding surgery. We are dealing with oligosymptomatic or asymptomatic patients mostly, and you are really able to return the patient back to his original life without any hindrance in majority of instances. On the other hand, this is dangerous surgery. The reasons are the same. Patients are frequently asymptomatic, and you give him 6th nerve palsy or 3rd nerve palsy, which is something very, very unpleasant. So offer surgery only to those where you prove the growth. I never ever operate on an oligosymptomatic or asymptomatic skull-base meningioma on a third side. I always call the patient in 6 months' time, 1 year time, if the tumor grows. I have many patients whom I only follow, never ever subjected to surgery. Always prove the growths. The next important fact is that the remnant is better than deficit. In skull-base meningioma, we are talking Simpson grade 1 to like 60–70%, not more, and that's very reasonable because it's always better than surgery, because you have the alternative treatment. Behind you, there may be radiosurgery, or even up front, there may be radiosurgery. So consider this almost complication-free technique. And suddenly in all this, observation is a legitimate treatment modality. There is nothing wrong with that. Not all tumors need to be treated. Management complications, very frequent cause of complications. You know about it with hindsight only. That you made a wrong decision, you do not know upfront. You know it only with the hindsight. So think twice, and if you have thought twice, think for the third and fourth time. Don't be afraid of that. Quite frequently, I've spent more time checking the images than with actual surgery. Complications, cranial nerve, vascular, and too much too late patients. Unavoidable, there will be complications with skull-base meningiomas, and the only way we can deal with them is try to keep them at bay and decrease their frequency. It's all about anatomy, and again anatomy, about training in a lab, and about all these hands-on workshops where you are just now, and where I'm sorry that I'm not coming for the dinner today. It's quite far. So to conclude with this, that Aib Cherian is really a successful young guy, and you see that not that long ago he has had a nice exhibition at the Museum of Modern Art in New York, where he was presented all his excellent abstract paintings. So Aib, be active, and all the participants enjoy the rest of the course. Thank you.
Carotid artery, different parts of the carotid artery. This is his own classification.
Thank you, Professor. I think Professor Keki Tudel is also here. Is he want to comment something on this?
Oh, I just joined.
Okay.
I just joined, and I saw, as usual, Dr. Benes
Yes.
is always very clear. Thank you very much.
Yes, sir.
Thank you.
I had taken a break because there was some emergency.
Okay, okay, sir. Okay, sir. Our next speaker is Dr. Matias Balondonci. He is the neurosurgeon who is working in Buenos Aires, Argentina. He is a deputy director of the microsurgical neuroanatomy laboratory. Is the Dr. Matias here? He can take the speech.
Yes, I am here. Can you hear me?
Yes, yes, we can hear you.
Great. Well, first of all, I want to thank you, my friend, Professor Itrian, and I want to congratulate to him and his team that are organizing this beautiful neurosurgery coach meeting with such important speakers before to me. And thank you very much. Well, the lecture I will start is related to the microsurgical management of these special paraclinoidal or ophthalmic aneurysms. As everyone knows, the ophthalmic aneurysms arise from the internal carotid artery in the segment between the distal dural ring and the origin of the posterior communicating aneurysms. For the majority of these vascular lesions, it's described the anterior clinoidectomy as the unique way in order to unlock the complete sac of the aneurysms before to clip it. And I want to share with you some interesting cases where the anterior clinoidectomy wasn't necessary prior to place the clip around the neck of the aneurysms. I want to start sharing with the audience these three cases. I want to say that for clip these aneurysms using only to expose these aneurysms is especially focused for those aneurysms that grows in the superior wall of the internal carotid artery in the ophthalmic segment, as you can observe here in this angio-CT. For all patients, we perform prior to the surgery an angiography plus the angio-CT. The angio-CT is an important study before to the surgery in order to make a good plan for this vascular resolution prior to the surgery, because we can observe the relation with between the aneurysms and the skull base. As you can observe here, we have a small circular aneurysm in the right internal carotid artery in the superior surface of the ophthalmic segment, and it's close to the medial border of the anterior clinoid process. And here is similar to the other. And another important observation that you need to keep in mind with you need to deal with this kind of aneurysms is is to observe if the roof of the optic canal is completed with bone, like in this case, or it is incomplete because you need to cut the dura mater here, and if you have not bone under the dura mater, you can produce a damage in the intracanalicular segment of the optic nerve. Well, I want to start showing these intraoperative images where we can observe here the left optic nerve, and before to perform the optic foraminotomy, yes, in this case we don't perform the drill of the drilling process of the anterior clinoid process, and after the optic nerve liberation, we gently mobilize the optic nerve upwards, and we can clip the aneurysms as we can observe here. And the anterior clinoid process is intact. In this left aneurysm, we can observe that the optic nerve is compressed from the inferior surface with these circular aneurysms. And here is exactly the same in the lateral surface. It's important to remember that frequently these kind of aneurysms, due to the close proximity with the optic nerve, produce in our patients some kind of visual field deficit prior to the surgery. And that's why I think that it's important to study our patient with visual field exams in the preoperative period, because if you fill these aneurysms with coils, the deficit of the visual field will be in the postoperative period. Of course, agreeing with my colleagues, with the speakers, with Professor Vladimir Ben, with Professor Yuha, and with agreeing with Ip too, it is very important to learn anatomy in the lab prior to the surgery. Anatomy, and then surgery. We can observe here the configuration of the skull base of the anterior cranial fossa, where we have here the planum sphenoidale, the tuberculum cellae, the foramen of the optic canal in the right side and in the left side, of course. And here we have the anterior clinoid process. The most important message that I want to give to the audience is that when you need to deal with vascular lesions located in the ophthalmic segment of the internal carotid artery, sometimes you will need to remove the roof of the optic canal. Sometimes you will need to remove not only the roof of the optic canal, you need to perform the hemiclinoidectomy, in other words, to remove the medial surface of the anterior clinoid process. And in another most complex cases, especially for those aneurysms that face laterally to the border of the internal carotid artery, you need to remove the anterior clinoid process. But I want to talk especially about the anterior optic foraminotomy, that we prefer to use the term foraminotomy because we drill not only the roof of the optic canal, we perform the drilling of the bone removal of the medial wall of the optic canal and the lateral wall of the optic canal. In the medial wall of the optic canal, we need to be careful because we are working very close to the sphenoid sinus. In other words, in red is represented the optic foraminotomy, hemiclinoidectomy, and of course, if we perform the 3 procedures of unlocking this segment of the skull base, we will do an anterior clinoidectomy. The vascular and neural structures that we have here are the optic nerve, of course, and the internal segment, the supraclinoid segment of the internal carotid artery. We have here the ophthalmic artery, of course, and this is the segment that we need to focus in this lecture, the ophthalmic segment of the carotid artery, especially for those aneurysms that grows from the superior surface of the ophthalmic segment of the carotid artery. And another important structure is the falciform ligament, because it's a fixed structure that we will observe in all patients, and we need to perform the foraminotomy using this structure because we can remove the bone over the optic nerve only in front of the ligament, 10 millimeters in front of the free edge of the falciform ligament. It is very important because if we remove the bone most anteriorly, we can introduce into the orbit, and we can damage the annulus of seeing in this region. This is an important structure that we have to recognize inside of the surgery. The aneurysms that I will show now are growing from this segment of the anterior carotid artery. The ophthalmic segment of the anterior carotid artery starts here. This is the distal dural ring and ends at the origin of the posterior communicating artery. And of course, it is very important when we mobilize the optic nerve for clip this kind of aneurysm to preserve the permeability, the patency, that we can control it with microdoppler of the ophthalmic artery. It's very important for our surgeries. The steps for this unlocking of the optic canal are remove first the dura mater in a C shape with the base located in the falciform ligament. To remove the bone of the roof of the optic canal, and not only the roof, you need to remove the bone located in the medial wall and lateral wall of the optic canal in order to produce a gentle mobilizing of the upwards of the optic nerve, and then we can clip the aneurysm, and we can show here in these microsurgical pictures. Of course, we perform generally frontotemporal craniotomy, and I will start with this first case, a small aneurysm located in the superior wall of the internal carotid artery in the ophthalmic segment. Here, this is our original drawings in order to show in an artistic way where the aneurysm is located and the close relation with the ophthalmic artery, of course. The patient was positioned in supine position with the 10 grades of contralateral rotation, and of course with the malar bone in the upper border of our exposure. This patient presents a preoperative visual field deficit, and he suffered a bleeding 2 days prior to the surgery. The surgery started with the frontotemporal craniotomy, with the pterional craniotomy, agreeing with Professor Borba that is our most important approach, or most common approach, the pterional approach for the anterolateral cranial base. First of all, we need to coagulate the dura mater in a C shape. Here we can observe the optic nerve, the carotid artery, the anterior clinoid process, and we coagulate with this curved bipolar forceps, the dura mater, in a C shape, starting from the tuberculum sellae and ending in the tip of the anterior clinoid process. Once the dura mater is coagulated, we cut the dura mater. We can observe some small bleeding from the dura mater. Small bleeding, of course, because we have no tumoral presence here. It's different when we operate, for example, tuberculum meningioma sellae. When we cut the dura mater, we prefer to remove it with a small micropale dissector. We perform a peeling of the roof of the optic nerve, and we remove the dura mater, of course. 10 millimeters anteriorly to the falciform ligament, we start to removing the bone located in the roof of the optic nerve. This is the technique step by step. And here is the anterior clinoid process. We don't touch the anterior clinoid process. The optic nerve is curved here due to the presence of the aneurysm located in the inferior surface of the nerve. When the dura mater is removed, we start with a 3 millimeter diamond tip drill and we remove all the bone located on the roof of the optic nerve and, of course, in the medial and lateral wall of the optic canal. This is why we prefer to use the term optic foraminotomy and optic nerve mobilization for clipping these superior ophthalmic carotid aneurysms, instead to use the term unroofed of the optic canal. Here we can observe that the remotion of the lateral wall of the optic canal with gentle irrigation. It's important to preserve the optic nerve. Here with a small micro dissector, number 7 Penfield micro dissector, we gently mobilize the optic nerve and we can observe this saccular aneurysm, the origin of the ophthalmic artery, and with this straight definitive clip, the aneurysm is secure, is clipped. Here is the ophthalmic aneurysm, and the aneurysm is cured. This visual final view of the surgery, the origin of the ophthalmic artery. And here is the anterior clinoid process intact. We don't touch the anterior clinoid process. The angio-CT in the postoperative period, of course. And here we can observe in this patient the visual field deficit in the preoperative period. And this is a visual field study 1 year after the surgery. And this is the patient who had a peripheral facial nerve pulses prior to the surgery. Another case, this 3D angiography reconstruction, we can observe a small aneurysm in the superior ophthalmic segment. Here we can observe that the aneurysm is very close to the anterior clinoid process. We suppose prior to the surgery that maybe we will need not only the unroofing of the optic canal, but we need to remove some piece of the medial border of the anterior clinoid process. For these all cases, we perform a pterional craniotomy and the exposure of the internal carotid artery at the cervical level in order to have proximal control if the aneurysm start to bleed into the surgery. The exposure of the carotid artery at the cervical level with a small incision of 2 centimeters under the microscope, and we start the surgery in a regular way, a right terminal craniotomy. We perform the transsylvial approach in all cases in order to gain space between the frontal and temporal lobe. After to remove the dura mater, we perform the optic foraminotomy, and with a small drill tip, the hemiclinoidectomy. Optic foraminotomy and hemiclinoidectomy was necessary to clip this small aneurysm located in the superior surface of the ophthalmic carotid artery segment, and the postoperative showing the difference between this optic canal, the roof of this optic canal, and the roof of the optic canal unroofed, and the medial or hemiclinoidectomy removed. The visual field deficit in the preoperative period, and the visual field study in the postoperative period. Another case, we can observe here this 3D angiography. We can observe a small ophthalmic aneurysm in the superior surface of the ophthalmic segment of the internal carotid artery. Here is a small aneurysm plus a small middle cerebral artery in the homolateral side. This patient was operated of a pica aneurysm 3 years prior to the surgery. The pictures, we can observe that the optic nerve compressed inferiorly to this aneurysm. After to perform the foraminotomy, we can observe here this small structure is some pieces of the falciform ligament. This is the intracanalicular segment of the optic nerve, and the aneurysm exposed without the necessity to perform the anterior clinoidectomy. With this angle clip, the aneurysm was solved, and the difference between both optic nerves, this optic nerve completely liberated in the intracanalicular segment, and the contralateral optic nerve intact, of course, in this case. Here we can observe two clips because this clip was placed in a small middle cerebral artery aneurysm in this patient too, in the same surgery. This is the study in the prior, and in the post, the patient improves, significantly in the post-operative period. It's important to keep this in mind. We not only solve the vascular problem, we solve too the neural deficit in our patients. Here we can observe another case. First of all, we remove the dura mater. We prefer to cut completely the dura mater in order to avoid to damage it with the diamond tip of our drill. We open the sheath of the optic nerve, of course, and we perform here an hemiclinoidectomy plus the optic foraminotomy, and the aneurysm was clipped with this angle clip, as we can observe. Not only we clip the aneurysm, we can liberate the inferior surface of the nerve. In the dissecting process of the aneurysm was open, presenting a small bleeding. And the last case, and with this case I will finish it. We can observe in this complex case that I operated some months ago, we can observe in the ophthalmic segment of the carotid artery two aneurysms and that are in close contact. We call to this case carotid ophthalmic kissing aneurysms. And we can observe here the video of the surgery. We have here the proximal aneurysm highlighted here, and the distal dysmorphic aneurysm highlighted here. We perform a left pterional craniotomy, transilvial approach. The patient presents a bleeding 24 hours prior to the surgery. We clip the distal aneurysms and the proximal aneurysm after to perform the optic foraminotomy and the liberation of the optic nerve. We puncture the distal aneurysm that present a bleeding, and we added a second clip, and we put a third clip on the proximal aneurysm in order to clip a small neck of this complex proximal aneurysm. This is the step by step, the proximal aneurysm, the distal aneurysm, the unroofing of the optic canal in order to liberate the neck of these proximal aneurysms. And this is the angiography scan in the postoperative period of this patient. Thank you very much. Thank you, Yves Charian, for your kind invitation. I'm very happy to be present in a virtual way from Argentina. Thank you.
Thank you, Professor. Is there any question? Thank you so much, sir. We will shift to the next presenter. Next presenter is Professor Wang from China. He is the pioneer of the cystinostomy in the China. Is he logged in? Professor Wang? John? Hello?
Yes,
John,
Professor.
are you there?
Yeah, I'm here.
Is Professor Wang here?
I don't know. Do you see him?
Okay. Then we will shift to the next speaker.
No, I don't see him.
Okay. Then we will have the next speaker, Dr. Srinivas Rohidas. He will be giving lecture from Krishna Institute only. He is present here. So we will transmit that lecture.
Okay, I'll try to get hold of Dr. Wang.
One second. Dr. Srinivas Rohidas will speak on his experience in the 3D endoscope in spine surgery. Rohidas sir is a neurosurgeon. He is working here as a director and chairman of the Rohidas Center for the Minimally Invasive Spine Surgery at Kolhapur. He is expert in Dr. Distinguished technique for the minimally invasive spine, and he has operated large number of patients. He is also the vice president for the World Endoscopic Spine Society, and is a faculty for cadaveric dissection workshop at the All AIMS Delhi. We are very pleased to have him here, Dr. Rohidas.
So let them arrange everything. Good
Now,
evening.
who are we waiting for?
Yes. We are just connecting. It will take a few seconds.
Okay.
Can you hear the transmission? I'm sorry, can you see the transmission from here?
We can see it, yes.
Okay, yeah.
So good evening, and let me start with this topic about 3D endoscope in spine surgery. This is something different apart from the skull base and the brain tumors. In 1990, Baker first described the 3D technology for the endoscope, which allows better recognition of the relationship of the anatomical structures and makes precise differentiation of the tissue layers. My journey with the spine started in 2002 with neuroendoscopy and spine endoscopy with Bernansky and Distandi. Then an era came where I had to decide about the spine and the neuroendoscopy. So these were the things which I took into consideration. I thought that we should work on the subject which others have not worked on, the subjects which are not explored. We have to focus on it and we have to do it persistently. And we should have a self-audit of all the results. And then I decided to shift over the spine. Then it was a minimally invasive spine. The minimalism in the spine does not require latest technology in the initial stages, but it requires to understand it is a concept. Minimalism in spine surgery is a concept, not regarding the size of the incision which we use for the approach. And the latest technology will help you in creating your brand value. In 2004, we did our first workshop at Indore, and this was the image. This was single chip camera, halogen light, small screen. But still the less muscle trauma, which was helpful for the patients. This is the screen which we used. We continued, in 2007, similar workshop. We continued with the workshop. Then in 2006, I started with the anterior cervical. And here I wanted to use a drill because it is a direct ban on removal of the bone. So to remove that bone near the vertebral artery was a little stressful in the initial stages. So I thought that I need something. Now this is the vertebral artery here. You are medial to the vertebral artery. I thought I need something which will remove the bone, because to use drill in that very narrow corridor, this thing can happen. And there are nearby structures, and the injuries with the drill are rare, but when you have the injuries, these are very dreadful injuries. I talked with the Zuring people, and these were the initial prototypes of the ultrasonic bone dissector, which will remove the bone, but which will not damage the soft tissue. This was the first thing in the market, ultrasonic bone dissector by me, by Zuring. We used to use with the endospine like this in the narrow corridors on the opposite lateral recess. This was the initial stage, prototype. Now this is the vertebral artery. Underneath my section is the vertebral artery, which is exposed. It's the medial border of the vertebral artery. And this is inside the canal going on the opposite side. Still, it was a single chip camera. This is an improved version, disposable cool knife of same company, which will cut the bone. This we are going on the opposite side, in the opposite lateral recess in a severe canal stenosis. In 2008, this is the HD camera, and the image was quite better. We could understand the anatomy. This is the midline. This is the right-sided L4 lamina, which we are removing. But life was comfortable at that time as compared to the single chip or 3 chip. This was the workshop in 2009. We could put the endoscope inside the disc space and inspect the disc space to see whether we have done an adequate discectomy. We can go inside the disc space in between the two vertebral bodies. Still, there was a skepticism that this is a 2D vision and we don't have a 3D appreciation of the anatomy. And the surgeon has to overcome this by considering the various landmarks and considering the depth appreciation with the 2D. So there was always a skepticism that this is not a microscope, this is an endoscope with 2D vision. It's a very good HD vision, but it's still 2D vision. These were the 3D technologies which were available at that time in this thing for the discussion. First was the vision sense, then I tried the Avion also, Machida, and the last one was the stars. This is the first 3D case which I did with the endoscope with the vision sense, and this was the intradural tumor at D12-11. This is a 2D video of a 3D. It's the endoscopic bipolar. We have retracted the dura. This is the outer and inner tube of the distant use technique. We can use micro scissors also. This is the bipolar. These were the cases which I used, where I used the vision sense. This was a canal stenosis, thick phlegm, canal decompression, bilateral root decompression. This is the ipsilateral root from where we have done the discectomy and the intradural tumor. But somehow I could not go ahead with this 3D endoscope by vision sense. This was a L5S1 disc on the left side. This is the nerve root here. But this was the vision sense. There were 2 lenses, multiple images were converted into 2 videos, and then the 3D appreciation was there. I could do around 10 cases with that endoscope. This is the canal decompression. This is ipsilateral root. This is contralateral root and complete dural sac which is decompressed. We are going inside the canal. As I could know the advantage of the 3D meanwhile, now in this endoscope, the head is not circular. We have to make changes into the endoscope for that. I was not able to go ahead with them. I thought of using a 3D converter, which is from the Machida. I used it from 2016 to 2017. I did around 132 cases with that. It converts a 2D image by deforming it into 3D. It's like this. And you have to use a specs. This is a 2D video of that. This is a ipsilateral root, right-sided approach. This is contralateral root on the opposite side. Then the 3D endoscope by Stars came. It was in October 2017. This is the TipCam 3D. And you need a monitor, specs, everything. This is the endoscope. It's a lightweight with a big monitor, 3D monitor, and you get 2 images when we record it with a 3D recorder. And these are 2 videos which are simultaneously running when you have a 3D screen, you'll be able to have a depth appreciation. Maybe next time when I'll present, I will ask the audio visual guy to have a 3D monitor, and then we'll be able to exactly know how the 3D looks. This is a 2D image of a 3D. This is a traversing route disk. This is a 2D image of that. It's a brighter image, crystal clear image. You will be able to see the capillaries also. Till now, I have used this 3D endoscope in spine for about 466 cases, lumbar 428, cervical 16 anterior cervical, posterior cervical 10, interdural tumor 10, and thoracic 2. I had around 5 dural punctures in cases of canal stenosis and cases of listhesis. One case recently we had to use a fibrin glue and tissue duroplast for the opposite side contralateral dural puncture with the nerve. This is the workshop which we do after we started after the 3D endoscope. First day, we have a training in the cadaver lab for selected number of people only. So by the 3D endoscope, we could successfully carry out that those surgeries with the 3D endoscope. There was no something like a vertigo or something like that. I never experienced that without any extra time or fatigue. It's easy for the beginner and it's suitable for complicated cases like reoperations, cases with severe fibrosis, interdural tumors, or anterior cervical where the approach area is something around 8 to 10 millimeters only. It is better for the canal stenosis to go on the opposite side, and the opposite side decompression is quite easy as compared to the ipsilateral decompression. So this 3D appreciation will definitely decrease the steep learning curve if it is commonly used for the cadavers and other things. Explanation of the anatomy is quite easy with the 3D endoscope. It definitely helps to reduce the complications related to the depth appreciation in the narrow spaces on the opposite canal or near the vertebral artery. This is my model. First day we have a hands-on. Second day they come to the OT and have a look at the anatomy, each and every step with the 3D endoscope, with the 3D anatomy. This is like inside the OT, intraoperative training. This is on the third day, they can use a 3D endoscope in the cadaver also. So better appreciation of the anatomy, I think it will decrease the steep learning curve in the endoscopic spine cases. This is the third day. They use the different cadavers and the 3D endoscope. This is in the Homburg SAR, where I presented the 3D endoscope videos and the work. So there are pitfalls with the 3D endoscope. Now, basically, we started with the endoscope for the panoramic vision. With 3D, there is no panoramic vision. It is a tubular vision. So there is no panoramic vision. But with the 3D converter, you can have a panoramic vision because you are converting 2D into 3D by distorting the images. But with the distant use technique, we have an outer tube and inner tube. We can slide the outer tube and inner tube up and down. And that's how we can have a zoom effect, which is not there in the 3D. At the site of the pathology, we can move the outer tube and inner tube whole endospine up and down or in 360 degrees so that the mobility and panoramic vision both can be achieved with the distant use technique with the 3D endoscope. So this not having a panoramic vision with the 3D endoscope can be taken care of with the distant use technique. This is how we can mobilize the whole system. So when we started with the single chip, then 3-chip HD image, the ultrasonic bone dissector was necessary for decreasing the stress and for the safety also. But with this crystal clear image, now we can use a drill also, endoscopic drill also on the opposite side because of a crystal clear image and the depth appreciation. And I think this will decrease the steep learning curve for the beginners in the future days. Maybe because of the better anatomy and 3D appreciation, we are able to appreciate more synovial cysts. These are not symptomatic cysts, but these are degenerated synovial cavities. We are aggressive in using the nerve retractor because of the appreciation of the depth for the disc inspection, and the vascular plexus near the axilla is easily appreciable because of the good anatomy and the 3D appreciation. Our patient's relative come into the OT and understanding of the anatomy, the disease process becomes quite easy for them to understand the disease process, because we explain each and every step of the disease process and the surgery to them in detail. Maybe in future, there will be monitors which will display 3D without having a need of a glasses. For some people, there is visual strain and vertigo for about, if you operate for about 2 or 3 hours with the neck pain. So those things will not be there in future. Maybe in future, 3D with 4K will come, and a navigation combination with the 3D endoscope will allow us to judge during the surgery how much bone we have to remove. Spine surgery is removal of the bone which is adequate, not more or not less. So that may be helpful if we combine the 3D endoscope with the navigation. Now this is the neurofibroma at C5 level. This is 4 to 6 hours after the surgery. No drain, no catheter mobilized. Next day we discharge the patient. And this we can use to create a brand value also. This is a senior doctor from Varanasi which came to me in COVID period with a charter flight just to get surgery by done with the 3D endoscope. Thank you.
Professor Rohidas, it's always a pleasure to see visionaries talking. So I was just talking to him at lunchtime, and I figured that the bone CUSA, concept of bone CUSA was started by him. And you know, people like Professor Rohidas, these are the people that you should learn from. They are the people who push the frontiers forward. I hope I can go ahead and learn some 3D principles from you so that I can put it into the cranial aspect. So we're trying to combine the exoscope, endoscope, 3D, 4K navigation, everything together into something called the hyperscope. So we will have to sit and discuss with him.
No problem, no problem.
People
Anytime.
like Rohidas always push the boundaries, and this quality is what I want the neurosurgeons to imbibe. This pushing boundaries, and this is where the concept of third world comes to an end. Okay, thank you very much. We are honored.
Thank you, thank you so much, sir. I think, Professor Wang had joined me. So can we have the next lecture from Professor Wang? Professor Wang is a professor he's currently neurosurgeon in China, and he's a pioneer of the systemastomy in China. Wang, and Professor Wang, can you hear us?
Wang, are you here?
He was in here. Where'd he go?
Yeah, Wang is here. You're muted, Wang. You're muted.
Unmute Wang. There you go.
Yeah.
Hey, how you doing, Wang?
Yeah, good.
How are you, Wang?
Yeah. Tomorrow you will have a conference.
No, right now we are going to have the conference. Right now we are having the conference, Wang.
Hello.
Yes.
Yeah.
Go ahead, Wang.
Sorry, because this is my iPhone, but the signal is not so good. Sorry.
Go ahead, Bang. We are seeing you.
Because I come in only 1 minute, so I have not listened to all the presentation. These doctors.
You can take your time. Don't worry. Just take your time. Let me introduce Wang. Or do you have any other speakers right now?
Yeah. Dr. Shivshankar Majaki.
Right. Let Wang, if you're taking time, then we will ask Shivashankar to have his talk, and after that you can join in. Is that okay?
At this evening, I have not prepared for it.
You have not prepared for it?
Yes. Because this evening I have not prepared for it.
Okay, so you want to do it tomorrow?
Tomorrow, let me prepare it.
Yeah, by tomorrow, if you can prepare, then we can give you a slot tomorrow. There's no problem at
all. Let me prepare. Let me see the details.
Right.
No
problem at all. So tomorrow we will see you tomorrow then.
See you tomorrow.
Yes, ma'am. Good to see you now. We will ask Shivashankar to present, please.
Dr. Shivshankar Majaki is a neurosurgeon at the Siddhigiri Hospital and Research Center at Kaneri Mad. This is a place near Kolhapur. He has completely transformed this place to a complete neuro institute. He is working there since last 6 months, so 6 years, and it's really good in the skull base and aneurysms. Can we have screen share?
Should I start?
Yes.
Yeah. Before I start my topic proper, I would like to congratulate Professor Ayapcharian and his team for organizing this cadaveric workshop followed by relevant lectures. It was really nice to see him here. Hardly he's here for the past 6 months, but he has done a wonderful job. And I think the guys who are learning here for MCH, they are lucky to have him here. So in these tough times of COVID, where there is difficulty to conduct any conferences, in this moment, within 6 months of his arrival, he has gathered 30 neurosurgeons here. It is a great job, actually. So I would like to congratulate him and his team for this wonderful job. So as Dr. Nilesh introduced, I work for a charitable hospital in Kolhapur. And most of the guys, you know Kolhapur by the name of Dr. Rohidas. I really take the pride, like he is a pride of Kolhapur, because wherever I go, when I tell that Kolhapur, everybody asks me, oh, you belong to place of Dr. Rohidas. So that's how the persons make difference to the place also and to the work that they do. So I really am lucky that I'm there in Kolhapur with him. And being a senior, he really guides us and he promotes us to do new things, that what he has done. And just imagine that being in a second tier city, he has developed spine endoscopy and he has taken across the globe. So sticking to one thing when you are in a private practice, it's quite difficult because only endoscopy and leaving rest of the part it really takes great strength by heart that you have to practice only that thing you have to develop, because finances matter a lot, because you have to invest. And rest of the cases that he doesn't do any other cases. He does purely endoscopy, and whatever neurosurgery cases go to him, he refer. So that's how it is difficult for us being even in a private practice to focus on one thing and develop that. And that is what he has done here. So coming to the basic art of aneurysms, as you guys had a wonderful workshop in the morning, where you went to the anterolateral skull base and you saw clinoid process, posterior clinoid process, dural rings, and the parts of ICAs. So a few of the videos I have, and they are relevant to the what you dissected in the morning. So this is a case of basilar top aneurysm. It is not a routine case as such, because this patient had a persistent primitive trigeminal artery and there is an aneurysm with it. As you know, these are the primitive trigeminal arteries, wherein in fetal period, the posterior circulation is supplied across these fetal arteries like trigeminal arteries and even the hypoposternal gossamer arteries to the posterior circulation. So persistent trigeminal artery supplies the posterior circulation and it arises from the ICA. So when it presents either as an aneurysm, trigeminal neuralgia, AV fistula, and stroke. And our Salman Khan is known for it because he has a trigeminal neuralgia with this persistent trigeminal artery. So most of the time when the PCOM develops, these primitive arteries disappear. And in some cases where there are absent flow in the ICA, they become persistent in the adulthood. So this case, she was a 60-year female. Actually, she was in her hospital to attend her grandson's surgery. We do epilepsy surgery and it was a hemispherotomy. She had come for a surgery. And while waiting, she had a certain severe headache. And on CT, it was showing SH. It was a fresh bleed. So on angiogram, it showed this large multilobulated aneurysm arising from the basilar top. So this is a basilar top aneurysm. It was multilobular, anterior, superior, and even on the bilateral side. So these are quite rare aneurysms and quite rare anomaly also. And most of the time when they're detected, we detect either with a neuralgia, stroke, AV fistulas, or trigeminal neuralgia. So in this case, you can see that this is a vertebral artery and that is aneurysm. And that bent structure there, this part is a trigeminal artery. You can see that it is originating on the right side and it is supplying the left side because left side petrous ICA is completely absent. And the whole of the left hemisphere is supplied from the posterior circulation through this trigeminal artery. So we had a difficulty here to decide about this approach, whether to go from the right or the left. So the basic rule of aneurysm surgery is that we need to have a proximal control first before we begin the surgery. So this aneurysm was, as such, it is a basilar artery which is supplying it. But because of this PCOM circulation, there was an anti-circulation supplying the posterior circulation also. So ideally, we went from the right side because right side vessels were supplying the aneurysm along with the basilar artery. So this is the patient on table in the supine with head extension on the Mayfield head clamp. We used navigation to know about the bony structures while operating. So this is a curvilinear incision and we went ahead with the right side frontotemporo orbitozygomatic one-piece craniotomy. And we expose the dura here. And in this case, this is what we do. This is the anterior clinoid here. This is the anterior clinoid. We drilled the sphenoid wing and went ahead with the resection of the anterior clinoid. So this is the clinoidectomy being done. That was extradural. And once we open the dura, you can see that there's a fresh blood in the cilian fissure. I have dissected open the cilian fissure from lateral to medial. These are the cilian fissure vessels. This is ICA. This is actually ICA coming up to here and AC and MC are here. And if you see here, this is the third now. This is third now. And from here, there's a large PCOM artery which is originating and supplying the posterior circulation. So for me, it was quite difficult because if you see, there is a large PCOM which is coming in a way to go for the posterior trunk of the aneurysm here, basilar artery. So I have opened the cisterns. You can see the trunk of the basilar trunk here. This is the basilar trunk. I'm just elevating the basilar trunk dissection for SOH temporary clipping. So I had a difficulty to see it because routinely what happens is once you retract the ICA, medially, you can directly see the basilar artery and bifurcation here. But in this case, because of the large persistent triangular artery, which was originating on the right side, going to the left side, and even a large PCOM, I had difficulty in looking at the basilar trunk and even the aneurysm. So I detected the temporal lobe, and here we can see the basilar trunk. Yeah, this is the aneurysm now. This is the anterior lobe bleb of the aneurysm. And I'm retracting the persistent triangular artery here. So through the optico-carotid system, I'm able to see the superior and the opposite side of the fundus, and you can see the teeth of the aneurysm on the one side. So there are a few of the perforators arising from the PCOM. So I have retracted the PCOM now, and below that is the persistent primitive triangular artery. So I have to dissect it away from the fundus of the aneurysm. So you can see that for every time I have to mobilize these vessels to have a complete view of the fundus of the aneurysm. And because of that, if it ruptures in between, it will be a hell here. Yeah, that is the teeth there, which has ruptured from that side. This is aneurysm fundus superior part. Here I'm lifting the basilar trunk so that I can put a temporary clip before I clip the aneurysm. So I'm running, this is a temporary clip. I'm trying actually because this posterior clinoid, this is the posterior clinoid here. It is in the, actually it is obstructing the applicator. So I went ahead with the posterior clinoid ringing. That is what you did in the morning. It is quite difficult because in below you is a basilar artery, and this side a carotid, and this side is a third nerve. And you have to be quite judicious and cautious because any movement might rupture the aneurysm here or basilar artery. So I have applied the temporal clip, and I'm going ahead with the permanent clipping here. Since this aneurysm was having fundus of the aneurysm, there was an anterior fundus, superior fundus, and it was projecting bilaterally. So single clip would not have solved the issue. So this was the first clip. I am including the anterior and superior part of the fundus here and preserving the PCOM on the opposite side. My clips of the blade are, tips of the blade are free. Now the left part is the posterior and superior part. And from here, mainly there will be perforators which arise and supply the posterior part of the thalamus, brainstem, and everything. So you can see that there are few of the perforators here. So I'm dissecting them away from the fundus of the aneurysm. So yeah, those are the perforators there. So I have used temporary clip for around 8 minutes in this case, and the temporary clip is on, and I'm dissecting. I have to be quick enough so that I should not prolong the temporary clipping. So this is the second clip being applied, which is quite straight, and inferiorly I have to be sure that I'm not catching hold of the opposite side vessels. So I'll have to have a look now. So this actually, it has completely obliterated, and there is a small fundus in between both the clips, which is totally avascular. It cannot be supplied because it is in between both the clips. So this is the immediate post-op CT. And this is post clipping. You can see the clip here, and the aneurysm is completely obliterated. This is a aneurysm here, and this is completely obliteration of two clips here. And this patient had a transient third nerve cranial paresis, and which improved over a period of time. So this is the importance of what you did in the morning. In this case, we need to drill the anterior clinoid and even the posterior clinoid. So anterior clinoid drilling is quite important, and you have to go base up to the strut, and you have to drill it so that you can get a proper view. And in case if the posterior clinoids are in the view, you need to take out the posterior clinoid so that your direction is completely open and it will not be obstructing the clips. So the next case is same. Here, this was a medial clinoid aneurysm. We can call it as a hypophyseal ophthalmic segment also. So here we need to dissect open the optic strut, and even have to take out the falciform ligament. Yeah, she was a 40-year female whom I operated last year actually You can see that this is the planum and this is aneurysm here. This is the base of the clinoid and this is a medial clinoid aneurysm, or you can call it as this is distal to the ophthalmic artery origin. So she had come with historical SH, headache with vomiting, and she had even visual disturbances. This is a medially pointing aneurysm around the clinoid towards the sella. So you can see that it is almost at the sella here. These are quite difficult because we need to expose the dural ring and we need to take out the falciform ligament. We have to drill the optic strut and we have to take out the optic roof also. So this is what I have done. I am drilling the antriclinoid now after drilling the sphenoid wing. So I'm over the antriclinoid and this is the base of the clinoid is being removed. Yeah, that is the optic now. I'm medial to the optic now. This is, I'm using a bone CUSA here because of the heat, the optic nerve might get damaged. So this is actually drilling of the base of the antriclinoid, and we'll through this we'll go to the strut of the optic strut. Yeah, here you can say that this is the optic nerve carotid on this side, and this is the strut. Yeah, once the strut was taken out and the optic roof was drilled and the optic nerve was the falciform ligament was cut, this thing was done extradurally, and falciform ligament will be opening after the dura is opened. So here we can see that this is optic nerve and this is a carotid. So I have drilled this part and I will be cutting the, yeah, this is what I have done. I have cut the dura over the optic nerve, that is falciform ligament. So now you can see that this is ICA. I have taken the neck control in this. I have opened the neck for ICA to have a temporary control if it under-ruptures. This is the optic now, and this is the ICA which is coming like this and going like this. And somewhere under the optic nerve is aneurysm. So this is actually the drilling of the optic strut now. This is the optic nerve, and this is a carotid here. And in between optic nerve and carotid, I was drilling. And these are the final parts of falciform ligament being taken out. And once this is done, we have exposed a long segment of optic nerve, and ophthalmic artery will be visible under this. So this is the arachnoid between the carotid artery, and you can see that this is aneurysm here under the optic nerve, pointed medially towards the sella. Yeah, this is the arachnoid dissection between the optic nerve here, and this is the carotid which is originating, and you can see the dural rings here. This is the distal dural ring. This is the distal ring, this is the proximal dural ring. Optic nerve is completely exposed, and now we will see the ophthalmic artery here once we elevate this optic nerve. Yeah, that is the distal dural ring. Yeah, that is the ophthalmic artery here. And this is an aneurysm which is arising from the medial wall of the ICA and directed towards the sella inferiorly. So in this case, actually the space is quite less to manipulate the clips. So I was just trying with the shape of the different size and shape of the clips. Because clipping, the horizontal clipping will be easy, but sometimes what happens is once you clip horizontal clip, actually the ideal principle of aneurysm is that we have to clip along the length of the ICA. But in this case, it was quite difficult because the cellular floor was touching the tip of the blades and I was not able to manipulate. It has ruptured here. So though I have taken a ICA's temporary control, but because of across the ACOM, the blood is flowing. So I will put a clip over the ICA here, the distal ICA, distal aneurysm. The blood has stopped. So here I could not see this part of the neck of the aneurysm properly. So it ruptured. So even this is not an ideal clip. So I will change with the transverse clip so that I will clip transversely here. This is the neck of the aneurysm, and I have reapplied the internal carotid artery clamp here temporarily. And using this, finally, I'll be clipping. Yeah. So this is a acute angled clip that I put across the aneurysm, and this completely operated the fundus, and even the neck was, the tips of the blades were completely free. So in this case, what you saw is ACP drilling, that is anterior canal drilling, and after that optic strut drilling. Strut is a structure which is under the optic nerve and medial to the carotid artery. Dissection of the dural rings, that is distal dural ring and proximal dural ring. So this completes our surgery. This patient actually had a visual dispersal in the pre-op, which persisted and improved over a period of time. So these were two relevant videos, what you saw in the morning regarding anterior process drilling and PCP drilling and optic strut removal, optic canal deroofing. These are two more videos. If there is a time, shall I proceed, Professor? Yeah. This was a case of intramedullary tumor that we recently did. She was a child of 5 years who came to us with torticollis, and there's something. Yeah, this was a 5-year-old female child who presented to us with a torticollis and 4+ power. Almost she came to us walking with such a large tumor here, which is extending from C2 down to D11. So the cord was completely expanded and hardly, the cord was completely distracted and hardly a millimeter of cord was left around the tumor. And this child had come to us to our OPD walking. So it was a challenge for us because for this, the midline myelotomy will be difficult because cord is completely round. We'll not be able to see the midline. So we used electrophysiological monitoring. Yeah, this was a child in prone position. We monitored SCCP and MEP throughout the surgery. Since it was a long segment laminectomy, being a 5-year-old child, if we do a laminectomy, child will have kyphosis and scoliosis. So we went ahead with laminotomy and laminoplasty at the end of the procedure. So this is what we did. This was a long segment laminotomy we did and took out the lamina in total posteriorly, and I have exposed the dura now. So I'm opening the dura in the midline. Yeah, you can see the cord down with the central vein. That is our landmark for myelotomy. So in this case, there are multiple subpial lesions, which were white and quite hard. So I thought I'm just waiting for the histopathology. There might be a subpial spread of the tumor. We have sent it for histopath, and now I'm opening. I have coagulated around the central vein, and I have done a midline myelotomy, and we are continuously monitoring SSCP and MEP. So this is a midline myelotomy being done, and once this is opened, you can see that thinned out cord is there, and the whole thing is a tumor. Lower down, I had this is what I'm doing now. This is a subpial upper region. There were multiple query metastases that have resected. And once the cord is opened from down to up, we opened the cord and sutured the paya with the dura so that whole cord is open like a pipe. So lower down, this is a tumor. Here there was a syringe. So I had a good plane for 2 to 3 levels. This is a tumor which has a good plane with the surrounding thinned out spinal cord parenchyma. You can see that hardly there is any. This is the tumor. Once I resected completely from the lower down 2 to 3 segment. But rest of the segment, there was no differentiation from the cord and the tumor because I feel that it is a pilocytic astrocytoma, might be a grade 2 or 3, astrocytoma grade 2 or 3. So this is after total resection. You can see that the whole cord is open from up to down. So this is the superior part of the cord, and this is the inferior part of the cord. The whole cord is open and the complete tumor is removed. and very thin rim of spinal cord is left behind. But throughout the surgery, the MEP and SSCP were quite normal. And from the beginning, she had this little bit decreased MEP potentials, and she had a right lower limb paresis, which persisted even after surgery. So this is the cord, thinned out cord. So this is open from top to bottom. So once again, we'll reobsubmit the cut ends of the cord using a pial sutures. So I'll be suturing this pia back so that the cord will completely closed. Yeah, these are the, I'm approximating. This is one end of the cut cord here, and this is the other end. So we'll put multiple sutures so that the opened cord is yeah, these are the sutures being taken from one end of the pia to the other end, so that the cut ends of the cord becomes approximate. They can be approximated properly. So this is after complete this thing. These are the pial sutures we have placed, and once again the cut cord is closed into its original place. So in such a long case, that this is a laminoplasty, we have placed the lamina back. We didn't use the plates here because 5-year-old child, and it might affect the growth of the child, because because it's a growing spine, once we put the clips, the bone will not grow, and that might compromise the canal. So what I did was that I just kept it, and I had made few holes around 3-4 on this side, and we had put sutures with Vicryl so that it will stay inside, and over a period of time it will get absorbed and the bone will heal. Yeah, this is a child post-op. Yesterday's video. This is on our 4th or 5th day post-op. She has normal grip. She can operate mobile. She eats by herself and she walks around. And when we do such a long level laminectomy and muscle dissection, patient will have a severe pain. And our neuroanaesthetist, he gave her erector spinae block under ultrasound guidance, and that took care of the pain that what he had in the post-op period. And just the child is almost near normal now, even with such a large tumor, such a long myelotomy. The child is almost like a normal now. So there is one more video. Should I stop or? Yeah. Professor Atul Goyal sir, I think he didn't give a talk on CVJ as such. It might be tomorrow. So they are the giants in this, and he is one of the world authority for CVJ, Dr. Patkar sir and all. So in front of them, this kit might be a small one, but I felt that I should present it because we did it in our center. He was a 47-year male patient who had a trauma at the age of around 14. He had a fall from a tree with head down, and since then he had a torticollis. So he was walking with that, and he never felt that there is an abnormality. He belonged to a poor community, so he never approached a doctor. And now for the past 2 to 3 months, he was having a gradually progressive weakness of all the 4 limbs and even bowel bladder disturbances. Here you can see that this is the foramen magnum, this is the C1 arch, this is the basilar invagination with atlantoaxial dislocation, and hardly there is any space left for the cord to go down. Yeah, this is it. So in this case, what actually had happened was because of the fall on the head, there was a basilar invagination, and the odontite tip has fractured, and that had abnormally fused with the anterior C1 arch. So, and along with that, there was an rotational subluxation. In this axial image, you can see this is the C2 arch. C1 was close in approximation with the foramen magnum, and the whole of the body of the C2 was in the canal. Yeah, this what I showed now. This is the body of the C2. Hardly this is a space left for the cord to go down. The joints were subluxated mainly on the right side. This is the whole, there is hardly a millimeter of space left behind the invaginated part for the cord to go down. So this is the 3D image that we did. This is a C2 here, and you can see that C1 is subluxated. This is a joint supposed to be here. C1 is rotationally subluxated. Yeah, the body is completely into the canal now. Yeah, from above, this is a form magnum. This is a view from form magnum from above. So in this case, I thought that I will go ahead with posterior approach and I will drill out the joint and will get a reduction so that I can put C1, C2 screws and I'll come out. Since there was one problem that it is not the joints only was the issue. The os was fused with the C1. Hence, I could not achieve a proper reduction posteriorly. But I could have in CVJ, there are two reductions. One is a vertical reduction in BI, where we reduce the odontoid tip, and there is a anteroposterior reduction. So I could achieve a vertical reduction, but I could not achieve anteroposterior reduction, for which I need to go anteriorly. So this is the angiogram, what we did. And in this case, this really helped us because if you see here, the pars is pierced by the vertebral artery. This is anomalous. If I would have put a pars screw here, I would have fired the vertebral artery. And this was a dominant vertebral artery. So preoperative CT angiogram helped us so that I finally planned for a translaminar screw here, because I cannot put this screw because hardly 1 millimeter of space was left through the pars. So this was a challenge for us. And once I opened posteriorly, you can see that this is a C1 arch. This is C2 here. There's a lot of space between C1 and C2 because C1 is anteriorly subluxated. So in this case, usually in all the CVG cases, we sacrifice the C1 ganglion here because it comes in a way. This is a joint, C1, C2 joint. So I have taken out the C1 ganglion here. So yeah, you can see the mobility of the joint there. So we use navigation so that I should not lose my vision. And yeah, so there was a difficulty for us to put the this side C2 screw here. So I have placed a translaminar screw because the vertebral artery was going along the parts of the C2. So this is a C1 lateral mass screw. This is a C2 pedicle screw. And this is C1 lateral mass screw. So here, because the vertebral artery was anomalous, it was coming in a view. So I wanted to put a cage. This is a cage actually, sorry. This somewhere is the C2 pedicle screw here. So this is a cage that I have put a spacer in between C1, C2 joint. So once, what I did was, once I opened the joints, I tried to drill out the things because sometimes what happens is for a chronic long-standing subluxation, there will be a calcification and joints will be fused. I could completely decompress the joint C1, C2 on both the sides. But because of the anterior fusion of the C1 odontoid, os odontoid with the C1 arch, I could not achieve an anterior posterior reduction. So with this cage, I could achieve a vertical reduction that I will show here. Yeah, that's the C2 arch. C1 arch I have completely taken out. Yeah, this is a post-op image. You can see this is a pre-op image that the lower border of C2 is with the C1 anterior arch here. And in this case, you can see that this is a C1 arch and this has come down to this level. So we have achieved significant vertical reduction, but because of this fused os odontoid, which was lying in between the C1 and the body, odontoid body, I could not achieve an anterior post reduction. So still this overhanging part was compressing the cord. So we just thought we'll just examine the patient post-operatively once of fluctuation and we'll plan for a surgery. So this is an axial image. The screws are perfect. It has pierced. Actually, I purposely put the bicortical screws for a good strength. Yeah, but still I was not happy with the vertebral body in the canal. So that was compressing the cord. So for that reason, we went ahead with, this is a post-op MRI after the first surgery. You can still see that the cord is completely pinched and our surgery has not served the purpose. So we went ahead anteriorly. We did an anterior odontorectomy. Using, once again, we use the navigation. And this is, once we opened the postopharyngeal wall, we confirmed our, once again, the points of what we registered and we confirmed the body and C1. and we drilled the whole odontoid from tip, even including the os, down to the base. I have preserved because C2, C3 joint was supposed to be preserved. So this is post-op after anterior odontectomy. This you can see the central, because I have to preserve both the joints, so I could not go on this side. Yeah, this is the anterior odontectomy what we have done and given a space for the cord to fall. So this is the spacer here, and this is a medial margin of the screws. Yeah, this is what we have done. That is anterior odontectomy. We're up to the canal, and this is a sagittal image. It is lateral sagittal. This is lateral sagittal. We're going to the midline, where we can see that the only this is the midline image. A small part of a body of the odontoid we have left, and the whole thing has been decompressed. So this gave a good amount of space, and the patient is remaining same as he was in pre-op. So because one side I have not put a cage, so I'll be using a hard collar for at least 3-4 months, so that I have put a cortical bones in the joints, so that over a period of time the joints will fuse, and after that we can remove the hard collar. So these are a few of the cases that we have done at our institute. We do a lot of vascular work, and there are a few aneurysm, AVM cases. So I will not be going much into the depth because it's already 6 o'clock. This is one of the large AVM what we did. These are the surface I just run across. Now this is other AVM with venous varix. Yeah, this was it. It is full hemisphere is AVM, and this is a post-op resection cavity. I will show you the post-op MRI images. These are the MRI images, MRI angio. So for this, this workshop has served very well, because before we think of approaching the skull base, we need to know the proper anatomy of it. And at the same time, we have to have a look at the videos wherein clinically we can apply the same thing. So just going through cadaver will not help us. We can read the books and we can see on the cadaver. At the same time, there are a lot of YouTube videos available. You can go through them videos so that your base will become very strong. And through cystonostomy, because all the aneurysms, they are in the cistern. So you have to dissect the cisterns, and that is how even the cystonostomy will help you. Yeah, thank you. Thank you very much. Thank you.
We'll give a big hand for Shiv Shankar. Give a big hand for him, please. Excellent. Yeah, so excellent work. I mean, I'm really happy that we've come to a locality where truly world-class work is being done. So at Kolhapur, I can see Professor Rohidas and you doing extremely well. And so we would hope to be in your
sure, sir, you're welcome.
Following in your league. We will try to do as good as work as you guys do. So I'm very proud that you guys are around, and these kind of workshops, when it is done, we would want both of you to come and teach this region. People should, the neurosurgeons should definitely benefit from this kind of excellent work.
Definitely.
Thank you very much.
Thank you. Thank you very much.
John, can you hear us?
John is slept off.
Okay. So this was the last lecture. So we'll kind of switch it off from this. And for the offline delegates, we'll meet at the front at 7 o'clock.
Vlad, are you there? Are you there, Vlad? Or
yes, I am.
Good.
But I hear
Vlad
you very
Ganesh.
badly. You have a bad microphone, right?
Yeah, I know. Vlad, for all of you, Vlad is an expert on suprascerebral infratentorial. He's one of the world's best exponents of suprascerebral infratentorial. he could probably do an anal watt with supracerebellar infratentorial. So he can do anything. He does petroclivals with that. Vlad was the erstwhile president of European Association, and we have real legends amongst us. And you see the kind of work that's going on here, Vlad. I'm really proud of.
I'm proud of you.
Well, I am proud that I am here. It's really truly world-class work going on with
Great.
Professor Rohidas, Shiv Shankar, all these guys. So I'm really happy that we can go ahead, and I'm sure that you guys, Yuha and rest of the guys should come down here sometime. You'll really enjoy this place. It's
For sure.
one of the most, even after being in Nepal, I can tell you that it's one of the most beautiful places that I've been to. So you and Eva, Fitri and Yuha, all of you, you should come down here, enjoy the place, enjoy the surgeries.
As soon as disease will allow. But definitely I shall be there.
Yes, yes. You're looking forward.
Me too.
Professor Vladimir. I
Keki
speak.
is here. Keki.
I'm Omar. Professor Vladimir. Can I speak?
Yeah, Omar is from Syria.
Yes.
Hi, Omar.
I always, on my idea, on my database, anatomy is better. No anatomy, no neurosurgeon. No physiology, no neurological surgeon. Physiological for examination and during surgery. This is my idea. Physiology. And anatomy for every surgeon and every neurological surgeon to make decide before the surgeon. Thank you very much for all. And Dr. all colleagues, professors.
For whatever I understood, thank you very much. Omar, thank you very much for all of you. This is the last lecture today. Now, I must thank my team, Nilesh, Trishant, and Nikunj, Nargiza, Manuel, this team to have held our end up and made it possible for a fantastic meeting. Thank you, and we'll see you tomorrow.
Bye.
Thank you.
Hey, type.
See you all at 7 at the fun. The dress code is
Okay.
Dr. John resting or tomorrow?
Yeah, I guess
going
the
to
same,
Fern
the
at
same,
6:30.
the same time.
Tomorrow?
Yeah,
Same
3.
time.
Tomorrow,
9 o'clock in India.
Patient is patient is need to kill me because I not examine any patient now.
Oh, okay.
Wanted to kill me. Okay, I finish now.
No, yeah, they're finished now. Let me. And Nisila, are you on the camera now?
Very because no electricity now. I'm in Syria, like India, like East people, not know the law of patient one-on-one. Not
Yeah. Okay.
He's very not obvious. I have lecture. No, you must examine me. You know that.
Okay, you coming tomorrow? You coming tomorrow? Okay, I see you tomorrow. Okay.
See you. Thank you very much for you, and very nice and excellent colleagues and professors. Thank you very much.